We also have on the dais our facility director, Dr. Nitesh Kumar sir. Thank you so much for coming and accepting your seat here. I would now like to invite Professor Dr. Ravi Gupta, Chairman Orthopedic Sports Injuries, Paras Panchkula, to please come and accept the seat on the dais. Now I would like to invite Dr. Rahul Khanna, Senior Consultant Orthopedics, Paras Health Udaipur, to please come and have a seat on the dais. And now I would like to invite Dr. Nirmal Kumar, Senior Consultant Orthopedics, Paras Ranchi, to please come and accept the seat on the dais. Would now request Dr. Vivek David sir, Consultant Orthopedic, Paras Ranchi, to please come and be seated on the dais. Now would request Dr. Avkash Kumar, Consultant Orthopedics Ranchi, to please be seated on the dais. And I would like to invite Dr. D.P. Sharma, Head Physiotherapy, Paras Health, to please come and be seated on the dais. And I would now like to request Dr. Kaushik Roy, Medical Superintendent, Paras Health Ranchi, to please come and be seated on the dais. A huge round of applause for all our esteemed dignitaries today. Thank you. Now, I would request Dr. Nitesh Kumar to felicitate our chief guest, Shri Ajay Nath Sardarji. Girls, please. दूसरा लेके आना डॉक्टर अजीत को भी बुलाना है वो कौन है Would now request Dr. Nitesh to felicitate Professor Dr. Ravi Gupta sir. Would now request Dr. Nitesh to felicitate Dr. Rahul Khanna. I would now request Dr. Nitesh to felicitate Dr. D.P. Sharma. I would also request Dr. Ajit Kumar, who is heading physiotherapy here, to please come and accept your seat on the dais. I would now request Dr. Kaushik Roy to felicitate Dr. Nirmal Kumar. Would now request Dr. Kaushik to please felicitate Dr. Vivek Kumar David. Would request Dr. Kaushik to please felicitate Dr. Avkash Kumar. I would request Dr. Kaushik to please felicitate Dr. Ajit Kumar. And now I would request Dr. Kaushik to please felicitate Dr. Nitesh Kumar. And I would request Dr. Nitesh to please felicitate Dr. Kaushik. Thank you so much, sir. Now moving forward, taking our program forward, I would request our chief guest, along with our dignitaries on stage, to please join us for the traditional lamp lighting ceremony. So, girls, please. Anita, get the candles. तुम थोड़ा साइड हो जाओ, इधर आ जाओ. और इधर आ जाओ. ए भैया जल्दी जल्दी करना है. कैंडल को सांस चढ़ेगा. नहीं नहीं. ना ना. सॉरी रुको मैं. देख के आस्ते. এটা ধরে থাকতে হবে. এটা ধরে থাকো সাইডে ওখানে. So as we light this flame, we symbolize the spread of knowledge and the illumination of new paths in the field of sports injury management. Thank you so much, respected dignitaries. Thank you. To officially open today's proceedings and offer a warm welcome to our distinguished guests, it's my distinct honor to invite our facility director, Dr. Nitesh Kumar. Sir, would request you to please come and welcome all our esteemed guests and dignitaries.
आदरणीय श्री अजयनाथ सहदेव जी, आपका बहुत बहुत धन्यवाद. हमारे रिक्वेस्ट पे आप इस ओकेजन को ग्रेस करने के लिए पहुंचे. बहुत बहुत धन्यवाद सर. प्रोफेसर डॉक्टर रवि गुप्ता, थैंक यू सो मच सर फॉर बीइंग हियर फ्रॉम पंचकुला. डॉक्टर राहुल खन्ना सर, थैंक यू सो मच फ्रॉम उदयपुर. डॉक्टर दीपी शर्मा, who is also our physiotherapy head for the entire group of Paras. And Dr. Nasir and Dr. Hasib Ghani, who will be joining us from Srinagar. We are on an online mode. And then definitely our doctors from Ranchi, Dr. David, Dr. Nirmal, Dr. Avkas. Thank you so much for being here. And it is our pleasure to welcome all the participants of this conclave. We have been thinking of this conclave for long. We thought there are conclaves which are happening which is organ specific, like cardiocon which is happening just down, you can see when you came up. So there is something which is where the departments integrate together, जहाँ पे 2-3 department मिल के काम करे, उससे जो result आता है, it is always better than when a single specialist work on it. और खास करके स्पोर्ट्स इंजरी एक ऐसा टॉपिक है, एक ऐसा सब्जेक्ट है जिसमें बहुत ज़्यादा चर्चा, बहुत ज़्यादा बात इस रांची झारखंड में नहीं हुई है। तो वी थॉट ऑफ कि ये एक कॉमन पब्लिक, कॉमन पीपल, बच्चे खेलते हैं, अलग अलग स्टेजेस में लोग काफी इंथुजियास्टिक हैं, खास करके झारखंड में क्रिकेट, हॉकी, फुटबॉल को लेके। तो इंजरीज होते हैं और अगर सही समय पे सही डायग्नोसिस, सही उपचार ना हो तो इट बिकम्स अ लॉन्ग टर्म डिसेबिलिटी फॉर देम। उनको लॉन्ग टर्म डिसेबिलिटी हो जाता है, जो कि समाज के लिए भी प्रॉब्लमेटिक है, इंडिविजुअली उस आदमी के लिए तो प्रॉब्लमेटिक है ही। तो इन दैट सेंस इट बिकम्स वेरी इंपॉर्टेंट एंड पर्टिनेंट टू डिस्कस इट आउट। स्पोर्ट्स इंजरी सिर्फ इलाज करने का तरीका नहीं डिस्कस करेंगे हम लोग आज, और ये भी डिस्कस करेंगे कि किस तरह की इंजरीज कब और क्यों होती है, कैसे उसको प्रिवेंट किया जा सकता है। अजयनाथ सहदेव जी एग्री करेंगे कि ज्यादातर इंजरीज टेक्निक सही नहीं होने से, सही तरीके से वार्म अप या आप अपने आप को उस लेवल तक रीच करने के बगैर आप अगर खेलते हैं या अटेम्प्ट करते हैं तो होती है। तो ये जो तरीका है, कैसे आप अपने आप को पहले उस स्तर तक लेके जाएं ताकि आप फिर वो स्पोर्ट्स खेलें तो आपको इंजरी ना हो, या कैसे सही तरीके से आप अपने स्पोर्ट्स को खेलें ताकि आपको इंजरी ना हो, ये भी बहुत इंपॉर्टेंट है। तो आज के डिस्कशन में मैं चाहूंगा हमारे जो पैनलिस्ट और स्पीकर्स हैं कि इस पे भी ध्यान दें कि स्पोर्ट्स इंजरी को कम कैसे किया जाए, स्पोर्ट्स इंजरी को मिनिमाइज कैसे किया जाए, स्पोर्ट्स खेलने के पहले किन चीजों का ध्यान रखना चाहिए। आप क्रिकेट ले लीजिए, आप हॉकी ले लीजिए, सब स्पोर्ट्स में पर्टिकुलर कुछ चीजें हैं जो कि उन जॉइंट्स पे, उन पार्ट्स ऑफ द बॉडी पे स्ट्रेस पड़ता है। तो कैसे अपने आप को ऐसे लेवल तक वार्म अप करें, अपने आप को ट्रेन करें ताकि स्पोर्ट्स इंजरी या इंजरीज कम से कम हो। और जब इंजरीज होती है तो उसका इलाज है, उसका सही तरीके से डायग्नोसिस करके उसका सही ट्रीटमेंट ही उसका उपचार है, और समय पे करने से लॉन्ग टर्म डिसेबिलिटी कुछ नहीं रहती है। मैं अपना ही एग्जांपल बताऊंगा। आई थिंक डॉक्टर डेविड के पास मैं गया था आज से 3 महीने पहले शोल्डर का पेन लेके, मतलब मेरे को दर्द हुआ था ड्यूरिंग माय एक्सरसाइज करते समय, कहीं पे पेन हुआ था। तो मैं 2-3 महीने से परेशान था, मुझे पता नहीं चल रहा था क्या है। मैं अलग अलग लोगों से पूछा, बीइंग इन मेडिकल फैटर्निटी आप बड़ा चीज ज्यादा सोचते हो, छोटा चीज कम सोचते हो पहले। तो किसी ने बोला फ्रोजन शोल्डर है, किसी ने बोला ये है, तो सब फिजियोथेरेपी करा लिया मैंने, सब कराया, दर्द जा ही नहीं रहा था, इनफैक्ट बढ़ गया था। तो फिर मैंने डॉक्टर डेविड ने बोला कि एक बार सीटी स्कैन करा लेते हैं। तो सीटी स्कैन कराने से पता चला कि आपके जो रोटेटर कफ्स है शोल्डर के, वहां पे टियर है। तो उसका इलाज क्या है, आपको इमोबिलाइज करके आपको जॉइंट्स पे रेस्ट देना है और वो अपने आप ठीक हो जाएगा। अब मैं एक्सरसाइज करके फ्रोजन शोल्डर का उसको और बढ़ा रहा था। तो सही डायग्नोसिस, सही इन्वेस्टिगेशन और सही जानकारी बहुत सारे आगे के इंजरीज को प्रिवेंट करती है। तो उसके बाद मैंने प्रॉपर रेस्ट लिया 2-3 महीने और अभी मेरा शोल्डर प्रॉपर ठीक है। तो अगर मैं उस समय फ्रोजन शोल्डर का फिजियोथेरेपी करता रहता या मैं उसको नेग्लेक्ट करता रहता तो ये क्रोनिकली पेन रहता मेरे शोल्डर में, जो कि आगे चल के मेरे को बॉदर करता। तो प्रॉपर इन्वेस्टिगेशन, प्रॉपर डायग्नोसिस बहुत जरूरी है, खास करके स्पोर्ट्स इंजरी के केसेस में। मैं थोड़ा सा आपको पारस के बारे में भी बता देना चाहता हूं कि बहुत सारे लोग अलग अलग जगह से आए हैं, ताकि आपको पारस ग्रुप ऑफ हॉस्पिटल्स जो हमारा है, तो ये एक कॉर्पोरेट हॉस्पिटल है जिसके 8 हॉस्पिटल्स हैं टोटल इंडिया में, जिसमें से एक रांची में भी है। हमारा हॉस्पिटल गुड़गांव में है, पंचकुला में है, उदयपुर में है, श्रीनगर में है, कानपुर में है, पटना में डेफिनेटली है, और एक दरभंगा में भी है। तो ये 8 हॉस्पिटल्स हैं हमारे, जो कि टोटल अभी इंडिया में, नॉर्थ इंडिया में स्पेसिफिकली हैं, और आगे भी हमारे 2 हॉस्पिटल्स आ रहे हैं। तो ऐसे करके वी आर ग्रोइंग मोस्टली इन द नॉर्थ इंडिया। हमारा जो ये हॉस्पिटल है रांची में, ये एक पब्लिक प्राइवेट पार्टनरशिप है एचईसी के साथ, और ये 300 बेड का हॉस्पिटल है। एंड वी हैव स्पेशलाइज्ड इन ऑल द सुपर स्पेशलिटी इंक्लूडिंग ऑन्कोलॉजी, वी स्टार्टेड रिसेंटली। तो जितने भी सब स्पेशलिटीज हैं हम उनको धीरे धीरे करके डेवलप कर रहे हैं। उसमें एक स्पोर्ट्स इंजरी भी है, जॉइंट रिप्लेसमेंट है, बाकी डिपार्टमेंट में भी हम चालू कर रहे हैं। सो आप सभी लोग का आज यहाँ पे आने के लिए बहुत बहुत धन्यवाद, और मैं चाहूंगा कि इस एकेडमिक एक्टिविटी का सब लोग फायदा उठाएं ज्यादा से ज्यादा, और क्वेश्चंस पूछें, बी इंटरेक्टिव। आई नो कि यहाँ पे बहुत सारे स्टूडेंट्स भी हैं जो फिजियोथेरेपी कर रहे हैं या कर चुके हैं, तो मैं चाहूंगा कि यू आस्क क्वेश्चंस, यू क्लैरिफाई योर डाउट, सो दैट कि जब आप प्रैक्टिकली फील्ड में या प्रैक्टिकली पेशेंट्स को देखते हैं तो यू हैव अ बेटर क्लैरिटी ऑन व्हाट यू आर गोइंग टू डू. So thank you so much again, and let's begin the fest today for the academic this one. Thank you so much.
Thank you, sir. Your insights perfectly frame the importance of the collaborative effort we are undertaking today. So, ladies and gentlemen, we are honored to have with us a personality who is at the helm of sports administration in our state. As the president of Jharkhand State Cricket Association, he knows better than anyone that an athlete's greatest ability is their availability. While we as clinicians work on the science of recovery, he and his team provide the platform where that recovery is put to test. His leadership has been instrumental in making Jharkhand a powerhouse on the national cricket map. I would now request Shri Ajay Nath Sahdev ji कि वो मंच पर आएं और दो शब्द आज के इस कॉन्क्लेव में शेयर करें हम सभी ऑडियंसेस के साथ. जोरदार तालियों के साथ स्वागत.
थैंक यू मैम, सबको जोहार. और सबसे पहले तो मैं डॉक्टर नितेश और उनकी पूरी टीम को धन्यवाद देना चाहूँगा कि दे इनवाइटेड मी हियर एज प्रेसिडेंट ऑफ JSCA. और सही है कि जब स्पोर्ट्स इंजरी की बात हो रही है तो क्रिकेट की बात भी आती है, और क्रिकेट की जो ऑथराइज बॉडी है उसके रूप में, उसके अध्यक्ष के रूप में मैं आपके बीच में मौजूद हूँ. और सब यहाँ पे मुझे लगता है स्पोर्ट्स मेडिसिन से जुड़े हुए लोग हैं, डॉक्टर्स हैं, फिजियोथेरेपिस्ट हैं. मैं इतना ही कहना चाहूँगा, आई वॉज डिस्कसिंग विथ, मैं अभी सर से डिस्कस कर रहा था. एक समय था कि जब मुझे याद है, मैं जब बोर्डिंग स्कूल में पढ़ता था, मैं वहाँ से जब रांची आया तो मुझे क्रिकेट का बहुत शौक था. तो आई ज्वाइन वन क्लब कमांडोज, जहाँ पे धोनी भी पहले खेलते थे. धोनी बाद में इनफैक्ट वो खेलना शुरू किया वहाँ पे. तो वहाँ चंचल दा वॉज अ कोच. तो मुझे फर्स्ट डे ही मुझे हैमस्ट्रिंग में इंजरी हो गई दौड़ने में. मैंने वार्म अप नहीं किया था और बॉल को लेने के लिए मैं दौड़ गया काफी तेजी से, तो मुझे हैमस्ट्रिंग पुल हो गया था. तो उस समय कोई फिजियोथेरेपिस्ट नहीं होते थे और इसकी बहुत चर्चा भी नहीं होती थी. आई एम टॉकिंग अबाउट 1989-90 की मैं बात कर रहा हूँ. तो लोग मुझे बोला कि चलो एक उस्ताद है, उस्ताद जो है उसको खींच के ठीक कर देगा. तो फाइनली वो मुझे उस्ताद के पास ले गया. ये अलग बात है कि उसने ठीक भी कर दिया था, बट दैट वाज वेरी रिस्की ऑल्सो. तो एक समय उस्ताद लोग इसको ठीक करते थे, बट ये आज अपने आप में एक साइंस है. और मैं देखता हूं कि क्रिकेटर्स भी हैं जो आज सब लोग स्पेशलाइज लोगों के पास जाते हैं. बट स्टिल व्हाट आई फील कि लोग अपनी इंजुरीज को आज भी छुपाना चाहते हैं. दिस इज व्हाट आई फील. एंड इंजुरीज आर अ नॉर्मल पार्ट ऑफ एनी स्पोर्ट्स पर्सन्स लाइफ. क्योंकि जब आप अपना 100% देते हैं, आप अपने पूरे एनर्जी को लगाते हैं, तो इंजुरी कभी ना कभी लाइफ में हो सकती है. एंड इसमें कोई शर्मिंदगी उठाने की भी बात भी नहीं है. इंजुरी ऐसी हो सकती है. पार्ट ये है कि उसको हम किस तरीके से ट्रीट कर रहे हैं, हम उसके प्रिवेंशन के लिए क्या कर रहे हैं. काफी बार मैंने देखा है कि लोग बेसिक गलतियां जो होती है, आप देखेंगे क्रिकेट में रनआउट काफी बार होता है. लोग गावस्कर काफी इसको क्रिटिसाइज करते हैं कि लोग ग्राउंड नहीं करते हैं क्रीज पे अपने बैट को. तो गावस्कर बहुत गाली देते हैं उसमें कमेंट्री कर रहे होते हैं, तो कि दिस इज बेसिक, लोगों ने कैसे गलती कर दी. तो आज भी बेसिक गलतियां लोग स्पोर्ट्स में करते हैं. लोग वार्म अप ही नहीं करते हैं, वार्म अप किए बगैर ही लोग ज्यादा एफर्ट लगा देते हैं. तो दिस इज वेरी एक नॉर्मल कॉज होता है जब इंजरी हो जाती है. मैं डॉक्टर साहब से अभी कह रहा था, मैं अभी हाल में के दिनों में मैं जिम में देख रहा था, जो जिम में ट्रेनर्स होते हैं, लोग जिम के ट्रेनर्स को मानते हैं कि भाई ये तो बिल्कुल वेट लॉस करा दिया इसको, मेरी फ्रेंड को इसने 10 किलो कम कराया है तो मेरा भी करा देगा. और उसकी बात को लोग बिल्कुल मानते हैं. मैंने देखा है पढ़े लिखे लोग, और वो जो आपका जिम ट्रेनर है, मे बी कि ही इज नॉट दैट एजुकेटेड, लेकिन उसने और वेट लेके वो जंपिंग करा रहा है. मैं सर से कह रहा था कि जंपिंग करना खुद ही नीज पे, जॉइंट्स पे आपको एक लोड पड़ता है, और वजन लेके अगर कोई कूद रहा है. तो मैंने उसको कहा, और विश्वास नहीं करेंगे, 2 दिन के बाद ही उस मैडम को एक सीरियस इंजरी हो गई. फॉर 3 months शी वाज इन बेड उसके बाद. तो ऐसे इंजरीज भी लोग करते रहते हैं, जो लोग वेट लॉस के चक्कर में हम लोग काफी बार कुछ ऐसा कर देते हैं जो नहीं करना चाहिए. तो मुझे लगता है जो बेसिक चीजें हैं हम लोगों को उस पर विशेष ध्यान देना चाहिए. सबसे जो बड़ी बात है, व्हाट आई फील, जिस पे ध्यान देना चाहिए, वो है प्रिवेंशन ऑफ इंजुरीज. क्योंकि मैंने देखा है कि जो प्लेयर्स हमारे भी जो स्टेट लेवल के प्लेयर्स आते हैं, वो पहले जिले में खेलते हैं. हर बच्चा जो है वो उतना एजुकेटेड नहीं होता है, या उसका बैकग्राउंड ऐसा नहीं होता है कि उसको बचपन से बताया गया है कि आपको न्यूट्रिशन क्या है, वो बेसिक उसके जो फूड के हैबिट्स रहे हैं उस पर वो आगे आया है। और जब वो हाई लेवल में क्रिकेट खेल रहा है या किसी स्पोर्ट्स में आ रहा है तो उसको इंजरी होने की चांसेस ज्यादा हो जाती है, और वो बच्चे हाइड भी करते हैं अपने इंजरीज को, जो अवेयर नहीं है। तो मोस्ट इंपॉर्टेंट इज जब ऐसे सेमिनार्स होते हैं तो स्पोर्ट्स इंजरीज के बारे में अवेयरनेस भी होता है। आज भी आप इस बात को माने कि हमारे राज्य में अच्छे स्पोर्ट्समैन हैं, टैलेंट बहुत है, लेकिन स्पोर्ट्स इंजरीज के बारे में अवेयरनेस आज भी कम है। हॉकी हो, फुटबॉल हो, क्रिकेट हो, एथलीट्स यहाँ पे काफी अच्छे हैं। ट्राइबल बच्चे यहाँ के काफी जेनेटिकली बहुत स्ट्रांग होते हैं, लेकिन उनके जो आप देखेंगे जो फूड हैबिट्स है, प्रोटीन रिच डाइट वो नहीं लेते हैं उतना। तो कहीं ना कहीं जैसे ही वो 18-19 साल की उम्र में जब उनको ग्राइंड किया जाता है तो उनको सीरियस इंजरीज हो जाती है, और जब उनको एक्सेल करना चाहिए तो 2-3 साल वो इंजरी के पीरियड में अपना वो गोल्डन पीरियड वो खो देते हैं। तो कहीं ना कहीं मुझे लगता है कि झारखंड के अंदर और देश में बाकी हिस्सों में भी हमें इसके प्रिवेंशन पे और काम करने की जरूरत है। और प्रिवेंशन कैसे होगा? अवेयरनेस से भी होगा, और इसके साथ साथ जो बडिंग टैलेंट्स हैं, जिनको यंगस्टर्स जो स्पोर्ट्स पर्सन हैं जो आगे अच्छा करेंगे, इनको भी जब जैसे स्पोर्ट्स अथॉरिटी ऑफ इंडिया को मैं देखता हूं, जब वहां जो बच्चे रह रहे हैं बोर्डिंग में, तो उनके जो खान पान की व्यवस्था होती है वो अच्छी होती है। लेकिन जिन बच्चों को नहीं चुना गया, स्पेशली क्रिकेट हॉकी में आप देखेंगे कि अचानक वो जब अच्छा करते हैं तो वो टीम में आ जाते हैं, लेकिन उनके पहले का जो बैकग्राउंड रहा है, जब खान पान ठीक नहीं रहा है, उसका काफी बुरा असर उनको आगे होता है। तो इसके लिए मुझे लगता है कि हम लोगों को ऐसे टैलेंट्स को आइडेंटिफाई करके उनको खान पान के बारे में भी हम लोग को और जागरूक करने की जरूरत है। इसके साथ साथ जो मैंने कहा कि कोई भी स्पोर्ट्स पर्सन जब अपना 100% देता है तो उसको इंजरी हो सकती है, लेकिन लोग अपनी छोटी इंजरीज को छुपाते हैं, और उसको जब आप ट्रीट नहीं करके आप खेलते रहते हैं तो वो फिर एक बड़ा रूप ले लेता है, एंड देन काफी लोगों का करियर भी खराब हो जाता है। और काफी ऐसे जो टैलेंट हैं जो देश के लिए देश का नाम रोशन कर सकते हैं, वो इंजरीज की वजह से पीछे हो जाते हैं। कपिल देव इज एग्जाम्पल, आप देखेंगे कि उन्होंने इंजरी फ्री होके खेला, तो कहीं ना कहीं उनका जो रिदम था, उनके बॉलिंग का एक्शन था, उस पर लोग कहते थे कि बिल्कुल स्मूथ था उनका। और काफी ऐसे प्लेयर्स आते हैं जो कि जिनका एक्शन ऐसा होता है या जिनके आप नेचुरली वो जर्क देते हैं तो वो इंजर्ड होते रहते हैं, उनको आप बहुत लंबे समय तक खेलते हुए नहीं देख पाते हैं। तो ये बिल्कुल एक नेचुरल ये बात होता है, रिदम की बात होती है, लेकिन उसको भी आप और जागरूक करके और ट्रेन करके ठीक कर सकते हैं। तो मुझे लगता है कि सेमिनार्स लाइक दिस, इस तरह के जो कॉन्क्लेव होते हैं, और मेरा जो मैं इस कॉन्क्लेव के माध्यम से प्रिवेंशन पे जोर देना चाहूंगा, क्योंकि इंजरी मैनेजमेंट तो एक बार इंजर कोई हो गया तो उसके मैनेजमेंट के लिए भी यहाँ झारखंड में और कुछ काम करने की जरूरत है। मैं अपने क्रिकेट एसोसिएशन में भी देखता हूं, एक समय था जबकि सभी टीम के अलग फिजियोज नहीं होते थे, बट आज हमारे टीम में रणजी टीम की अलग फिजियो है, आपको अंडर 19, अंडर 16, विमेन्स टीम, सो सारे टीम्स के अलग अलग फिजियोज हैं, एंड दे आर रियली वर्किंग हार्ड। तो इसमें ना केवल लोगों को एम्प्लॉयमेंट भी मिला है, बल्कि हमारे प्लेयर्स की सर इंजरी भी जो पहले होती थी वो काफी प्रिवेंशन में हम लोगों को काफी हेल्प मिला है, बिकॉज दे ऑलवेज स्टे विद द टीम। उनको वो एजुकेट भी करते हैं, उनको बताते भी हैं कि जब ऑफ सीजन में भी आप क्या करें, क्योंकि जनरली ऑफ सीजन में भी क्या है, बच्चे जब चले जाते हैं कि अरे अभी तो 2 महीने 3 महीने का ब्रेक है, बट उस समय भी अगर कोई प्रोफेशनल स्पोर्ट्स पर्सन है तो उस समय भी उसको क्या करना है, नहीं करना है, इसके लिए भी जो स्पोर्ट्स मेडिसिन के एक्सपर्ट्स होते हैं, जो फिजियोथेरेपिस्ट होते हैं, उनकी बड़ी भूमिका होती है। तो आने वाले दिन में अगर फ्यूचर में हमें स्पोर्ट्स में और एक्सेल करना है, हमें ओलंपिक्स में भी अगर नंबर 1 बनना है, तो हमें काफी लंबा सफर तय करना पड़ेगा, और उसमें स्पोर्ट्स मेडिसिन का की काफी बड़ी भूमिका रहेगी, फिजियोथेरेपिस्ट की बड़ी भूमिका रहेगी। कैसे उसको प्रिवेंट किया जाए, इंजरी हो गया तो उसको कैसे मैनेजमेंट किया जाए ताकि वो जल्द से जल्द फिर से फील्ड में आ जाए। तो इसके लिए मुझे लगता है आप जितने यहाँ पे यंगस्टर्स भी बैठे हैं, मेरी शुभकामना है कि ये अपने आप में एक बहुत ही बड़ा फील्ड है, बहुत ही वास्ट है, एंड इट इज पेइंग ऑल्सो, बिकॉज यंग जनरेशन है। आपको ये नहीं सोचना चाहिए कि कोई, मैं देखा है ना केवल क्रिकेट, बल्कि आप देखेंगे मैं हॉकी को भी काफी क्लोजली फॉलो करता हूं, तो हर जगह पे पैसे की कमी अब नहीं रही कोई। अगर आप किसी टीम से एसोसिएट हो जाते हैं तो मनी इज नॉट अ इशू, फेम इज नॉट अ इशू। फिजियोथेरेपिस्ट को भी मैं देखता हूं, उन लोगों से भी लोग सेल्फी लेने के लिए वहां पे आते हैं। तो कहीं ना कहीं मुझे लगता है ये फ्यूचर आप लोगों का बहुत ही ब्राइट है। मेरी बहुत बहुत शुभकामना है। और फिर से पारस हॉस्पिटल को, डॉक्टर नितेश कुमार जी को और उनके पूरे टीम को मेरी तरफ से बहुत बहुत बधाई है कि आपने इस इशू को चुना, इस पे एक्सपर्ट्स को बुलाया यहाँ पे, और मीडिया के माध्यम से लोग इस पे और जागरूकता फैलेगी, लोग इसको छुपाएंगे नहीं। जैसे मैंने कहा कि कभी भी वी शुड नॉट हाइड आवर इंजुरीज, और इसके अलावा जो बेसिक चीज होती है उसे हमें कभी नहीं भूलना चाहिए, उसको अवश्य उस चीजों का पालन करना चाहिए। थैंक यू सो मच सर फॉर इनवाइटिंग मी हियर। आप सबको बेस्ट ऑफ लक। थैंक यू सो मच। जय हिंद।
थैंक यू सो मच सर। आपके शब्द हमारे लिए बहुत ही प्रेरणादायक हैं, और आप आज यहाँ पे आए और इतना सब कुछ शेयर किया, उसके लिए बहुत बहुत धन्यवाद। मैं अनुरोध करूंगी डॉक्टर नितेश को कि वो आज के इस अवसर पर हमारे मुख्य अतिथि को मोमेंटो प्रेजेंट करें, और एज अ टोकन ऑफ अप्रिसिएशन विच ही कंट्रीब्यूटेड इन द कॉन्क्लेव। Ladies and gentlemen, we have reached a pivotal moment in today's program. Paras Health is proud to announce a new chapter in specialized care. It is time for the official inauguration and launch of our dedicated sports injury clinic. So I would now request our dignitaries to kindly do the honors of unveiling and ribbon cutting. So we have to go there. This clinic is more than just a facility. It is a promise of world-class rehabilitation and surgical excellence for the people of Jharkhand and beyond. Let's do the unveiling with a huge round of applause. So we are deeply grateful to our chief guest, Shri Ajay Nath Sahadev and all our dignitaries for such an auspicious start today. We now are ready to start our academic session. So now I would like to request our guest on stage to please take the seat in the front row so that we may clear the view for the upcoming session. Thank you so much. I would request the team to please remove the chairs from here and the tables. So with the formal inauguration complete, we move into the core of our conclave, the academic exchange. Over the next few hours, we will delve into the complexities of knee, shoulder, and hip, guided by the best minds in the country. So let the learning begin. हाँ सर, मैं बुलाऊंगी आपको. Our first speaker for today's conclave. Our speaker is a cornerstone of the orthopedic team here in Ranchi. He is not only a master of joint replacement, but also a specialist in arthroscopy and sports injury care. Having worked across some of India's most prestigious medical centers, he brings a level of clinical accuracy that is truly commendable. Whether it is a complex ligament reconstruction or a robotic-assisted joint surgery, his expertise ensures that his patients walk back to life with confidence. So with a huge round of applause, please welcome Dr. Vivek Kumar David, Senior Consultant Orthopedics, Paras Health, Ranchi, to present his talk.
A very good morning and Johar to everyone present here. आदरणीय चीफ गेस्ट महोदय, पारस की सारी मैनेजमेंट टीम, फिजियोथेरेपी एसोसिएशन और सारे सीनियर फिजियोथेरेपिस्ट और हमारे कलीग्स, मेरे तरफ से आप सबको इस पारस स्पोर्ट्स इंजरी कॉन्क्लेव में स्वागत है। तो हम शुरू करते हैं। So I will be basically presenting the clinician's opinion and orthopedic surgeon's view on lateral knee pain from common to not so common. So the learning objectives today will be to recall the anatomical structures, discuss various etiologies which lead to the pain, and learn about their management. And while on the journey, maybe we will learn a rare cause of an extra-articular lateral knee pain. So by definition, any pain which is localized to the lateral side or the outer aspect of the knee is called lateral knee pain. We see about 15 to 25% of patients presenting to us with this kind of an injury, commonly seen in runners, cyclists, and field sports athletes. So the pathophysiology, if we look at it, the spectrum involves mostly the overuse kind of injury, which leads to friction and inflammation. And over a period of time, it may become degenerative and cause a structural lesion. So what are the structures which are present on the outer side of the knee? The bony points, if we all remember, the lateral femoral condyle, lateral tibial plateau, the joint line, and the fibular head. The soft tissue structures which are present: iliotibial band, lateral collateral ligament, lateral meniscus, the biceps femoris and the popliteus tendons, the joint capsule, common peroneal nerve, and the retinaculum. So any one or more of these structures could be involved, contributing to the pain. So if we try to classify them, we can classify them into soft tissue kind of an injury, which is due to overuse. It can be a ligamentous injury, it can be an intra-articular or extra-articular pathology, or it can also be a referred pain from the hip or the spine. So for a workup, we obviously need a detailed history and a thorough clinical examination. We need radiographs, which are a basic diagnostic need for our practice, and MRI wherever there is indication. So first, the most common we see is iliotibial band syndrome, or it's also called as iliotibial band friction syndrome. So the iliotibial band is a structure which arises from the iliac crest. The TFL and the gluteus maximus muscle contribute to it proximally, travels along the lateral aspect of the knee, and finally it attaches to the Gerdy's tubercle on the lateral tibia. So epidemiology, if you discuss, most commonly seen in runners, incidences up to 12% are reported. Causes are repetitive friction of the distal band over the femoral condyle. Most likely happens at the 30-degree flexion mark. It leads to localized inflammation and edema, and is also associated with hip abductor weakness genu varum, overpronation of the foot or poor footwear. Clinical features, there is a sharp or burning pain over the lateral femoral condyle, and there is tenderness at the lateral epidendral condyle, which is approximately 3 centimeter proximal to the joint line. There might be some soft tissue swelling or capitis, and Ober's test is positive. Ober's test, if you basically ask the patient to lie on the side and abduct the hip and extend it and try to bring down the thigh, if the ITB band is tight, the thigh will remain high and it will not fall down on the bed. So that is a positive Ober's test, and it signifies there is a tight IT band. Imaging, if we do an MRI, it may show some edema deep to the ITB band, and there can be some thickening. Treatment is mostly conservative. Rest, NSAIDs, ITB stretching exercises, hip abductor strengthening, and gait correction are advocated. Sometimes injections are given in the clinics, which can include steroids or PRP, and surgery in some refractory cases. Surgical options are many, from percutaneous release to open release, lengthening, and arthroscopic releases. Then we come to a lateral collateral ligament injury. Lateral collateral ligament is a cord-like structure which is on the outer aspect of the knee. So it originates about 1.4 millimeters proximal to the lateral epicondyle and slightly posterior to it from the femur, and inserts on the fibular head. So it covers almost 38 to 40% of the fibular head. It is one of the primary stabilizers of varus stress in all degrees of knee flexion. Mechanism, injury happens due to varus stress. It can either be a direct blow or a very high energy trauma. Incidence is less than 2% of all knee injury cases in isolated cases, but it is usually seen alongside other structure injuries to up to 16% of the knee injury cases. If we try to grade it, grading is done on the scale of mild sprain, partial tear, or complete tear, which leads to an instability. More often, it is associated with a PLC injury, and PLC, or the posterolateral complex, includes the popliteus tendon, the popliteofibular ligament, and the arcuate ligament. The posterior third of the capsule, fibular ligament, biceps femoris, and lateral gastrocnemius muscle might also contribute to the PLC complex. So what do we see? If there is an LCL injury, there can be tenderness along the LCL and varus instability, sometimes a possible peroneal nerve symptom. So on varus test, we have to remember to do the varus test in 30 degrees of flexion and in extension both. A combined LCL and PLC injury will produce gapping at about 30 degrees of flexion and in extension. It only opens up in 30 degree, then it is just LCL. So the key differentiator is the extension test. If the instability remains when you extend the knee, then it is a strong indicator of combined LCL and PLC injury. There's also the dial test, which is diagnostic for a PLC injury. So whenever in doubt, we always go for an MRI, which is a gold standard for ligament integrity, and varus stress radiographs can be helpful in chronic cases. Management involves usually in lower grades, or if the patient presents to us with a grade 1 or 2 injury, bracing and physiotherapy is sufficient. Rest and ice should be given, but always remember, icing in LCL injury should not be given directly for more than 10 to 15 minutes, because cold injuries to the common peroneal nerve are very common. So the patient can be kept non-weight bearing to partial weight bearing with crutches for 1 week, followed by a knee ROM brace, and planned return to sports by about 8 weeks. If it is a grade 3 injury or there is a PLC involvement, surgical reconstruction is must. Either repair if the patient presents to us acutely, or a reconstruction using a hamstring graft or the graft of your choice should be done. The third cause which we commonly see is the lateral meniscus tear. Now, menisci are basically wedges of fibrocartilage. They are located between the tibial plateau and the femoral condyles, and they get injured in twisting injuries, especially when the knee is in flexion. It can also be degenerative when we see it in an elderly patient. So the lateral menisci is more commonly injured because it is loosely attached as compared to the medial meniscus. The lateral meniscus tear, it might produce symptoms such as lateral joint line pain. Effusion is rarely there, but the patient might have locking or a clicking sensation. Examination tests, McMurray's and Apley's grinding tests are positive in this situation, and to confirm, a MRI is done. An MRI might show the tear pattern, whether it's a horizontal tear, a radial tear, or a complex kind of a tear. MRI can also show a cyst which can be formed due to a lateral meniscal tear, which is a secondary injury to the tear. And if the cyst is too big, we have even seen it being palpable along the joint line. Management, again, it's mostly non-surgical if the patient is minimally symptomatic or if it is a degenerative kind of a tear. Arthroscopic surgery, arthroscopic repair or partial meniscectomy is done in tears which cause mechanical symptoms. Coming to the less common kind of injuries, now it's a biceps femoris tendinopathy. It is usually due to overuse, repetitive knee flexion, sprinting, or repetitive eccentric loading at the fibular head. Pain is usually present on the posterolateral aspect near the fibular head. And a very important differentiating factor, the pain will increase when the knee is flexed with resistance or against resistance. An MRI might show a tendon thickening and a peritendinous fluid. Treatment again, mostly rest, gradual loading of the knee, physiotherapy focusing on eccentric strengthening with focus on gradual return to sports. Popliteus tendinopathy is also seen. The popliteus muscle usually functions during the internal rotation of tibia. It unlocks the knee during flexion. So the mechanism of injury is downhill running, pivoting, or a hyperextension kind of an injury. Symptoms can be a posterolateral pain aggravated by downhill walking. On an examination, pain with resisted external rotation of the tibia, if done in a sitting position, can cause aggravated symptoms. MRI might show a thickened tendon with peritendinous fluid. Treatment is again mostly conservative, rest, NSAIDs, and physiotherapy. There are other causes such as bursitis, proximal tibiofibular joint disorders, or referred pain from the spine and really from the hip joint. And in certain cases, if the athlete is a bit older, we also see some lateral compartment arthritis, which is a degenerative condition. So now I would like to present a case which presented to us about a month back. He was a 39-year-old CRPF personnel. He had a vague lateral knee pain when he presented to us on his left knee, following a trip and a fall 5 days ago, which happened during trekking. So basically, when he had come, there was no limp, there was no visible swelling. The pain used to aggravate while squatting, and very peculiarly, he used to complain of increasing paresthesia along the lateral border of the leg. On detailed history, he also says that he had a similar fall about 9 months ago, and following that he had some mild instability with difficulty climbing downhill during his drills, and he was told by someone that he has a ligament injury for which he didn't receive any treatment. So on examination, ambulation was non-antalgic. There was a tenderness at the lateral aspect of the knee, especially at the fibular head. There was no varus or valgal instability. There was no knee effusion. Lashman was positive. Dial test was positive. So this was his X-ray which we took. So anyone would like to guess what it was? Any guesses? Is it a normal knee X-ray? Joint space is less on the medial side, yeah, that may be one. But it's hardly arthritic, I don't think there is arthritis there. Anything else? So we went ahead and we did a X-ray of the other side. So this is the normal knee, asymptomatically. So when we are evaluating the knee joint, the fibula position is also very important. So on a lateral knee X-ray, the fibula should, at least 1/3 of the fibula should overlie the tibia, the posterior tibial line. So if you see the other side, this is I hope it's visible. The left side knee X-ray, in our case, the fibula is more posterior than the normal knee X-ray. Okay, so there was something going on the proximal tibiofibular joint. So the diagnosis of an acute traumatic proximal proximal tibiofibular joint was made. So we went for an MRI just to confirm, and the MRI reported complete disruption of anterior and posterior fibers at the proximal tibiofibular joint articulation with a posterior medial dislocation of the fibula. There was also some LCL strain, and because of his previous injury, there was chronic ACL ligament injury. There was also the problem with the progressive paresthesia. So we went with a plan to surgically fix and explore the common peroneal nerve. So first, we did a diagnostic arthroscopy. The torn ACL was confirmed, and we did a reconstruction with a quadrupled hamstring graft. Then we went ahead and opened the proximal tibiofibular joint, and we fixed it with a knotless tightrope device. So the incision is given on the lateral aspect of the knee. We create a thick flap, and this is actual intra-op images. So if you see, there is a structure at the bottom which is yellow in color, that is the common peroneal nerve. So we isolated the common peroneal nerve, and the fibula head is somewhere here. On a C-arm image, when we used to push with our thumb, the fibula used to go back up, but it was very unstable and it used to come back. So basically the fibula head had dislocated posteriorly, and it was pressing on the common peroneal nerve. So we went ahead, and under C-arm guidance, we used a 1.6 mm guide wire, and we drilled through 4 cortices. The starting point was at the center of the fibula head in a posterior lateral to anteromedial direction. So taking care of the ACL tibial tunnel. And now in this scenario, we had already made a tunnel in the ACL for the passage of the graft. So we had to be careful, and we had to plan the trajectory in such a way that it should not coincide with the ACL tunnel. So this is an image from the internet which shows how the wire was drilled. And following that, we used a tightrope device, which is a suspensory device. And as we gradually tightened, we took C-arm guidance also, gradually tightening it and during that movement, the head was reduced. I think. Okay, so now you can see the Siam images on the extreme left. क्या हो गया? वीडियो तो आ गया था. ओके, हाँ थोड़ा पीछे जाएंगे. ये वाला क्यों नहीं आ रहा? वीडियो नहीं है इसमें. दिस इज प्लेन. It's a very important slide. Okay. Chalo. So one of the slide is somehow not visible, but anyway. So this is the final construct. This is a APCM image. It is showing the final position of the construct, and on varus stress, this is minimal to no opening on the lateral side. This is the final X-ray, and it shows the joint properly reduced. Now the post-op rehab, what we planned was partial weight bearing with knee brace for first 4 weeks with range of motion exercises up to 90 degrees. Weeks 5 to 6, 50% partial weight bearing, full range of motion as tolerated. And 6 to 12 weeks, weight bearing as tolerated, full range of motion. And week 12 onwards, jogging, running to gradual return of sports. So basically the patient had presented to us at 4 weeks. When he had presented, he had 0 to 90 degrees of painless motion, and he had complete resolution of his paresthesias. He is due for his 6 weeks visit. So what does the literature say about this? So the dislocation of a proximal tibiofibular joint is very, very uncommon. Counts for less than 1% of all knee injuries. It was first described by Nelleton in 1874, and a classic paper on this condition was given by Ogden in 1974, who classified it into 4 different types. Now type 1 is just a subluxation or an instability, which is more commonly seen. Anterolateral dislocation is the commonest, which is 85%. Posteromedial dislocation is 10%, which was our case. And type 4 superior is very, very rare. So a total of less than 150 cases have been reported worldwide for acute traumatic proximal tibiofibular joint. And with the incidence being 10% for a posteromedial makes our case less than 15 in the whole world. So injury to the common peroneal nerve is rarely seen, 5% of cases, more commonly seen in the posteromedial dislocation types. Closed versus open reduction procedures are performed, followed by immobilization. Usually the closed reduction works in an anterolateral kind of instability. In acute setting of joint instability after closed reduction, most commonly done surgeries are open reduction. Various fixation methods are used, Kirschner wires, pins, or screws. In chronic instability, however, physiotherapy is done, and in some cases, fusion of the joint or excision of fibular head has been reported with variable outcomes. So we chose a suspension device which has shown that during kinematic analysis, it can successfully repair the joint to its normal spatial motion. So take-home message from this talk is that there is a wide spectrum of disorders which can lead to a lateral knee pain. We have to keep a high index of suspicion for both intra-articular and extra-articular pathologies. Clinical examination is first and foremost, and when needed, it can be supplemented with imaging. And getting a specialist opinion at the earliest is better for a patient's outcome. So don't wait for the problem to become chronic. if possible, at least get a specialist opinion as early as possible. Thank you.
Any questions from our audience to our doctor?
एक स्लाइड नहीं चला एक स्लाइड नहीं चला वो बड़ा अच्छा था उसमें दिखता है वो कैसे जा रहा है
Very good morning, sir. I am Rajesh, lecturer in physiotherapy, CRC Ranchi. Sir, my question is related to your slide number 3, in which you told about referred pain from the spine. So, would you like to elaborate about that? In what conditions of the spine we can have a referred pain to the lateral knee pain?
See, spine, usually any disc pathologies, when there is a disc prolapse or a sequestration, sometimes it causes a radiculopathy, which travels along the lateral aspect of the leg. So most commonly, these are the conditions that we see.
Right.
So you should, when a patient presents to you with a vague kind of a pain, always try to ask them whether the pain is radiating, and if you, in that setting, if the local examination is negative, you have to always think that the pain might be referred.
Right.
If the knee is silent, so you may think that there is no problem at the knee, or it's rather something which is coming from up top.
Right. Sir, my next question is related to slide number 5, in which you have, in surgical management, you have told about percutaneous release of ITBP, iliotibial band.
Yes.
Sir, would you like to elaborate a bit, like percutaneous, like how do you decide we have to go in for percutaneous or no muscle involvement is there?
No, basically, those are different kind of a surgical techniques which has been described in literature.
Right, sir.
Okay. When it comes to us, we prefer doing a Z lengthening. Okay.
Sir, sir, in case, one more question, that is related to the case you discussed at the last part. Sir, if any fibular bone is absent, like due to any accident, the fibular bone was excised off, so are there any chances that person will return to sports?
See, it depends on the fibula has a lot of attachments.
Right.
Okay. So the whole posterolateral complex is attached to that area. Now, if there is a residual instability after the fibular excision, then the patient might have difficulty returning to sports. So it all depends on his clinical symptoms that he is presenting to you. Right. If there is just an excision and nothing has been done to prevent that instability, it might be difficult for the person to go back to sports.
Okay. Thank you, sir.
Thank you so much, sir, for that excellent opening today morning. I would now request...
Hello.
Sorry.
One more question, please. I am Bir Singh Purti, physiotherapist from Khuti. My question is, sometimes intentionally we push the joints. As you told that as tolerance means pain tolerance, we should, as a protocol, 4 weeks, 6 weeks, we have to reach 90 degree, 100 degree, so and so. Like if suppose the patient is having pain, so should we follow the protocol or accept his pain tolerance according to that?
See, again, it's very patient specific. The case that we discussed or any case that we do, we are talking about a patient who is post-surgery.
Yeah.
A post-surgery patient, usually we expect that the pain level should go down after the initial couple of days or maybe 2 or 3 weeks time. If the patient is still having a lot of pain while doing physio, then we have to evaluate the cause of his pain. Okay. So some patients, they are very, very cooperative with the physio. So usually they do well, but an uncooperative patient can also present with pain. So if the patient is still having a lot of pain, if you think that the patient's pain is out of proportion to the injury or out of proportion to the post-op time period that he has crossed, I would say it's advisable to send the patient back for a revisit to the operating surgeon. Let him evaluate the patient and then let him determine the further course of action with your cooperation and with your coordination. So I would say it's always we should not just keep on pushing the patient for continued rehab if the patient is very, very resistant to further improvement. So try to consult the operating surgeon one time.
Okay, thank you, Madam.
Any more questions from the audience? Please raise your hands. Okay, thank you so much for today's opening, sir. One moment. I would request Dr. A.K. Thakur, sir, Director, Internal Medicine, to please present a memento of gratitude to our speaker for his contribution in today's conclave. Moving on to the next topic of the day. Ladies and gentlemen, we now come to a moment of true inspiration. It is an honor to introduce a personality who is not just a surgeon but a beacon of excellence and a mentor to generations of orthopedicians. With an unparalleled career spanning over 35 years, he has been a pioneer in the field of joint replacement and arthroscopy. His name is synonymous with clinical precision and surgical mastery. Throughout the decades, he has remained at the forefront of medical evolution, bridging the gap between traditional wisdom and modern innovation. Ladies and gentlemen, with a huge round of applause, please welcome our speaker, Professor Dr. Ravi Gupta, Chairman, Orthopedic Sports Injuries and Joint Replacement, Paras Health, Panchkula. Sir, we are humbled to have you with us today. The stage is yours and we are anxious to hear from you. All yours.
छोड़ो हो गया देखो तो 2 मिनट इस सब जगह हो जाता है 1 मिनट नहीं ले रहा क्या होता है कुछ भी तो नहीं आ रहा एक पेन ड्राइव निकालो जल्दी ये डेटा लेकर सेकंड स्क्रीन ओनली करो आगे नहीं लैपटॉप कनेक्ट
Hi, good morning, everyone. I am Dr. Rahul from Udaipur, Paras. So meanwhile, they are engaging with this kind of presentation to be uploaded. Lots of physiotherapists here and will like to interact so that become more of an interactive session. The last case presented by Dr. David has said that the patient was having a kind of proximal tibiofibular dislocation, and there was a little bit of in the distal aspect of the leg, probably due to some kind of common peroneal nerve injury. Suppose I give you a situation that if this peroneal nerve injury would have been a severe one and patient would have presented with a foot drop to you, how you are going to manage that? Is there any role of any electroneurophysiology kind of thing? Is there any role of any kind of stimulation as far as nerve is concerned? Or would you go for any pharetic stimulations for your anterior or peroneal compartment? So please come up with the answers. Anyone here? Would anybody would like to go for any kind of galvanic stimulation?
So in any nerve injury, we have certain protocol to follow in physiotherapy department. First of all, we have to find out whether it is nerve condition. To know that, we have SD curve plotting in physiotherapy department. That suggests the nerve has congested fully or some fibers are still intact. Accordingly,
Suppose the integrity of nerve is intact here, sir. The surgeon has decompressed the nerve, but still the patient is having a common peroneal palsy with foot drop. How you are going to-
in case it is compression, then we can go for Faraday galvanic test. If it is responding with Faraday current, then okay, we have to proceed Faraday current. I mean, it is not responding with Faraday current. That means the nerve is not responding. So you have to directly stimulate the muscle itself. That is galvanic current.
So a very nice answer from sir. He used to say that first we'll see for the integrity of the nerve, and depending if the nerve is intact, we'll go for galvanic stimulation of the nerve, as well as if required, we'll go for the pharetic stimulation of the anterior and the peroneal compartment muscles. So this is how you proceed. You'll wait for initial 2 to 3 weeks for the inflammation to subside, and gradually you will take over from there. Thank you.
This is a perfect example of proving that good things take time, isn't it? So wait karna hai.
Thanks for the nice and kind words. So I'll be speaking about how the evolution of arthroscopy has taken place in India and how it has impacted. So in the rest of the world, the arthroscopy started becoming popular in 1960s. But in India, the first course was had in 1985. And then in 1988, the second one. And mostly people thought that it is of no use in orthopedics. That was till 1990s. And then that was the phase 1, and now we entered the phase 2 in 1990 onwards. What was the phase 2 in the rest of the world? The scope, that is the arthroscope, it started to be equated with sports. स्कोप को और स्पोर्ट्स को लोगों ने इक्वेट कर दिया कि ये इकट्ठे चलेंगे. हमने आई वॉज वर्किंग इन GMCH चंडीगढ़ 1996 में स्कोपी शुरू की. सो द इंस्टीट्यूशंस दे टुक ओवर द चैलेंज कि इसका कोई रोल नहीं है. हमारे साथ साथ बॉम्बे में डॉक्टर अनंत जोशी और दिल्ली में डॉक्टर बसीन. सो मेनली 3 of us we started in 90s. and then this sports person listened to him. Can you make the sound? The sound is not coming. This is an important video if you can listen.
और वहाँ पे मुझे इंजरी हो गई थी और डॉक्टर रवि गुप्ता और
स्लाइड शो करो.
हेलो, दिस इज अब्दुल रज़ाक और 97 पाकिस्तान क्रिकेट टीम का टूर था इंडिया का और वहाँ पे मुझे इंजरी हो गई थी और डॉक्टर रवि गुप्ता और लकीली मेरे लिए अच्छा दिन था कि डॉक्टर रवि गुप्ता ने मेरी ट्रीटमेंट की, ऑपरेशन किया और स्पोर्ट्स की इंजरी को वो समझते हैं और बड़ा ज़बरदस्त इन्होंने ऑपरेट किया और उसके बाद मैं फ़ौरन 2-3 दिन के बाद वो ठीक हो गया. और हमारे जो फिजियो थे उनका कहना था कि अभी ये 2 महीने के लिए भी रेस्ट करेंगे.
अभी यहाँ पे मोस्टली फिजियोज हैं, तो इसने बोला कि जो हमारे फिजियोज थे उन्होंने बोला कि ये 2 महीने के लिए रेस्ट करेंगे और अगर कोई इंटरनेशनल प्लेयर क्रिकेट का 2 महीने रेस्ट करे, व्हाट विल हैपन, यू नो, मैनी पीपल आर वेटिंग कि हम अंदर एंटर करें. सो द फर्स्ट मैसेज जो अजय नाथ जी ने भी दिया कि हमें उनको जल्दी लेके जाना है गेम में, उनका कैरियर खराब नहीं करना. जर्मन फिजियो थे इनके साथ, ये पाकिस्तान का ऑलराउंडर है अब्दुल रज़ाक. सो 97 में हमने इसकी हिप आर्थ्रोस्कोपी की, जबकि हिप आर्थ्रोस्कोपी बहुत कम लोग करते थे वर्ल्ड में तब भी. सो ही वॉज बैक. सो इफ यू लिसन टू द कंप्लीट वीडियो एंड यू नो हाउ ही हैज परफॉर्म्ड. मोस्टली ये सचिन तेंदुलकर को आउट करता था. तो बहुत मीडिया में आया ये, पाकिस्तान के भी, इंडिया में भी, कि जी कोई इंडियन डॉक्टर ने पाकिस्तान के प्लेयर को ठीक किया. आपको पता है इंडिया पाकिस्तान के रिलेशन कैसे रहते हैं. बीच बीच में ऐसी बातें भी उठी कि ये एंटी इंडिया हो गया काम. मेरे को एक बार किसी रेडियो जॉकी का फोन आया कि लाइव लेके कि आपने इंडिया को हरा दिया. तो मैंने उसको बोला कि जी हमारे लिए तो पेशेंट होता है, एज वी ऑल आर डॉक्टर्स एंड फिजियोथेरेपिस्ट सिटिंग हियर. तो उसके बाद ये पॉपुलर होनी शुरू हो गई आर्थ्रोस्कोपी, इंडिया में भी, पाकिस्तान में भी और other Asian countries में. Then we started publishing from the institutions. So we published lot of papers on arthroscopy, on ankle arthroscopy, on hip arthroscopy, and this is our own technique also. So when we published and when we treated the players, so ये data है हमारा 4 साल का elite players का. 1103 elite players नी लिगामेंट इंजरी के हमने ऑपरेट किए. ये डिफरेंट गेम्स हैं एंड रिटर्न टू स्पोर्ट्स टू द सेम लेवल वाज 80%. सो इन चीजों से आर्थ्रोस्कोपी को पॉपुलैरिटी मिली. सो दीज आर द टोटल नंबर ऑफ, आई हैव पब्लिश्ड 235 पेपर्स. सो उससे जो है देन इट केम द गोल्डन एरा फॉर आर्थ्रोस्कोपी. आज हम गोल्डन एरा में हैं. जो ऑर्थोपेडिक सर्जन बनता है उसको पूछो क्या करना चाहता है, मैं आर्थ्रोस्कोपी करना चाहता हूं या जॉइंट रिप्लेसमेंट करना चाहता हूं. 1990 में ये कहते थे कि इसका कोई फायदा ही नहीं है ऑर्थोपेडिक्स में. सो दिस इज द एवोल्यूशन ऑफ आर्थ्रोस्कोपी इन इंडिया. एंड नाउ आई विल गो टू सम ऑफ द केसेस विच वी हैव ट्रीटेड ऑफ डिफरेंट जॉइंट्स. ये 2008 में एक हिमाचल में लड़का था 19 साल का और he was doing hunting in the forests of हिमाचल प्रदेश. शिकार कर रहा था तो एक बुलेट का पैलेट उसके हिप में चला गया. आफ्टर द इंजरी वो कहता मैं 5 महीने सोया नहीं हूं और मैं बैठ भी नहीं सका आराम से, बिकॉज द पैलेट वॉज सो पेनफुल. दिस इज द एक्सरे, यू कैन सी पैलेट इज हाफ प्रोजेक्टिंग इनटू द हिप जॉइंट. सो इट वॉज सो पेनफुल. वो सोया नहीं 5 महीने से. ही वेंट टू डिफरेंट प्लेसेस. वेल टू डू फैमिली का था. सबने बोला कि हिप को खोल के हम निकालेंगे, बट एज ऑल ऑफ यू नो, एवास्कुलर नेक्रोसिस ऑफ द हिप, जब भी हिप को डिसलोकेट करते हैं, दैट इज ए कॉम्प्लिकेशन. वो सबने उसको बताई थी. somehow he came to us in 2008 January, and this is the hip arthroscopy picture. तब हमारे पास डेडिकेटेड इंस्ट्रूमेंट्स भी नहीं थे हिप के. नी आर्थ्रोस्कोपी वालों से हमने किया, एंड दिस पैलेट वाज रिमूव्ड, एंड दीज आर द पोर्टल्स. सो नो रिस्क ऑफ एवास्कुलर नेक्रोसिस, एंड ही इज द पेशेंट. सो दिस इज हाउ इट हैज इंपैक्टेड ऑर्थोपेडिक्स. ये हिप आर्थ्रोस्कोपी का केस है. पेशेंट हैज गॉट फुल फंक्शन आफ्टर द सर्जरी. नेक्स्ट डे मेरे को बोलता है कि मैं पहली बार ही सोया हूं 5 महीनों में. हमने ये वर्ल्ड लिटरेचर देखा. दिस वाज द ओनली केस इन द वर्ल्ड. सो वी पब्लिश्ड दिस केस, लेट आर्थ्रोस्कोपिक रिट्रीवल ऑफ बुलेट फ्रॉम द हिप जॉइंट. पहले फॉरेन बॉडी रिट्रीवल के थे, बुलेट का नहीं था. नाउ वी मूव टू द नेक्स्ट जॉइंट. सो दिस इज एन इंटरनेशनल बॉक्सर फ्रॉम आवर कंट्री. शायद वो बिहार या झारखंड का ही रहने वाला है ये, और ये उसका प्रोफाइल है. आप राइट साइड पे देखोगे कितने मेडल इसने जीते हुए हैं, सिल्वर, ब्रॉन्ज, गोल्ड. बट लास्ट 2 ईयर्स से ये खेल नहीं पा रहा था, बिकॉज बॉक्सिंग में जब ये पंच करते हैं, देयर इज इंपैक्ट ऑन द एल्बो जॉइंट. सो उसको एल्बो की डीजनरेशन हो गई, लूज बॉडीज हो गई, साइनोवाइटिस हो गया. दिस इज द लूज बॉडीज इन द एक्सरे, and in the arthroscopy picture you can see the loose bodies. That is the MRI, and these are the loose bodies we removed by arthroscopy. And he is the patient in the ward next day of arthroscopy. Uske parents बैठे हुए हैं. So this is the beauty of this procedure. अगर आप ओपन करते हो तो आप अगले दिन प्लस्टर दोगे उसको 3 हफ्ते का. So it is how it has impacted, and he is back in game, again playing for India. Now again this is a very interesting boy, football player. 14 महीने पहले इसके इंजरी हुई, and range of motion elbow पे थी 45 to 90 degree, and in the X-ray there was internal myositis, and we did ankle arthroscopy. This is immediately after the surgery in the recovery room. We start exercise in the recovery room because elbow is notorious कि ये दोबारा stiff हो जाएगी. No passive manipulation, only active. See, almost full. And this is the function now. He has full elbow motion, and he is back in the game. So this is the beauty of this procedure. So we published our elbow arthroscopies also in 2013, 23 cases. Because यहाँ पे डॉक्टर विवेक ने बड़ा अच्छा केस भी दिखाया, और हम और लोगों के पास भी बड़े अच्छे अच्छे केसेस हैं. मैं पब्लिकेशन पे इसलिए भी जोर दे रहा हूं कि हमें सबको पब्लिश करना चाहिए. आपका रेयर केस है, ताकि वर्ल्ड को पता चले कि इंडिया में भी काम होता है. और दिस इज अनदर वेरी इंटरेस्टिंग केस. शी इज ए टीचर who was having pain in the right ankle joint for the last 28 months. She took multiple treatments. आपको पता है ना कि हर तरह के इलाज, देसी के पास भी चले गए, मालिश भी हो गई, टीबी का भी इलाज कर लिया उसने. ये एक्सरे है, एक्सरे देखने में नॉर्मल लगता है. ये 2007-8 के पेशेंट हैं हमारे. तब एमआरआई इतना पॉपुलर नहीं होता था, और लोग ये सोचते थे कि महंगी इन्वेस्टिगेशन हम क्यों कराएं. हमारे टीचर्स ये बोलते थे. बट वी गॉट द एमआरआई डन. आप देखो कि टेलस में उसके देयर इज ए ऑस्टियोकॉन्ड्राइटिस. सो ये टीबी की दवाई से भी नहीं ठीक होगा, रूमेटॉइड आर्थराइटिस की दवाई से भी नहीं. इसके लिए तो आर्थ्रोस्कोपी चाहिए, या ओपन करोगे. सो वी डिड आर्थ्रोस्कोपी, एंड वी डिड डिब्राइडमेंट एंड द माइक्रो फ्रैक्चर्स, एंड वी आल्सो पब्लिश्ड दिस केस आल्सो इन BMJ case reports. So this is a beautiful procedure for all the joints. Now आप लोगों के पास हील पेन के बहुत पेशेंट्स आते होंगे फिजियोथेरेपिस्ट के पास. हैगलैंड हील सुना है आपने? हैगलैंड हील, पोस्टीरियर कैल्केनियस बोन थिकनिंग हो जाती है. So this boy is from UK. He came to India for this treatment. 2012 का patient है, और this is how we do in the prone position. These are the portals, and the results are excellent. So ankle arthroscopy way again we published many years back. I think 2008 we have published. Similarly, in wrist arthroscopy, we were the first in India to start the upper limb arthroscopy in the year 2003. Shoulder तो आजकल बहुत से लोग करते हैं. This is recurrent dislocation shoulder. So I am not going into the procedural details, क्योंकि हमारी ऑडियंस में बहुत सारे फिजियोथेरेपिस्ट हैं, तो प्रोसीजर पे मैं स्किप कर जाऊंगा. ये सारा प्रोसीजर है, how we do it. But we published a data of 103 athletes, all elite players, of recurrent shoulder dislocation. अब इसमें जो टाइटल है सर्जिकल डिले फॉर ट्रॉमेटिक रिकरेंट डिसलोकेशन लीड्स टू इंफीरियर फंक्शनल आउटकम. सो दिस इज माय मैसेज टू द फिजियोथेरेपिस्ट्स. जो लोग जनरल फिजियोथेरेपिस्ट होते हैं, अभी स्पोर्ट्स में नहीं उभरे होते, कई बारी वो रिकरेंट डिसलोकेशन को कंजर्वेटिव ट्रीटमेंट से ठीक करते रहते हैं और उसका ट्रीटमेंट डिले होता रहता है. तो मैसेज ये है कि जब हम डिले करते हैं तो वो उसकी जब हम सर्जरी करेंगे वो वाले रिजल्ट नहीं आएंगे अगर जल्दी करते तो. इफ देयर इज ए रिकरेंट डिसलोकेशन, देन द पेशेंट विल रिक्वायर ए रिपेयर, बैंड-कट रिपेयर एंड रैम्पलीसाइज रिपेयर. सो दिस इज द मैसेज. एंड नाउ वेयर नॉट टू डू आर्थ्रोस्कोपी. हमारे टीचर्स ने हमें सिखाया और हम अपने स्टूडेंट को सिखाते हैं कि अच्छा सर्जन वो है जिसको ये पता है कि सर्जरी कब नहीं करनी. करनी तो आजकल सबको ही आती है. सो दिस पेशेंट हु इज फादर ऑफ ए न्यूरोसर्जन इन दिल्ली, देयर इज ए रोटेटर कफ टियर इन एमआरआई. बट अगर आप ध्यान से देखोगे उस साइड पे ना, राइट साइड पे ऑस्टियोफाइट्स दिख रहे हैं. सो रोटेटर कफ टियर जब डिले हो जाता है, इट लीड्स टू रोटेटर कफ आर्थ्रोपैथी, जॉइंट डीजनरेशन हो जाती है. तो समवन डिड रोटेटर कफ रिपेयर इन दिस पेशेंट हु इज ऑलरेडी हैविंग रोटेटर कफ आर्थ्रोपैथी. तो वो पेन तो नहीं जाएगी, एंड इट फेल्ड मिजरेबली. देन ही केम टू अस एट दैट स्टेज एंड वी डिड रिवर्स शोल्डर रिप्लेसमेंट. So this is the patient next day of the surgery. So the message here is, क्योंकि कई बारी क्या होता है, हमारे फिजियोथेरेपिस्ट आर द फर्स्ट लिंक विद द पेशेंट. पेशेंट सीधा आपके पास आता है, आपने भेजा सर्जन के पास, सर्जन ने ट्रीटमेंट बताया, वो फिर आपसे पूछने आता है कि ये कराऊं कि ना कराऊं. तो इसलिए आपको भी पता होना जरूरी है कि कहां करना है कहां नहीं करना. So this is my message to you. Now this is a very interesting case of multi-ligament injury and interesting story also. He was from this area, 58 years old, ex-serviceman. ये वैष्णो देवी की यात्रा पे गए और जब वापसी में पठानकोट से आके जाना पड़ता है, तो इनका जो यूनिट था पुराना वो पठानकोट में था. तो इसने नाइट स्टे वहां पे किया और उन्होंने पार्टी की, ड्रिंक किया, और ड्रिंक के बाद एक्सीडेंट हो गया. नी पे इंजरी हुई, 8 महीने वो व्हीलचेयर पे रहा विद प्लास्टर, ब्रेस एंड फिजियोथेरेपी. ही कुड नॉट वॉक बिकॉज ही हैड ए नी डिसलोकेशन which was reduced, but it had a multi-ligament injury. Also he had a foot drop, common peroneal nerve injury. Luckily his artery was saved. In cases में कभी कभी artery भी चली जाती है. So he was on wheelchair. He came in 2021, and this is his MRI. तो ये सारी इंजरीज थी उसमें जो हमने रिपेयर की. ACL रिकंस्ट्रक्शन, PCL रिकंस्ट्रक्शन, LCL रिकंस्ट्रक्शन, PLC रिकंस्ट्रक्शन. डॉक्टर विवेक ने एक PLC का बात की थी, तो इसमें PLC रिकंस्ट्रक्शन, partial meniscectomy of both the meniscus and repair of the patellar ligament. His patellar ligament was also torn. and common peroneal nerve release was done. और जब कॉमन पेरोनियल नर्व जाती है नी में ना, तो हम पेशेंट को बताते हैं कि सर्जरी के बाद रिकवरी के चांसेस 20% है. Only 1 in 5 will recover with best surgery. This is the world literature. But God was kind on him. So this is the X-ray after the surgery. गरीब आदमी था, हमने सारे इसके मेटालिक इम्प्लांट्स यूज किए. We took help from some organizations also, and he came back to this area. ये उसने आके देखो उसकी dorsiflexion भी हो रही है, and he sent this video to me on WhatsApp. So this is the beauty. This is how it has impacted. अगर हमारा पुराना ऑर्थोपेडिक्स होता तो ये ब्रेस से ही सारी उम्र चलता. ठीक है, तो ये आर्थ्रोस्कोपी ने हमें ये दे दिया है. Now this is a very interesting case. Total knee replacement हुआ. One of the top industrialists of our country, I cannot take name, in Delhi, wife of one of the top industrialists, knee replacement के बाद pain, and she says pain is more than what she was having before the replacement. Because अगर आप इस पिक्चर में देखो, ये हमारी आर्थ्रोस्कोपी पिक्चर है. There is a meniscus remnant on the left side, and यहाँ पे हमने शेव ऑफ कर दिया उसको. सो आजकल बात करते हैं जी रोबोटिक सर्जरी है, ये सर्जरी है, वो सर्जरी है, बहुत अच्छी है सारी, लेकिन सर्जन का एक्सपीरियंस भी अच्छा होना चाहिए और उसमें जल्दबाजी नहीं होनी चाहिए. आजकल लोग कहते हैं कि मैं 20 मिनट में सर्जरी कर देता हूं. जो 20 मिनट में सर्जरी करते हैं वो ऐसी चीजें छोड़ते हैं फिर बीच में. सो यू शुड बी वेरी मेटिकुलस. पेशेंट आपके पास बड़े ट्रस्ट से आता है. एंड देन अनदर पेशेंट आफ्टर नी रिप्लेसमेंट, पेनफुल नी. दिस इज द MRI showing popliteus tendon impingement. ये अल्ट्रासाउंड में आपको दिख रहा है.
वो आना ही नहीं उन्होंने, तो फिर क्या करें?
So then we did the,
इनको तो हो ही रही है.
इसकी साउंड बंद कर दो, कर सकते.
मैंने बताया इधर
साउंड बंद कर सकते हो उधर से. सो popliteus tendon की टेनोटमी आर्थ्रोस्कोपिकली 5-10 मिनट का प्रोसीजर है. जितनी ये वीडियो है उतना ही प्रोसीजर है ये. एंड शी गॉट ट्रिमेंडस रिलीफ नेक्स्ट डे. शी वॉज नॉट एबल टू वॉक प्रॉपरली, इट वॉज सो पेनफुल. सो ये रेयर डिजीजेज हैं. लेटरल साइड पेन आफ्टर नी रिप्लेसमेंट ऐसे भी होता है. तो आर्थ्रोस्कोपी इज ए बून, आई वुड से. एंड नाउ दिस इज माय लास्ट केस टू यू. दिस 29 years old मेल इज सन ऑफ बांग्लादेश के हेल्थ सेक्रेटरी का बेटा है. इसका 2017 में इंडिया में ही ये सर्जरी हुई, बैनकाट और रैम्पलीसाज की, बट इट डिड नॉट वर्क. उसकी डिसलोकेशन भी होती रही और पेन बढ़ गई उसके सर्जरी के बाद. फिर हमने MRI किया तो ये सब कुछ था, लेकिन जो मेन प्रॉब्लम थी वो ग्लिनॉइड बोन लॉस था. आई थिंक फिजियोथेरेपिस्ट ये अप्रिशिएट करेंगे कि अगर बोन लॉस हो तो बैंकाट और रैम्पलीसाज अकेले काम नहीं कर सकते, बोन को रिकंस्ट्रक्ट करना पड़ेगा. सो दैट इज व्हाई इट हैज फेल्ड. तो अगर अच्छा फिजियोथेरेपिस्ट होगा, स्पोर्ट्स फिजियो होगा, MRI की रिपोर्ट पड़ेगा, वो भी पेशेंट को बता देगा कि डॉक्टर तुम्हारा बैंकाट कर रहा है, लेकिन एक बार उसको बोलो बोन लॉस भी असेस कर ले. सो हमने बोन लॉस असेस करवाया अपने रेडियोलॉजिस्ट से. इट वाज 22%. एंड देन वी डिड आर्थ्रोस्कोपिक बोन ब्लॉक प्रोसीजर. पहले हम ओपन करते थे, अब आर्थ्रोस्कोपिक करते हैं. एंड देन दिस इज द बोन लॉस. इसमें जो असेस हुआ है ये रेडियोलॉजिस्ट की पिक्चर है. And then, another problem, why it was painful. Can you see where A is written? उसका एंकर जो है वो बोन के अंदर है, मेटालिक एंकर पहली सर्जरी में यूज हुआ, और वो it should be buried in the cartilage. So that was impinging, और इसने कार्टिलेज भी इसकी सारी खराब कर दी है. उधर भी दिख रहा है, ये एंकर निकालने के बाद है, ये एंकर पहले अंदर पड़ा हुआ है. लेफ्ट साइड पे एंकर निकाल दिया हमने. And then we did the bone block. This is the bone block. This is arthroscopic picture on the left side. और फिर हमने उसके बाद सीटी स्कैन करके उसका असेस किया कि उसका जो है बोन लॉस ठीक हो गया है, एंड दैट इज द वीडियो ऑफ 3D आफ्टर द सर्जरी. So we should know whether we have done the right job or not. So we did the, because हमारे देश के लिए भी तो prestigious है, बांग्लादेश के हेल्थ सेक्रेटरी का बेटा. So he is doing well, although still he has pain. Last 2 videos.
Hello everyone. Sound. मैं संदीप कुंडू, इंटरनेशनल ताइक्वांडो प्लेयर. मैं 14 times नेशनल गोल्ड मेडलिस्ट, कॉमनवेल्थ गोल्ड मेडलिस्ट, साउथ एशियन गेम्स गोल्ड मेडलिस्ट. हेलो एवरीवन. मैं संदीप कुंडू, इंटरनेशनल ताइक्वांडो प्लेयर. मैं 14 times नेशनल गोल्ड मेडलिस्ट, कॉमनवेल्थ गोल्ड मेडलिस्ट, साउथ एशियन गेम्स गोल्ड मेडलिस्ट और एशियन गेम्स क्वार्टर फाइनलिस्ट हूँ. मुझे हरियाणा से भीम अवार्ड भी मिला है, जो कि हरियाणा का टॉप मोस्ट स्टेट स्पोर्ट्स अवार्ड है. 2012 में मेरा ACL टीयर हो गया था और मुझे लगा कि अब मेरा स्पोर्ट्स करियर खत्म हो गया है, मैं दोबारा कभी गेम नहीं कर पाऊंगा. लेकिन डॉक्टर रवि गुप्ता ने मेरी सर्जरी की और 2013 में मैंने फिर से नेशनल में गोल्ड लिया. तब से लेकर अब तक मैं कंटिन्यू नेशनल चैंपियन हूँ. डॉक्टर रवि गुप्ता मेरे लिए भगवान के समान है. उनके बिना दोबारा गेम कर पाना इम्पॉसिबल था. मैं भगवान.
अरे वीडियो चलाना उधर वाला.
स्वागत करते हैं 71वीं अखिल भारतीय पुलिस रेसलिंग क्लस्टर चैंपियनशिप में पहला नंबर प्राप्त किए हैं टीम पंजाब. 17 गोल्ड मेडल्स, 9 सिल्वर मेडल्स और 15 ब्रॉन्ज मेडल के साथ इस प्रतियोगिता में सभी का दिल जीता है. जोरदार तालियों के साथ स्वागत करते हैं टीम पंजाब. शौर्य, दृढ़ता, कर.
हेलो जी, मैं सूरजवीर सिंह, असिस्टेंट सब इंस्पैक्टर पंजाब पुलिस ਤੇ ਨਾਲ ਹੀ ਮੈਂ ਇੱਕ ਫ੍ਰੀ ਸਟਾਈਲ ਇੰਟਰਨੈਸ਼ਨਲ ਰੈਸਲਰ ਵੀ ਹਾਂ ਤੇ ਇੰਡੀਆ ਨੂੰ ਬਹੁਤ ਸਾਰੇ ਇਵੈਂਟ ਦੇ ਵਿੱਚ ਜਿਹੜਾ ਇੰਟਰਨੈਸ਼ਨਲ ਲੈਵਲ ਤੇ ਰਿਪਰੈਜ਼ੈਂਟ ਵੀ ਕਰ ਚੁੱਕਾ ਹਾਂ. ਤੇ ਰੈਸਲਿੰਗ ਦੇ ਦੌਰਾਨ ਹੀ ਅੱਜ ਤੋਂ ਕੁਝ ਸਾਲ ਪਹਿਲਾਂ ਮੇਰੇ ਨੀਂਹ ਦੇ ਉੱਤੇ ਕਾਫੀ ਮੇਜਰ ਇੰਜਰੀ ਹੋ ਗਈ ਤੇ ਉਸ ਇੰਜਰੀ ਤੋਂ ਬਾਅਦ ਮੇਰੇ ਲਾਈਫ ਦੇ ਵਿੱਚ ਇੱਕ ਬਹੁਤ ਵੱਡਾ ਟਰਨਿੰਗ ਪੁਆਇੰਟ ਆਇਆ. ਮੈਂ ਕਈ ਸਾਲ ਤੱਕ ਕੰਪੀਟੀਸ਼ਨ ਨਹੀਂ ਖੇਡ ਸਕਿਆ ਕੋਈ ਵੀ ਤੇ ਉਹਨਾਂ ਸਾਲਾਂ ਦੇ ਵਿੱਚ ਮੈਂ 2 ਸਰਜਰੀਜ਼ ਵੀ ਕਰਾਈਆਂ ਜਿਹੜੀਆਂ ਕਿ ਅਨਸਕਸੈਸਫੁਲ ਰਹੀਆਂ. ਤੇ ਇਸੇ ਦੌਰਾਨ ਫਿਰ ਮੈਂ ਡਾਕਟਰ ਰਵੀ ਗੁਪਤਾ ਜੀ ਦੇ ਬਾਰੇ ਸੁਣਿਆ ਤੇ ਉਹਨਾਂ ਨੂੰ ਚੰਡੀਗੜ੍ਹ ਦੇ ਵਿੱਚ ਮਿਲਿਆ ਤੇ ਬਹੁਤ ਵਧੀਆ ਇਨਸਾਨ ਲੱਗੇ, ਬਹੁਤ ਵਧੀਆ ਡਾਕਟਰ ਲੱਗੇ. ਉਹਨਾਂ ਨੇ ਮੈਨੂੰ ਕਾਫੀ ਜ਼ਿਆਦਾ ਮੋਟੀਵੇਟ ਕੀਤਾ, ਮੈਨੂੰ ਬਹੁਤ ਵਧੀਆ ਟਰੀਟ ਕੀਤਾ ਤੇ ਮੇਰੇ ਨੀਂਹ ਦੀ ਜਿਹੜੀ ਆ ਸਰਜਰੀ ਕੀਤੀ ਜਿਹੜੀ ਕਿ ਬਹੁਤ ਜ਼ਿਆਦਾ ਸਕਸੈਸਫੁਲ ਰਹੀ ਤੇ ਰਿਕਵਰੀ ਵੀ ਬਹੁਤ ਜ਼ਿਆਦਾ ਫਾਸਟ ਹੋਈ ਤੇ ਬੜੇ ਥੋੜੇ ਟਾਈਮ ਦੇ ਵਿੱਚ ਮੈਂ ਦੁਬਾਰਾ ਫਿਰ ਉਸੇ ਲੈਵਲ ਤੇ ਪਹੁੰਚ ਗਿਆ ਤੇ ਦੁਬਾਰਾ ਫਿਰ ਵਰਲਡ ਪੁਲਿਸ ਗੇਮ ਚੋਂ ਤੇ ਹੋਰ ਵੀ ਨੈਸ਼ਨਲ ਇੰਟਰਨੈਸ਼ਨਲ ਲੈਵਲ ਤੇ ਜਿਹੜੇ ਮੈਡਲ ਲੈ ਤੇ ਇਹ ਜੋ ਕੁਝ ਵੀ ਹੋਇਆ ਇਹ ਡਾਕਟਰ ਸਾਹਿਬ ਦੀ ਬਦੌਲਤ ਹੋਇਆ ਤੇ ਮੈਂ ਬਹੁਤ ਬਹੁਤ ਥੈਂਕ ਯੂ ਕਰਦਾ ਡਾਕਟਰ ਸਾਹਿਬ ਦਾ.
ਇਹ ਕਹਿੰਦਾ ਕਿ बहुत फास्ट रिकवरी हुई. आजकल जो हम लिगामेंट सर्जरी करते हैं, यहाँ पे भी जो लोग करते होंगे,
71वीं अखिल भारतीय पुलिस रेसलिंग
इसको स्टॉप कर.
चैंपियनशिप में पहला
उसमें हमारे पास टेक्नोलॉजी इतनी बढ़िया आ गई है, फिक्सेशन टेक्निक्स इतने बढ़िया आ गए हैं कि हम ब्रेस नहीं देते नी में सर्जरी के बाद, ना क्रचेस देते हैं ना वॉकर देते हैं. सो फास्ट रिकवरी के लिए अग्रेसिव रीहैब प्रोटोकॉल आप लोग भी देते होंगे. तो यूजुअली ACL लिगामेंट अलोन जो होता है वो हमारा 10-15 दिन में जिम चला जाता है फॉर मसल स्ट्रेंथनिंग, और हम 1 महीने में उसकी जॉगिंग शुरू करा देते हैं, 2-3 महीने में प्रैक्टिस गेम शुरू करा देते हैं, और 5 to 6 months में हमारे प्लेयर जो हैं दे गो बैक टू देयर फुल गेम. सो दिस इज व्हाट ही इज सेइंग कि हमारी फास्ट रिकवरी हुई. सो लास्टली मेरी रिक्वेस्ट कह लो, अपील कह लो टू माई कोलीग्स एंड टू फिजियोथेरेपिस्ट, हमें अपना काम जो है पब्लिश जरूर करना चाहिए. वी शुड बैलेंस. हम सब लोग बिजी हैं, टाइम कम है, बट बैलेंस करना है बिटवीन क्लिनिकल प्रैक्टिस एंड रिसर्च. रिसर्च बहुत इजी चीज है. हमेशा मैं अपने स्टूडेंट्स को बोलता हूं कि एक हाउसवाइफ भी रिसर्च करती है. वो खाना बनाती है, वो देखती है कि जब मैं नमक थोड़ा सा ज्यादा डालती हूं तो खाना ज्यादा टेस्टी हो जाता है, जब खटाई डालती हूं तो ज्यादा टेस्टी हो जाता है. दैट इज रिसर्च. तो हमें अपना डाटा देखते रहना है कि मैंने क्या किया, क्या रिजल्ट्स हैं, और मैंने जब ऐसे किया तो कैसे हो गए रिजल्ट्स? यही रिसर्च है, इसको पब्लिश करना है। सो थैंक यू वेरी मच। ये हमारे सारे पेशेंट्स हैं जो बिना ब्रेस के नेक्स्ट डे सर्जरी चलते हैं। ये इंटरनेशनल फुटबॉलर है, ये वाली वीडियो चलाना, और वो इंडिया का क्रिकेटर है, वो लेफ्ट साइड पे। दोनों की सर्जरी सेम डेज पे हुई। ये 6 मंथ्स पे है। थैंक यू वेरी मच।
Any questions from our audience?
Very good afternoon, sir. I am Rajesh from lecturer physiotherapy, CRC Ranchi. I just wanted your opinion regarding the role of arthroscopy in chronic frozen shoulder. Like the patient is not having DM, diabetes mellitus, neither he is having a trauma, but frozen shoulder has been there for a long time, and PT also he did, but it had a limited effect. So does arthroscopy will help in that? Would you like to say?
अभी मैंने एक आर्टिकल लिखा है पिछले हफ्ते, आप अगर लिखोगे गूगल पे डॉक्टर रवि गुप्ता एंड फ्रोजन शोल्डर एंड ट्रिब्यून, पूरा आर्टिकल आ जाएगा। उसमें यह है कि 90% पेशेंट्स को सर्जरी की जरूरत नहीं पड़ती, ओनली 10% होते हैं जो रिकैल्सिट्रेंट और रेजिस्टेंट होते हैं, वो पेनफुल रहते हैं इन स्पाइट ऑफ कंजर्वेटिव ट्रीटमेंट। उनमें हम आर्थ्रोस्कोपी के रिलीज करते हैं, रिजल्ट्स आर एक्सीलेंट।
Right, sir. Sir, I have one more question. This is regarding to recurrent shoulder dislocations. Sir, arthroscopic होने के बाद, suppose the patient is not having any trauma or whatsoever, are there any chances that recurrent will happen again? क्योंकि patient का डर रहता है, मैं ऐसे घुमाऊंगा निकल जाएगा, उठाऊंगा निकल जाएगा, ऐसे कुछ chances रहता है arthroscopy के बाद?
In the best centers of the world, arthroscopic repair of the recurrent dislocation के results 96% है, 100% नहीं है। I always tell my patients, आके मरीज आजकल कहते हैं जी गारंटी दोगे? मैं कहता हूं गारंटी कोई नहीं है। तुम रोड से आए हो, रास्ते में एक्सीडेंट हो सकता था, तुम्हें यहां पहुंचने की गारंटी नहीं थी।
Right.
So there is a 4% failure rate in those cases.
Right. Thank you, sir.
Thank you.
सर, हमारे लिए बहुत ही सौभाग्यपूर्ण मौका है कि हमें आज मौका मिला आपसे सब कुछ सुनने का। सब कुछ किताबों में मेंशन्ड है, बट विशेषज्ञ से सुनना अलग ही है, isn't it? Did you all enjoy the session? Everyone? Great. अब मैं अनुरोध करूंगी डॉक्टर नितेश कुमार सर को कि वो प्लीज आके हमारे स्पीकर को मोमेंटो भेंट करें और उन्हें सम्मान करें।
I am obliged to be amongst you.
Thank you, sir. Coming up is the next topic of discussion, for which please join me in welcoming the next speaker. It is my pleasure to introduce a surgeon whose expertise spans the entire spectrum of orthopedic care. He is not just an expert in treating athletes, but a specialist in managing complex musculoskeletal challenges across all age groups. With more than a decade and a half of experience, he has been instrumental in restoring quality of life for thousands of patients through advanced joint replacement and trauma surgery. So with a huge round of applause, please welcome our next speaker, Dr. Nirmal Kumar, Senior Consultant Orthopedics, Paras Health, Ranchi.
छोड़ो छोड़ो छोड़ो। सब में ऐसा क्यों है? चलो हो गया, छोड़ो छोड़ो।
Let me thank our facility director for taking such a great initiative. And on that note, I would like to mention that probably most of us have interacted earlier also on a different platform. So, हो सकता है कि हम कुछ चीज़ों को repeat करें. But for those who probably we are interacting with whom for the first time, I would like to introduce myself. I am Dr. Nirmal Kumar, Senior Consultant Orthopedics, currently working with Paras HCC Hospital, Ranchi. और मैं I started like most of us do as a trauma surgeon, and I had keen interest in arthroplasty. And Scopy was my probably, I would say, a romance with Scopy started quite late. But once I started, I will say that I keep falling again and again in love with this branch of orthopedics. So it's such a sub-specialty जिसमें आपको इतने ज़्यादा varieties हैं और इतना ज़्यादा I would say आर्थ्रोस्कोपी में scope बहुत है. आप trauma में use कर सकते हैं, स्कोपी तो है ही. तो जैसे कि we all know कि ACL, PCL ये बहुत common है, हमें सबको पता है ligaments में LCL, MCL. But meniscus probably कहीं ना कहीं वो थोड़ा backdrop में चला जाता है. So it has been an underdog, but over the next 20 to 30 minutes, I will try to convince you all कि meniscus सबसे important क्यों है. और अगर meniscus ढंग से जहाँ ज़रूरत हो repair नहीं करते हैं, तो even the rest of the great work gets spoiled. So probably we all love to hear stories. So I'll just go back to the history, and probably the first mention of meniscus per se comes in the Greek poet named Sappho, and that dates back to probably 630 to 570 before BC. So there we find the first mention in literature, or probably by mouth to mouth spread, I would say. There it was named as a grieving fisherman, and the name was meniscus. So probably the meniscus story goes back much before what we think actually it to be. And then meniscus per se word was derived from a Greek word which even I can't make out, but that's a Greek word, and that means crescent-shaped or moon-shaped body. So as we all know that both the menisci, lateral and meniscus, दोनों ही crescent-shaped होते हैं, और उनका सामने और पीछे वाला पार्ट वो फिक्स्ड होता है जिसे हम रूट बोलते हैं, एंटीरियर और पोस्टीरियर रूट. रेस्ट ऑफ द पार्ट को हम बॉडी बोलते हैं. सो द फर्स्ट डॉक्यूमेंटेड, अगर हम मेंशन बात करें लिटरेचर में, साइंटिफिक लिटरेचर में, देन प्रोबेबली दैट डेट बैक्स टू अराउंड 400 BC, जब हिपोक्रेट्स ने, हालांकि उन्होंने द वर्ड विच ही यूज was cartilage, but his likely reference was to meniscus. तो meniscus एक लंबी जर्नी तय करके और बहुत लंबे समय के उपेक्षा के बाद probably again limelight में आया है. So probably Vesalius was a person who referred to meniscus again in his work, and then because of different religious reasons and sanction on cadaveric dissection, एक हम डार्क एज में चले गए, एंड सो मेनिस्कस वाज समथिंग व्हिच वाज लेफ्ट टू काइंड ऑफ वाज नेग्लेक्टेड, और इस पे काफी कुछ काम हुआ नहीं. सो आई जस्ट ट्राई टू ड्रॉ एन एनालॉग कि हम सभी बिहार झारखंड, लाइक वी ऑल वर्क हियर, वी मोस्ट ऑफ अस आर रूटेड हियर. सो सत्तू एक जो है उसको हम लोग काफी नीचे निंदा की भाव से देखते रहते थे, and we used to consider it as a poor man's protein shake. तो आपको बिहार में, झारखंड में भी बहुत से जगह पे आपको सत्तू मिल जाएगा. सत्तू इज लाइक इजिली अवेलेबल. फिर हमने बहुत देर से समझा कि इट्स वन ऑफ द बेस्ट प्रोटीन शेक एक्चुअली. तो हम बोलते हैं प्रोटीन लो, प्रोटीन लो. तो प्रोबेबली वी रियलाइज इट्स इंपॉर्टेंस सो लेट, एंड प्रोबेबली द क्रेडिट गोज समवेयर to our honorable Prime Minister, sir, when he popularized this photograph and this interaction at Bihari Vyanjan Litti Chokha at a stall, and that got, that introduced literally Sattu to the whole world. So हम सभी लिट्टी चोखा खाते हैं, I mean we are so fond of that, but सत्तू किस जमाने से यूज हो रहा है, but यही होता है कि probably कुछ चीजें हम लोग उसको इंपॉर्टेंस तभी समझते हैं जब वो लाइमलाइट में आता है. सो इट हैज बीन एन अंडरडॉग इवन टुडे, एंड प्रोबब्ली आज अगर हम ये समझे कि मेनिस्कस शुड बी द एट द कॉर्नर स्टोन ऑफ डिसाइडिंग कि किस पेशेंट में हमें सर्जिकल इंटरवीन करना है या नहीं करना, तो प्रोबब्ली आज का पूरा डिस्कशन और ये मीटिंग हमारा फ्रूटफुल होगा. सो meniscus, I would say, is no more an underdog, it's a superhero now. So the philosophy what I'm trying to propagate today is we salvage what we can, what truly matters to us, even at the gates of despair. So meniscus, many times we just rule out कि छोटा सा तो है, कुछ नहीं करेगा. Many times it's बड़ा ही तो है, थोड़ा दर्द होगा, कुछ दिन बाद सेटल कर जाएगा. तो as I was saying, we all should understand the scientific logic behind whatever call we take, whether it's conservative or operative, and then only that should be like a decision finally taken in interest of the patient, and it should not be कि मैं तो ऐसा ही करता हूँ और finally मेरे हिसाब से patient को आज तक ठीक ही हुआ है. So we have to have a scientific temperament if we want to really embark upon a proper and adequate treatment when dealing with any sports injury, and the cornerstone has to be the meniscus. ये स्लाइड probably आर्थ्रोस्कोपी की कोई भी कॉन्फ्रेंस आज तक मैंने नहीं देखी जिसमें ये स्लाइड आता नहीं हो, because this was probably one of the I would say the most historic moment जब vascularity को लेके मेनिस्कस के बारे में जो भी मिथ्स थे या फैक्ट्स थे उसको दे वर सेट ऑन रिकॉर्ड. एंड इसमें एज यू कैन सी दैट्स द पेरिफेरल पार्ट, एंड एज वी गो इट्स टेपर्स दैट्स द टुवर्ड्स द जॉइंट. तो ये वास्कुलैरिटी मेनिस्कस की यहाँ तक ही होती है. सो जब भी हम डिसाइड करते हैं कि कौन सा मेनिस्कस अपने आप हील करेगा और कौन सा नहीं करेगा, तो ये भी काफी इंपॉर्टेंट है कि मेनिस्कस आफ्टर ऑल इंज्योर कहाँ से हुआ है. तो जितना अंदर की तरफ रहेगा वो उसकी हीलिंग कैपेसिटी कम होगी, और जितना ही बाहर यानी पेरिफेरी की तरफ होगा उसकी वैस्कुलरिटी अच्छी होगी, इसलिए उसके या तो नेचुरल हीलिंग या आफ्टर इंटरवेंशन अच्छा होगा. सो मेनिस्कस का स्ट्रेंथ डिफरेंट रीजन से वैरी करता है, दोनों मेनिस्कस एक जैसे हमारे नहीं है, बट ओवरऑल इफ यू सी देन ये एक तरह का नहीं है. सो डिफरेंट लेयर ऑफ मेनिस्कस विल हैव डिफरेंट आर्किटेक्चर एंड दैट इज द रीजन दैट बेस्ड ऑन द मैकेनिज्म ऑफ इंजरी मेनिस्कस अलग अलग तरीके से इंजर होता है. So if you look at the how basically meniscus is important or how exactly it functions, it has got a hoop stress effect. तो जब भी आप वजन देते हैं और वेट बेयर करते हैं तो जो प्रेशर आता है that gets propagated peripherally from inside to outside और that's the reason ये पूरा आपका शॉक एब्जर्वर का काम करता है. और जब भी मेनिस्कस इंजरी सिग्निफिकेंट होगी तो ये मेनिस्कस नॉन फंक्शनल हो जाएगा. और उसकी वजह से मैं बाकी स्लाइड्स में दिखाऊंगा कि अगर ये मीडियल मेनिस्कस की बात करें तो ये 50% ऑफ द बॉडी वेट मीडियल हाफ में इसके थ्रू ट्रांसमिट होता है और लैटरल मेनिस्कस 70%. सो ये एक वेट शेयरिंग या वेट लेने वाला स्ट्रक्चर है. सो अगर बायोमैकेनिकल फंक्शन की बात करें तो लोड ट्रांसमिशन हमें सबको पता है, स्टेबिलिटी में भी इसका रोल है. सो इफ यू लीव meniscus unaddressed और सिर्फ आप ACL करते हैं, still you will see that patient is not happy because meniscus was not addressed adequately. Now of course lubrication and nutrition we all understand. Proprioception, इसलिए जब meniscal injury होती है तो proprioception भी disturb होता है, इसलिए patient को पता नहीं होता कई बार कि उसका knee exactly किस position में. इसलिए meniscal post meniscal injury अगर आप उसको प्रॉपरली रिहैब नहीं करेंगे सो देयर इज अ वेरी हाई चांस कि पेशेंट नेक्स्ट टाइम ACL या PCL टीयर लेके आएगा. एंड ऑफ कोर्स वी ऑल नो दैट एक्ट्स एज अ शॉक एब्जॉर्बर. सो जब भी कॉम्प्रोमाइज होगा मेनिस्कस तो पूरा का पूरा जो लोड है वो कार्टिलेज पे आएगा एंड दैट लीड्स टू अर्ली आर्थराइटिस. सो होल लॉजिक और आई वुड से द होल रीजन for stressing so much on meniscus is to avoid any early onset of arthritis post meniscal or any sports injury in the knee. So that, as I was saying, that's just to demonstrate the hoop stress or the way the force gets transmitted peripherally, radially, when we bear weight on knee. So there are lots of literature now which has proven that एक बार जब किसी भी कारण से मेनिस्कस मेरा नॉन फंक्शनल होगा, जैसे हमने उसको अनट्रीटेड छोड़ दिया, वो डिजनरेट कर जाए, या हम उसे पार्शियली हटा दें, जैसे हम पार्शियल मेनिस्केक्टमी कहते हैं, या फिर अर्लियर वी यूज्ड टू बी वेरी ब्रूटल. एंड जैसे मैंने बोला हिस्टोरिकली देयर वाज अ मिसकंसेप्ट दैट्स अ वेस्टिजियल ऑर्गन. सो प्रोबेबली वी डिडंट रियलाइज कि जैसे वो ऐड हम देखते हैं राकेश सत्तू का है, सॉरी सत्तू हमने आपको पहचाना नहीं, तो probably we need to be really apologetic and we need to apologize to meniscus that we realize its importance so late. So इतना ज़्यादा ये pressure transmit होता है and that leads to the degeneration. So point is that every meniscal injury, howsoever small or trivial it might appear, we need to consider it very seriously, and the decision has to be scientific or rational, and it should not be based on our myth, our whims and wishes कि भाई हम तो ऐसे ही करते हैं इसलिए ऐसा रहेगा. The amount of removed meniscus is the most important predictor for the development of knee OA. So probably these are all like different reviews which we go again and again visiting to see if we doing too much of meniscal repair. तो बार बार यही कंक्लूजन आता है कि मेनिस्केक्टमी जो है वो एक इंडिपेंडेंट रिस्क फैक्टर है, इसलिए मेनिस्कस की रिपेयर प्रोबेबली हम कहीं ना कहीं कम कर रहे हैं या उसकी मिसमैनेजमेंट है आज के डेट में भी 2026 में भी, और इसलिए वी नीड टू अंडरस्टैंड दैट. सो ये ग्राफ भी एंड ये स्टडी प्रोबेबली फ्रॉम सेम पेपर आई हैव टेकन दैट percentage of meniscal removed as it increases, there also increases the joint contact stress. सो ट्रॉमेटिक टीयर्स की हम अगर बात करें, सबसे कॉमन है जो यूजुअली हम देखते हैं, और ये यंग एथलीट्स में होता है जो काफ़ी एक्टिव इंडिविजुअल्स हो सकते हैं, और ये यूजुअली आइसोलेटेड नहीं होता है, यूजुअली दैट कम्स विद ACL. बट व्हाट हैपेंस इज इवन you will see that MRI जिस तरीके से reported होता है, they will say there is some like enhancing lesion or something like that. So probably we consider कि वो tear है नहीं है. So what we are doing nowadays, we are not totally kind of relying blindly on the MRI reports. We try to make out from the films reports ourselves. That's a great practice, and I think हम सबको कुछ तो basics पता होना ही चाहिए, so that if the need be हम हर केस को individually और case based discussion पे जाएं, वापस से re-reporting कराएं till we are really satisfied that there is either a meniscal or no injury, and if at all there is, तो किस type से है और कैसे उसको फिर हम लोग tackle करें. So the point is, कोई भी repairable जो meniscus है वो बचना नहीं चाहिए, because अगर आप बाकी चीजों को कर देंगे, then the patient would never be satisfied because early arthritis आएगा. एक और group जो which we generally come across, and that brings us to a very diagnostic dilemma, at the same time dilemma in management. They are in mid, I would say, they're not so aged and neither they are so young. The middle-aged people जो थोड़े बहुत degenerative changes पहले से हो सकते हैं, about trivial twisting injury के बाद उनमें injuries आते हैं. So they consider it otherwise like it's a minor sprain. तो ये काफी लेट से आते हैं हमारे पास, मे बी आपके पास भी, और sometimes we ourselves think कि let's see first कैसा रहता है. So what point I want to actually make is we need to have a very thorough evaluation, जिसमें diagnosis के लिए हमारा clinical examination no doubt is very important. At the same time, if the need be, we should not hesitate in going in for the next investigation of choice, which is usually MRI. So interpretation of MRI is equally important. And then I'm unable to repair or not, that again is not so straightforward, but the point of whole talk is to pick up those who will really benefit from early intervention. So जैसे मैंने कहा कि meniscus ऐसा नहीं है कि you should not mistake me for like कि I am propagating that all meniscal injuries need to be actually repaired arthroscopically. It's not like that. But then the decision has to be rational and decision has to be taken in a way that is supported well by literature, जैसे सर ने कहा. So that is the importance of going and keeping ourselves updated on literature side also. So what are the cases which would be ideal for observation, not going in for straight away for surgery? Those are probably quite small in size. Maybe we can say 1 centimeter से कम में length हो, stable हो, और कोई mechanical symptoms नहीं हो. और जैसे मैंने दिखाया कि वहाँ पहले स्लाइड में जो पेरिफेरल है, तो उनकी हीलिंग की कैपेसिटी अपने आप ज़्यादा अच्छी है क्योंकि उसमें आपका ब्लड सप्लाई अच्छा है. सो आगे मैं दिखाऊंगा व्हाट वी कॉल एज, जो हम डिस्कस करते हैं या नोट्स में आप देखेंगे, तो ये बहुत ज़रूरी है कि जब भी आप रिहैब शुरू करें तो यू शुड हैव द फुल आइडिया कि हुआ क्या था. सो यू शुड स्टार्ट फ्रॉम द नोट्स विच वाज प्रोबेबली टेकन इन द ओपीडी और मे बी लेटर ऑन ड्यूरिंग द डिस्चार्ज, और एग्जैक्ट सर्जिकल नोट्स भी बहुत इंपॉर्टेंट है. एंड प्रॉब्ली हम भी कई बार हड़बड़ी में छोड़ते हैं, बट देन वी नीड टू रियली डॉक्यूमेंट इवन फॉर मेडिकल लीगल पर्पस कि वो टीयर किस टाइप का था. सो व्हाट वाज द जोन, वेदर इट वाज रेड जिसे हम सबसे वास्कुलर पार्ट समझेंगे, या वेदर इट वाज इन द मिडल, दैट इज रेड वाइट. सो रेड वाइट जोन एंड रेडेड जोन जो हमारे हैं वही एक्चुअली हम रिपेयर के लिए जाते हैं. सो द वन विच इज वाइट वाइट, दैट्स द सबसे इनर जो होता है, उसको हम सेक्रीफाइस करते हैं मेनी टाइम्स इन केस अगर हमें लगता है कि वो बेटर रिपेयर के लिए जरूरी होगा. सो ऑपरेटिव में मेनिस्कल रिपेयर ओपन डेफिनेटली शायद ही आप करते हैं, स्पेशली जब आप ट्रॉमा के केस में किसी कारण से आप जॉइंट को खोलते हैं, आर्थ्रोटमी करते हैं, स्पेशली विथ प्रॉक्सिमल टिबिया फ्रैक्चर, और फिर आपको कोई मेनिस्कल रिपेयर के लायक दिख जाता है तो आप करते हैं, अदरवाइज हार्डली वी एवर डू इट ओपन नाउअडेज. सो आर्थ्रोस्कोपी इज द gold standard, and arthroscopic meniscal repair is a gold standard now. Meniscectomy total definitely is big no, but having said so, there are certain situations जैसे bucket handle tear, यानी full thickness tear जो anterior से लेके posterior तक जाता है और वो chronically dislocated पड़ा हुआ है, तो फिर जब पेशेंट आएंगे, so we even with our best of efforts, we are not able to reduce that. तो फिर irreducible bucket handle tears वो condition है जहां हमें आज भी total या partial meniscectomy करना पड़ता है, sometimes total करना पड़ता है. इसलिए ये बहुत जरूरी है, जैसे मैं बोल रहा हूँ कि ऐसे cases को जल्दी पिक करना और उसको एक मौका देना जिसमें हम meniscus को salvage कर सकें. Non-operative, of course, you all understand better because majority, I think, of us here are from physio side. So that is something which probably we'll be discussing, or we can have a separate during our panel discussion. So how do we come to a conclusion, like what surgery probably we are taking up, if at all we are taking up for a meniscal injury? So that is the chronicity. So पहला point है, बहुत late होगा तो फिर सर्जरी का कोई पॉइंट नहीं बनता है, इसलिए अर्ली पिक करना बहुत जरूरी है. सो देयर हैज टू बी सम कट ऑफ, आई वुड से 6 वीक्स, एट मोस्ट 3 मंथ्स. 3 मंथ्स के बाद इट रियली बिकम्स डिफिकल्ट टू गिव अ गुड रिजल्ट इवन इफ यू हैपन टू रिपेयर. although that's not a very kind of, I will say, hard and fast ये. So location of the tear matters because that will decide आपका वो healing होगा, कैसा होगा या नहीं होगा. Ability of the patient to follow rehab instructions, तो वहाँ आपका रोल काफ़ी important हो जाता है और हमारा भी, और यहीं पे we need to work hand in hand जहाँ आपको communicate करना है. So probably मेरा experience, like I have been in Ranchi for the past 12 years and my colleagues and rest of us will agree that we hardly ever get any communication from any of the physios. So होता क्या है कि we feel कि patient is doing well, patient feels कि ठीक ही चल रहा है, you also feel that everything is going well, but probably the optimal physio is not happening. क्योंकि आपने surgery के दौरान actually haven't seen, we don't share the surgical videos, so आपको पता नहीं होता कि exactly what has been done. And if the result doesn't seem to be going the way we expect it to be, so actually we need to discuss. So being in touch, the surgeon and physio both have to be in touch always. That only is the way we can produce. So communication is the key, even with the patient. अगर आप patient से communication नहीं करेंगे, तो probably वो समझेगा नहीं. He will feel मैंने surgery करा लिया, थोड़ा exercise हो गया, and then probably he will keep blaming either the physio or the surgeon, or maybe both, that ठीक से काम हुआ नहीं. So age of the patient matters, no doubt. Degenerative significant changes के साथ we never take up those for repairs. Quality of the meniscal tissue, as I said, could be for different reasons. Maybe previous injury leading to poor quality, overall nutrition of the patient, and maybe age directly affects the decision making. So again, coming to this one, as I showed, that this is the cornerstone of decision making. And it can come in different shapes, sizes, and colors. So red zone, that's the peripheral part, is the real catch. So we have to catch these cases early. Red white zone, again younger patient, a big emphatic yes. Lateral tears heal better than medial. So अगर हम बात करें कि किसमें ज़्यादा अच्छे है, तो even for prognosticating patients, we can be more confident in saying कि आपका lateral tear है तो ज़्यादा better result आएगा. So these are the certain facts which we all should know. Now these are types of tears. I won't go into the detail because MRI जब आप देखते हैं, so this is how you interpret. तो MRI में a good, well-reported MRI should not just say that there is a tear in the meniscus. It should explain everything. What is the extent of the tear? What is the nature of the tear? ताकि आप पहले से planning कर सके as a surgeon and even prognosticate कि इसमें exactly result कैसे आ सकते हैं. So these are all the different types जो अलग अलग ये में आते हैं and इसमें उसी हिसाब से symptoms भी आते हैं. So we all should have some idea, and based on our clinical finding and the history as a presenting complaint of the patient, we can have a basic guess like किस तरह का tear हुआ होगा. So ये locking करा सकता है. So that's the vertical, longitudinal or bucket handle tear, depending on कितना बड़ा है. This usually presents as locking. So the patient जब बोलता है मेरा knee lock हो जाता है, फंसता है, then that's the point when we should suspect this kind of tears. So this is the most common one, and this occurs at the posterior and middle third of the meniscus, flap or parrot beak type of tear, जो वहाँ पे बीच में circle हुआ है. Then radial or transverse tear may result in complete loss of meniscal function if tear reaches periphery. So ये वाले खतरनाक varieties हैं, and इनको हमें probably early surgery के लिए convince करना है. So horizontal tears again, they divide the meniscus into superior and inferior flaps, and they may be highly unstable. So instability, as I said previous में, that becomes an indication for surgery. So idea ये है बताने का कि what exactly keeps happening, हम अपने दिमाग में क्या करते हैं. So it's not as simple as that. जैसे लोग करते हैं कि they will, because I don't think अभी इंडिया में कोई भी आदमी बचा है जिसके पास मेडिकल डॉक्टर के किसी मेडिकल प्रोफेशनल का एक्सेस नहीं है. So all of us would agree that every other day we get one fine morning, evening, afternoon, एक MRI report आएगा, and based on that they will ask for opinion. इसमें surgery कराना है या नहीं कराना है. So that's the worst kind of opinion which you can give. So probably I would suggest seriously कि WhatsApp पे आप एक caution के साथ एक message जरूर छोड़ें कि we don't advice based on MRI reports, at least not on WhatsApp. So let's stop being WhatsApp doctors. So chronicity जैसे मैंने बताया, that decides, and that also decides the changes which you will expect. जितना पुराना इंजुरी होगा उतना ही ज़्यादा कार्टिलेज को डैमेज हो चुका होगा. So A is compliance. तो सर्जरी आप उसमें करते हैं जो पेशेंट कॉम्प्लायंट हो. कॉम्प्लायंस के लिए हम दोनों का, फिजियो डॉक्टर दोनों का रोल है, क्योंकि वो मोस्ट ऑफ द टाइम्स वो आप पे दे ट्रस्ट यू मोर एक्चुअली, क्योंकि उनको लगता है कि सर्जरी डॉक्टर बोल रहा है, ही हैज गॉट वेस्टेड इंटरेस्ट, इसको तो हर केस के पास काटना है. सो वी नीड टू अंडरस्टैंड, वी नीड टू बी ऑन द सेम पेज that in actual scenarios or the cases where we actually need surgeries, that is well justified, and what happens if we really keep neglecting or delaying the surgery. So rehab and restrictions are very important, and those definitely is part of discussion during panel discussion. So knee stability, and as I said कि ACL और meniscus का combination बहुत common है, तो अगर ACL deficient knee में सिर्फ आप meniscus करके छोड़ देंगे और ACL नहीं करेंगे तो फिर उसमें भी meniscus fail कर जाएगा. So stability का assessment वो clinical ज़्यादा होता है, many times MRI actually misguides you. So incidence of ACL injured knee, medial or unrepairable भी ये percentage है, just to quote the literature, in case patient जानना चाहता है तो we should be aware कि कितने cases हो सकते हैं जो हम जाके भी शायद sometimes we change the idea and we don't repair. So we just come out as kind of, we go for partial meniscectomy. So जो techniques हैं उसके details में नहीं जानना चाहूँगा, but फिर भी just to give you a glimpse, because जहाँ तक मेरा interaction का अभी तक conclusion है कि you are always having some vague idea, although everything is available nowadays on net, कि actually किया क्या होगा. Because many times हम भी out of our kind of, I would say, maybe slight, I would say, not that being vigilant, हम अपने notes में उतना detail में नहीं डालते हैं कि किस तरीके से किया हुआ है. So even rehab can have repercussions based on the technique जो हमने use किया है. So usually nowadays we just mix and match, क्योंकि कुछ technique जो conventional है जैसे outside in या inside out जैसे हम meniscus को repair करते हैं वो काफ़ी economical होते हैं, और all inside no doubt is like latest and one of the best ये to do, because उससे आपको extra time बचता है, and that's very important sometimes, but that is costly. So every time you fire one fast fix, we run the cost in thousands. So affordability एक बड़ा issue है. So I'll just skip through this thing, but the point is that meniscus repair gives better results because that saves the knee from early arthritis, and these are all data from different studies. So even if आपने partial meniscectomy किया, you can see that only 40% needs to know osteoarthritic change. So 60% partial meniscectomy knees will go in for early osteoarthritis, whereas if you repair meniscus, तो उसमें 20% knees only go. So very significant number of knees you can save from इवन टू प्री इंजुरी एक्टिविटी की अगर बात करें कि पेशेंट का जो एक्सपेक्टेशन रहता है कि चोट से पहले मैं पहुंच जाऊं, तो उसमें भी मेनिस्कल रिपेयर 96% तक इट कैन गिव एक्सलेंट रिजल्ट, जबकि पार्शियल मेनिस्केक्टमी में सिर्फ 50% लोग ही प्री इंजुरी लेवल तक जा पाते हैं. सो द कैच इज वी नीड टू अंडरस्टैंड किस जोन में इंजुरी हुआ है, और दूसरा कि कहाँ बेसिकली हमारे फेलियर्स के चांसेस ज़्यादा हैं. इसी तरीके से हमें पेशेंट को कन्विंस भी करना है, और इसी तरीके से हमें पेशेंट को लॉन्ग रन के लिए और बेटर या रेदर कहें इवन इफ यू सस्पेक्ट सम कॉम्प्लिकेशन मेंटली प्रिपेयर करना है. सो लॉन्ग एक्सटेंडेड टीयर्स विल हैव पुअर प्रोग्नोसिस, नो डाउट, but long extended meniscectomy will give even poorer prognosis. So every time you try to repair, actually you give a chance for that meniscus to recover and a chance for the knee to not undergo early osteoarthritis. So repair gives better outcome than meniscectomy in long term. Repair gives better activity levels than meniscectomy. Meniscal repair lower failure rate than meniscectomy. So आज के डेट में meniscectomy is no more. So problem is why still meniscectomy is happening, because probably surgeons also find it easy to take out the meniscus. They will be in a bit of hurry, or probably they are not that well trained to repair that. Now two of the talks are coming up, that's probably online, so I won't be going into detail, but it's important to mention that there's something called ramp lesion. तो ramp lesion बहुत common है, that's under-reported, and हम इसे कहते हैं कि ये जो periphery से आपका उखड़ा हुआ है, that's in the corner, जो बहुत difficult होता है, इसलिए a good diagnostic arthroscopy जिसमें 360 हम सारे meniscus को देखते हैं, that's very important, because कहते हैं कि arthroscopy में रैम्प ने आपको देखा, आपने रैम्प को नहीं देखा. तो रैम्प तो आपको देख रहा था, but actually आप रैम्प को नहीं देख पाए. So that's a suboptimal diagnostic arthroscopy which we do, and the surgeons have to take the blame for that. So meniscal root tears, again that's a topic for discussion, but why I put it here, because meniscal root tear अगर हम मिस करते हैं, जो usually calf में पेन के तौर पे आता है, पेशेंट को भी लगता है छोटा सा दर्द ही तो है, so that leads to very early arthritis. So why I put this image is, that's from internet. So this legend standing by the side of our late Prime Minister Sri Atal Bihari Vajpayee is none other than C.S. Ranawat. And यहाँ दो चीज़ बहुत important है discuss करना, कि हमारे पेशेंट्स पहले तो चीज़ों को नेग्लेक्ट करते हैं, और फिर जब वो अर्ली ऑस्टियोआर्थराइटिस हो जाता है, सो दे कम टू दैट डिनायल मोड कि हमें आर्थराइटिस कैसे हो सकता है, इस उम्र में कैसे नी रिप्लेसमेंट की बात कर रहे हो. सो इफ एट ऑल वी वांट टू अवॉइड दैट नी रिप्लेसमेंट जो वाजपेयी जी का भी हुआ था, आई डोंट नो दैट्स फॉर्चुनेट और अनफॉर्चुनेट, क्योंकि अनफॉर्चुनेटली शायद ये मैसेज गया कि TKR जो है वो उनका सक्सेसफुल नहीं रहा. बट this is such a big gathering, so I would like to put facts on record that it was done by the best of the hands. He was a legend, and we should be really proud that late Dr. C.S. Ranawat, he passed away last year only. He was a legend, and he was like a pioneer in the field of total knee replacement, and the surgery was beautifully done. So the point is, if you don't manage things properly, then you will land up in early arthritis. So just to show you a few glimpses of like exactly what we do inside out technique, that's for lateral meniscus here. So we just explore the lesion, we just find out, reconfirm with our MRI findings. We have to freshen up the edges of the lesion so that that can be repaired and that heals well. So you can see that's in the very peripheral part which will have a good healing. So I will just be skipping few of the things because probably we are having short time. We're running short of time. So all inside medial meniscus repair again, that's another this thing case. So outside in repair technique for complete radial tear of the lateral meniscus. So that's another case, and that was in the mid body. So as I said, radial tears are the ones which are the most notorious ones. I didn't go through the this thing, video. Outside in repair for longitudinal tear of medial meniscus. That's suture subtle technique which we call. So that's the tear, and we are exploring so these are all more in the, we have to have a good look and good assessment, and for that we should not hesitate from going in for different accessory portals. So that is the whole point. So ये मैं इसे दिखा रहा हूँ so that you understand कि आप जब notes देखते हैं या जब communicate करते हैं तो you should actually discuss with the surgeon कि exactly क्या किया गया है. So that's ये last का video है जो basically bucket handle है, और जैसे मैंने बताया most of the cases will have some partial relief and फिर वो late से आते हैं and we just keep on lingering things. So ये बहुत difficult हो सकता है reduction, और reduction अगर stable है तो उसे हम फिर उसको repair करते हैं. That gives excellent result. So repair is important, and like जैसे मैं बोल रहा था all inside technique, although that's excellent but that's very costly. So अगर हमारा financial constraint है. Now this case I just wanted to share. She was like a national level kabaddi player and very kind of eager to continue her kabaddi career. So as I said, अगर आप सही समय पे ये नहीं करें, that's a video which she has compiled. So that's post rehab, that was with ACL and meniscal injury, and we were so happy to see that she could resume her kabaddi aspirations of playing for India, and she is doing excellently well. So the idea is to show us that especially even the patient is not a weekend warrior as we say, जो Saturday Sunday को जोश में आके खेलते हैं और इंजरी करते हैं, उनमें तो probably result उतना मैटर करता ही है, but उससे ज़्यादा इनके लिए करता है. तो उसमें अगर results अच्छे आ सकते हैं तो why not in most of our patients जो apprehension होता है. So what is this is the last slide, so just bear with me 2 more minutes. Orthobiologics for meniscal injury, probably इसके बारे में बहुत बातें होती हैं. We also try, many of you might be trying also PRP injections, steroids and all kind of, but then I would say most of the meniscal injuries don't heal by this. So it's more of a palliative rather than therapeutic, and सिर्फ वो आपको थोड़ा relief देता है. और orthobiologics definitely has got a role during surgery, क्योंकि जो orthobiologics scaffold use करते हैं आप, या जो हम जो repair करते हैं उसके बीच में we inject PRP there. So these are all definitely going to work, but just PRP देना या steroid injection देना, that's not going to help. That's many times actually worsens, and that gives a false assurance the patient is doing well. So what is the message? Message is saving meniscal tissue is of prime importance, because that prevents osteoarthritis and restores normal biomechanics. The surgeon, even the physios, have to be well aware with different methods of meniscus repair, and hidden lesions like ramp and root tears, if left unaddressed, or any other surgery, badly done surgery is worse than no surgery at all. So we have to remember that we all owe that responsibility to the patient, because patient holds great faith in us. But point is probably we need to educate each other more and more to the patients, because ultimately the call is always from patient side. So thank you so much for your patient hearing, and any question if I would be happy to answer.
Sir, can we take the question and answers later, please, because we are running short of time. So thank you so much, sir, for the... So thank you so much for the insightful presentation. I would request Dr. Nitesh Kumar, sir, to please come on stage and present the memento as a token of gratitude to our speaker. A huge round of applause for our amazing speaker. Thank you. Moving on to the next topic of discussion today, and for that, please join me in welcoming our next speaker, our expert speaker for the session. Our next speaker is a true titan in the world of rehabilitation. With a career spanning over 3 decades, he has witnessed the entire evolution of physical therapy in India. For the last 14 years, he has been a driving force at Paras Health Group, where he heads the physiotherapy department with distinction. When you have a 33 years of clinical experience, you just don't treat injuries. You master the art of healing. Please join me in welcoming a veteran leader and an inspiration to many in this room, Dr. D.P. Sharma. With a huge round of applause, please welcome sir.
Respected senior doctors, distinguished speakers, colleagues, friends, and dear delegates, good afternoon to you. It gives me immense pleasure to be here today at this sports injury conclave in Ranchi. I sincerely thank the organizers for inviting me and giving me the opportunity to interact with such experienced and passionate group of professionals. I am Dr. Dharampal Sharma, Head Department of Physiotherapy at Paras Health. For those us working closely with athletes, sports injuries are not clinical cases. They are stories of dreams interrupted, careers put on pause, and sometimes confidence shaken. Our responsibilities goes beyond relieving pain and healing tissues. Over the years, we have seen clear rise in trends of sports-related injuries, not only among the professional athletes, but also among young players, fitness enthusiasts, and weekend warriors. Many of these injuries are preventable, and many reoccurrences happen simply because of rehabilitation is rushed or incomplete. This is where physiotherapy role is critical. Today, physiotherapists are not only working in rehab rooms, but also present in fields, gymnasiums, operation theaters, and during return to play decisions. Our focus is to restore movements, rebuild strengths, correct faulty patterns, and bring back confidence in the athletes. At Paras Health, our approach is simple but sincere. Every athlete is treated as an individual. We believe in constant communication with orthopedic surgeons, sports physicians, psychologists, dietitians, and family members. Our aim is not just faster recovery, but lasting. Platforms like this conclave are extremely important. They allow us to learn from each other, to discuss real challenges, share mistakes, and improve our practice. Medicine evolves every day. Unless we evolve with it, we fall short need of our patients. I truly believe future of sports injury management lies in teamwork, evidence-based medicines, practice, and empathy. When science and compassion go hand in hand, outcomes are always better. I congratulate the organizing team for these excellent initiatives and wish Conclave all its success. Looking forward to meaningful discussion and learning from all of you. Thanking for your patience and attention. Sports injury is any damage to the body tissues that occurs during sports or physical activity and result in pain, reduced movement, or inability to continue normal training or competition. Types of injuries. Category, what it happens. Examples, acute injury happens suddenly, like sprain, fractures, dislocations. Chronic injuries develops over a period of time, tendinitis, stress fractures, direct injury by external force, bruises, fracture from collision, indirect injuries, internal force while moving, muscle strains, overuse injuries, repeated stress like tennis elbow and shin splints, soft tissue injuries, affects muscles, ligament, tendons like strains and sprains, heart tissue injuries or affects bones and joints, fractures, dislocations. There are some authorized data from some media centers. The maximum injuries in the sports are sprains and strains. They consist of 30% injuries. Next is knee injuries. They consist of 20%. Rest follows them. According to duration of injuries, acute injuries occur suddenly and are typically caused by trauma or specific incidents. The onset of pain or discomfort is immediate or with a short time after the injury event, like sprains, fractures, dislocations, contusions. Symptoms are pain, swelling, bruising, loss of function. The injury happens instantly or within minutes of trauma. Chronic injuries develops gradually over a period of time due to repetitive stress. These injuries may not even show symptoms immediately, but worsens with continued stress on affected areas. Examples are tendinitis, stress fractures, shin splints. Symptoms are pain that gets progressively worsen over a period of time. The injury is not the result of a single incident, but rather the repetitive movements or a stress on a particular area of body. According to mechanism of injuries, direct injuries. A direct injury is caused by direct impact or blow to the body. The force directly affects the tissue involved. Examples are again bruises, fractures from a direct fall or collision, lacerations. Symptoms are immediate pain, swelling, bruising at point of impact. Indirect injuries occurs when the force of trauma does not directly hit the injured area, but instead causes damage through a twist or strain or overextension of the body. Examples are sprain, strain, like twisting your ankle during quick direction, or change or pulling muscles while sprinting. Ligament tears, like ACL tear, caused by sudden twisting of movements. Muscle strains, pulling off a hamstring when sprinting fast. Pain develops after the motion that caused the injury, often felt in stretched or torn tissues. Overuse injuries. Overuse injuries occurs due to repetitive activity or overtraining without adequate rest, which leads to wear and tear on the affected tissues. Examples are again tendinitis, repetitive motion or leading to inflammation of tendons, stress fractures, shin splints, bursitis, symptoms like gradual onset of pain and discomfort that worsens over time with continued use. According to types of body tissues, soft tissue injuries involves damage to muscle, tendons, ligaments, cartilage. Examples again are sprains, like ligament injuries, strains, muscles or tendon injuries, contusions, bruises or crush injuries, tendinitis, bursitis. The symptoms are pain, swelling, tenderness, and limited range of motions. Healing usually involves rest, ice, compression, and elevations for minor injuries and physical therapy for more serious injuries. Heart tissue injuries involves bones or joints often caused by a traumatic event such as impact or fall. The examples are fractures, broken bones, dislocations, joint injuries like knee dislocations or shoulder dislocations. Symptoms are sharp shooting pain, swelling, deformity, and limited or inability to move to affected areas. Treatment may involve immobilization, casting, and surgery. Common sports injury conditions are muscle strains, muscle tear, delayed onset of muscle soreness, and tennis elbow, lateral epicondylitis. Jumper's knee, patellotendinopathy, golfer's elbow, medial epicondylitis, rotator cuff tendinopathy or tear, shoulder impingement syndrome, HLH tendinitis, ankle sprain, ACL injury, PCL injury, MCL injury, LCL, joint subluxation, joint dislocation, ligament sprain, spondylolithiasis, disc prolapse, spondylosis, chondromalacia patella, IT band syndrome, swimmer's shoulder, frozen shoulder. Now, most important point is prevention of sports injuries. Sports injuries can rarely be completely avoided, but most can be reduced with proper training, conditioning, equipment, and recovery strategies. Prevention focus on pre-participation, preparation, injury-specific measures, and overall fitness. The general principle of injury prevention is proper warm-up and cool-down. Warm-up to 10 to 15 minutes of light aerobic activity and dynamic stretch to increase muscle temperature, elasticity, and nerve conductivity. Cool down 5 to 10 minutes of light activity with static stretching to prevent stiffness and aid recovery. Progressive training and load management. Gradually increase intensity, duration, and frequency of training. Avoid sudden increase in load, which are common cause of stress fractures, muscle strains, and tendinopathies. Strength and flexibility program. Strengthen muscles, tendons, ligaments for joint stability. Flexibility training reduces risk of muscle strains, tendon injuries, and ligament sprains. Include eccentric training for hamstrings and calf muscles, which reduces strain risk. Endurance and conditioning. Cardiovascular and muscular endurance training which reduces fatigue, which is a major risk factor for injury. Fatigue athletes have poor coordination, decreased proprioception, and higher injury risk. Proper technique and biomechanics. Training correct movements, pattern, posture, and sport-specific skills prevents overuse and acute injuries. Use video analysis or coaching feedback to correct faulty techniques. Protective equipment and footwears, helmets, padding, braces, tapes, and properly fitted shoes reduces impact and joint stress. Footwears should match surface type. For example, turf shoes versus running shoes. Recovery and rest. Adequate rest between sessions reduces overuse injuries like tendinopathy, stress fractures, and shin splints. Sleep, hydration, and nutrition support tissue repair and prevent fatigue-related injuries. Comprehensive sports rehabilitation plan, physiotherapy based. Sports rehabilitation aim to restore full function of injured area while preventing recurrence. Physiotherapy follows a structured phase approach, protect and promote healing, restore range of motion, strengthen muscles, proprioception and balance training, functional and sports specific training, psychological readiness. Phases of rehabilitation. Rehab is generally divided into 5 phases, but timing may vary depending on the injury. Acute or protective phase up to 3 days. The goal is to control pain, swelling, inflammation, prevent further injuries. Physiotherapy interventions are rest and immobilizations, use braces, slings, or cast if needed. Cryotherapy 15 to 20 minutes, 2 to 3 hours per day. Compressions and elevations, gentle circulation exercises, precautions to avoid stretching resistance or weight bearing on the injured part. Early recovery, mobility phase up to from 3 days to 2 weeks. Goal is to restore pain-free range of motion and prevent stiffness. Physiotherapy interventions are passive and active assisted ROMs, isometric exercises, cardio training, scar, soft tissue mobilizations. The precautions is to avoid activities that provoke pain, swelling, monitor healing closely. Strengthening phase from 2 to 6 weeks. Goal is to rebuild muscle strength, endurance and joint stability. Physiotherapy interventions are progressive resistance exercises. Start with low weight, increase gradually. Closed kinetic chain exercises like safe for joints. Examples are mini squats, leg press, etc. Core and trunk stability, important for balance and transfer to force. Flexibility exercises, stretching muscles gently to regain full ROMs. Proprioception exercises, balance boards, single leg stance to improve joint control. Precautions to avoid high impact or sport specific movements until strength and stability are adequate. Functional or sport specific training from 6 to 12 weeks. Restore coordination, agility and sport specific skills. Physiotherapy interventions are plyometric, hopping, bounding and jump training. Speed and agility drills are lateral movements, shuttle runs, change of direction exercises, simulated sports drill like light practice of mimicking the sports movements, passing, kicking, throwing, endurance training, gradual increase of intensity and duration. Precautions only, progress if pain-free, monitor for swelling or tenderness. Return to sports phase. Safe return to full competition at pre-injury performance level. Physiotherapy interventions are full intensity training, gradually reintroduce full speed and intensity, protective sports like taping, braces or padding if necessary, maintenance program, continue strength, flexibility and proprioception exercises, psychological support and precautions are to ensure full strength, flexibility and functional movement before unrestricted sports. Sports rehabilitation for acute injuries approach. Recent physiotherapy protocols have moved from traditional rise or price to peace and love, which emphasizes not just immediate protection, but also early loading and education. Protections, avoid further tissue damage, use braces, sling or crutches as needed. Elevation, elevate the injured limb. Avoid anti-inflammatory drugs initially. Some inflammation is necessary for healing. Use only if prescribed. Compressions, education, inform the athlete about expected symptoms, early mobility and gradual return to activity. Subacute recovery from 3+ days. Load, gradual progressive loading of injured tissue to promote healing and prevent deconditioning. Optimism, psychological support and positive reinforcement improve compliance and recovery. Vascularization, encourage controlled cardiovascular activity like cycling, swimming to improve blood flow to the healing tissues. Exercise, early therapeutic exercise tailored to injury type like strength, flexibility, proprioception and balance. Taping technique in sports rehab. Taping is an adjunct to physiotherapy, providing sports, proprioceptive feedback and pain relief in acute and chronic injuries. This gives us support and stabilizes injuries joints, reduces pain and swelling, improve proprioception, allow early safe movement, prevent re-injury. Types of taping, rigid taping, elastic and kinesiology taping, functional prophylactic taping. These kinds of taping, ये वीडियो है. Then dry needling technique in sports rehab. Dry needling is a physiotherapy technique in which thin, solid filiform needles are inserted into myofascial trigger points, tight muscles or connective tissues to reduce pain, improve muscle function and restore movement. Unlike injections, no medication or fluid is used, hence the term dry. Purpose in sports rehabilitation to relieve muscle tightness and spasm, reduces pain, improves blood flow, restore range of motion, enhances muscle function and performance. Common indications, muscle strains like hamstring, calves and quadriceps muscle, tennis elbow or golfer's elbow, rotator cuff or shoulder tightness, low back or neck pain with muscle spasm, plantar fasciitis, mechanism of action. Needles insertion stimulates a local twitch response in tight muscle fibers, reduces abnormal muscle contractions, increases blood flow and oxygenation to tissues, modulates pain by affecting neurotransmitters and nociceptors. These are the BFR techniques. Blood flow restriction is a training method in which a cuff or band is applied to a limb to partially restrict venous blood flow while performing low load resistance exercises, promoting muscle strength and hypertrophy similar to high load training. Purpose of sports rehabilitation is increases muscle strength and size with low load exercise, prevents muscle atrophy during immobilization or post-injury, improves endurance and functional capacity, reduces joint stress compared to heavy lifting, enhances recovery and early rehabilitation. These are BFR. Hydrotherapy or aquatic therapy. Hydrotherapy is a physiotherapy technique that uses water for therapeutic purpose to improve muscle strength, flexibility, circulation and functional recovery. It is also called aquatic therapy. This reduces joint stress due to buoyancy effect. Here Archimedes principle is applied. Improves muscle strength and endurance and flexibility. Reduces pain and swelling. Hydrostatic pressure. Enhances balance and coordination in a safe environment, useful for early rehabilitation after surgery or injury. Neuromuscular electrical stimulation plays a significant role in ACL reconstruction post-surgery rehabilitation. It is used to strengthen weakened muscles, reduces muscle atrophy and improves knee function. NMES is particularly effective in early phase of rehabilitation. Why NMES is important? This reduces muscle atrophy and weakness, improves quadriceps strength and function, enhances knee joint stability, promotes faster recovery and return to sports. Key benefits of the NMES: improved muscle strength, enhances quadriceps and hamstring strength, crucial for knee stability and function, reduces re-injury risk, strengthen muscle gains, and improved symmetry, reduces the risk of re-injury. Enhanced knee functions. NMES is improved functional outcomes such as sit to stand and counter movement jump performance. Importance of sports injury rehabilitation. Rehabilitation uses therapeutic exercise and physical techniques to reduce or decrease pain, swelling and muscle spasm after sports injuries. Early and progressive mobilization prevents stiffness and helps joint regain full functional movement. targeted strengthening programs rebuild weakened muscles and restore power needed for sports performance. Stretching and corrective exercise improves flexibility and correct muscles imbalance that can cause further injury. Rehab restrains neuromuscular control, which is essential for agility, stability, and injury prevention in sports. Structured phase-wise rehabilitation ensures athletes return to training and competition safely at the right time. Patient's progress. Patient is operated by Dr. Avkash Kumar. Diagnosis: left axial reconstruction, medial meniscus, lateral meniscus repair. Surgery on 4 December 25. Operated by Dr. Dhruv Paul. Diagnosis: left axial reconstruction on 30 October 24. Rehabilitated at Paras HTC Ranchi. My only one word and simple advice to all physiotherapists sitting here, my last 33 years of experience, only simple advice: kindly communicate directly with your orthopedic surgeon, with your patients and families. Don't hide anything from your orthopedic surgeon. He is the master who has operated that patient. Don't hide. Don't think that I will do that. That is my simple advice. Don't hide anything. Directly communicate with your orthopedic surgeon. That is the only one advice I have with your sitting therapist here. Thank you.
Thank you so much, sir, for the amazing presentation. I would request Dr. Ajit Kumar, sir, to please come on stage and felicitate Dr. D.P. Sharma. So, यहाँ से देखा जाए तो बहुत सारे मुरझाए हुए चेहरे दिख रहे हैं. साफ इंडिकेशन है कि सुबह से पढ़ के सबका ग्लूकोज लेवल डाउन हो गया है, राइट? सो इट्स टाइम फॉर सम ग्लूकोज लोडिंग. सो लंच इज सर्व्ड इन वाटिका, राइट? मैं अनुरोध करूंगी सारे पार्टिसिपेंट्स को कि वो वाटिका जाएं लंच करके हाफ एन आवर. सो वी कम बैक बाय 2:50 p.m. We are back here. Okay? Please, let's make it fast and resume our session after lunch. सारे हमारे speakers, हमारे doctors would request you to please wait here. My son, Dr. Faisal Nasir Mir. Dr. Faisal Nasir Mir.
आधा घंटा तो इनफ है ना, आधा घंटा तो इनफ है. अभी जैसे वहाँ डीसी होगा ना, उनको पहले इंस्ट्रक्शन देना अपना माइक म्यूट कर दो, जैसे बोल लिए ना यहाँ पर सुन लिए, उसके बाद म्यूट कर दो, माइक आगे ले लिया, माइक नहीं बस माइक अनम्यूट म्यूट होता है ना, जैसे अपना वर्ड पूरा करेंगे म्यूट कर देंगे, डबल वाला चक्कर नहीं रहेगा. माइक पे भी बोलना
ले काम नहीं कर रहा.
अभी बोले कंफ्यूज है डॉक्टर को उतना थोड़ी टेक्स्ट से भी उनको थोड़ा देर पहले बता. अरे कोई दिक्कत नहीं, उतना चले. अरे अब कल महीने चल रहा हमारा कहाँ किया उसके बाद कुछ चला ही नहीं. इतना बड़ा नहीं चल बड़ा है छोटा दोनों बड़ा दोनों बड़ा छोटा बैटरी बैग में है.
So welcome back everyone. I hope you enjoyed the lunch. Yes, खिले खिले चेहरे बता रहे हैं कि glucose level अब proper है, right? And concentration better होगा. ऐसा ना हो कि सब सो जाएं, right? So please keep your energies on. We will be moving on with our next session, but before that, we have with us our Director, Internal Medicine, Dr. A.K. Thakur sir, who wants to share few things related to physiotherapy. 2 minutes. So, sir, please request you to please come on stage.
Good afternoon, everyone. I have great regards for the physiotherapist. With my personal experience, I developed sacroiliac dysfunction around 15 years back. I was treated by the best neurosurgeon at Bokaro General Hospital and orthopedic surgeon. And they advised me, because there may be times where there is a radiculopathy or not. The physiotherapist just manipulated, I got the recovery. Because when Dr. Nirmal was speaking, वो बोल रहे थे कि आप लोग भेजिए. मेरा कहना है कि साइकिल के 2 पहिए होते हैं. एक पहिया वाला साइकिल हम लोग बहुत पहले 70s के ज़माने में जो सर्कस होती थी उसमें देखते थे. तो हम लोग एक दूसरे के कॉम्प्लीमेंट्री हैं. हम लोग, आप भी सर्जन को, हमें एज ए फिजिशियन मैं तो रेफर करता हूँ एज ए फिजियोथेरेपिस्ट को, तो आप लोग भी सर्जन के, ऑर्थोपेडिक सर्जन के पास भेजें, न्यूरो सर्जन के पास भेजें, फिजिशियन के पास भेजें, और हम लोग भी डेफिनेटली आपके पास, आपके बिना नहीं चलेगा. क्योंकि मैं हमेशा, कुछ पेशेंट बोलते हैं कि सर आप तो बता दीजिए. मैं बोला मैं 3-4 एक्सरसाइज जानता हूँ. मान लो कि मैंने एक्सरसाइज बता दिया, क्वाड्रिसेप्स बता दिया, बैक एक्सटेंशन बता दिया. अब वहाँ बैक एक्सटेंशन करना है कि बैक फ्लेक्शन करना है वो भी नहीं मुझे मालूम. तो 4-5 एक्सरसाइज जानने से आपने कम से कम जो कोर्स किया है बीपीटी, आई नो इट इज 4 years कोर्स, और मेनी ऑफ देम वुड हैव डन द एमपीटी व्हिच इज अनदर 2 years कोर्स. तो मैं यही चाहूँगा कि हम लोग एक दूसरे के साथ मिल के चलें, तो अल्टीमेटली बेनिफिट विल बी द पेशेंट. फायदा मरीजों को होगा, क्योंकि हम लोग का आपस का ये, और इसमें किसी का नहीं, ना मेरा ईगो है, ना सर्जन का ईगो है, ना आपका ईगो है. बेनिफिट हमेशा पेशेंट को होगा जब हम लोग दोनों मिलकर काम करेंगे. थैंक यू वेरी मच.
Thank you, sir. So we are going to jump straight back into action, and we are doing it with a bit of a digital journey. So while we are gathered here in Ranchi, our next experts are joining us all the way from the beautiful snow-capped valley of Srinagar. So our next speakers, we have 2 speakers for this session. We have senior consultants joining us from Srinagar, Paras Health Srinagar. We have with us Dr. Faisal Nasir Mir and Dr. Muhammad Hasib Ghani. So I would request our team to please connect them.
Am I audible?
Good afternoon, Dr. Faisal Mir.
Good afternoon. Good afternoon.
So welcome to the
Is my
Paris
screen visible?
Conclave.
Thank you very much. It's a pleasure to be a part of this team and to be presenter here today. Is my screen visible?
Yes, we can see you on screen.
Okay, I have started to share my presentation.
Your
Are you able to
presentation
see
is
it?
not visible yet.
Okay. So I've opened it on my iPad actually. So I don't know if you are able to see it.
Not yet.
Can you share my
IT
screen?
IT team, sir, please help. Mr. Rakesh is here, heading our IT. He will help you out.
Okay. Hello? Just a minute. Right side. To come today because he's busy in a case. So I'll be presenting on his behalf. So my name is Dr. Faisal Nasir Mir and I'm a senior resident currently working at Sports Injury Center, Safdarjung Hospital. So today my topic would be about medial meniscal root tears. Am I audible to all of you? Excuse me?
Yes, sir.
Hello?
Please start.
Okay, so my topic would be medial meniscus root repairs and root tears and where do we stand today. So as we all know, medial meniscus is a fibrocartilaginous structure which is composed of primarily of collagen fibers, mainly type 1 collagen, which is orientated in 3 different types of patterns, a radial, circumferential and a mixed pattern. And out of all these, a circumferential one is the one which is one of the most important configurations which helps to divert the load which is onto the knee joint. So these fibers, what they do is they convert the axial load into hoop stresses, thus distributing the load across the knee joint. So what actually happens is the body weight transfers to the knee joint. This vertical load is transmitted through the meniscus into hoop stresses, just like this radial fibers. And what these circumferential fibers do is they distribute these hoop stresses evenly across the joint, thus distributing the load of the body around the knee joint. So now, the root of the meniscus, what it actually is, the root is not a fibrocartilage, rather it acts more like a ligament, and which serves as an anchor to the tibia. And the medial meniscus posterior root, it attaches to the posterior intercondylar fossa, between the attachments of posterior root of the lateral meniscus and the posterior cruciate ligament. As you can see here in this diagram, this is the axial section of the knee joint showing the posterior root of the medial meniscus. So as you can see where it attaches it is between the posterior root of the lateral meniscus and in front of the posterior cruciate ligament. So determining its exact location, you can see there is the medial tibial eminence here. You can see it is just around 9 millimeters posterior to the medial eminence and just 3 millimeters lateral to the posterior tibial eminence. So if we have to just identify the landmark during arthroscopy, so we will have to see the medial tibial eminence and just go 9 to 10 millimeters posterior to it and around 3 millimeters lateral to it. This will determine the root of the posterior horn of medial meniscus. Same is depicted here on the coronal section, where you can see the shiny white fiber lines, and just adjacent to that is the posterior medial meniscus root. Now, currently, the meniscus root tear, it is defined as either an avulsion of the meniscus attachment to the tibia or a radial tear which is within 1 centimeters from the bony insertion of the meniscus root. And now, why these root tears are important? It is because the meniscus root tears, they lead to rapid progression of the osteoarthritis, similar to total meniscectomy. So if you have a root tear, it is as if the total meniscus is torn. So any tear of the root or a complete radial tear around the posterior horn of the meniscus, it behaves as if it is a complete meniscus tear. Why does it do so? We'll see further. So hence, early detection and treatment, it may improve outcome of the patient in case of meniscus root tears. Now going on to the biomechanics of the knee, normal load of the meniscus, like what meniscus, it takes around 50 to 70% of the total load of the body, both the menisci combined, and out of which the medial side is more predominant as it takes around 70% of the total body weight. And of this, 50 to 70% is taken up by the menisci and rest 40% goes directly onto the articular cartilage. And out of the meniscus, the body and the posterior horn especially, they being the least mobile. Why? Because they are attached to the meniscocapsular ligaments posteriorly, meniscotibial and meniscofemoral ligaments, which makes this medial meniscus posterior horn a relatively immobile compared to the lateral meniscus. So that thus the body and the posterior horn of medial meniscus takes most of the force applied to the medial compartment. So thus it's at a greater risk of tears. So with knee flexion, what happens? The pressure on this posterior horn of meniscus is the highest. Why? Because of the posterior femoral rollback. So as you know, during the posterior femoral rollback, the posterior surface of the tibia is actually in contact with the femoral condyles. So thus most of the load is borne by the posterior part of the meniscus and the posterior root. And thus the posterior horn tears and the posterior root tears form the basic and are the most important tears which we see in chronic or degenerative tears of the meniscus. So in case of a torn meniscus, posterior root tear or total meniscectomy, it has been seen by this study by Fairbank that the peak pressures to the medial articular cartilage is increased, which leads to early osteoarthritic changes. Those changes were described by Fairbank as those 3 cardinal signs like squaring of the condyles, decrease of the joint space, or subchondral sclerosis, which we all know. Now, repair of this medial meniscus posterior root can thus restore the normal tibiofemoral contact pressures, and it may be as if it is a normal meniscus. Like we repair the root and we can restore the normal biomechanics of the knee. The prevalence in the past, medial meniscus root tears, they have been neglected because of difficulties in diagnosing, because we could not pick them up on MRI findings, or most of the times they were being missed. So, but with today, with increased recognition and with more enhanced MRI imaging modalities, these tears have been diagnosed more often. So now these root tears account for around 10 to 21% of all the meniscus tears. And in some studies, it has been shown that they are more in Asian population. Why? Because we as Asians more commonly adopt a squatting type position during our day-to-day activities. Now, the incidence of this medial meniscus tear was up to 78% in patients. It has been seen in those patients who went on to undergo a total knee arthroplasty. It was seen that in around 78% of those patients, they had an associated medial meniscus root tears. Apart from that, many of them also had other defects in the alignment. So these root tears, they have a very important association with the biomechanical alignment of the knee as well. That is the coronal and the sagittal plane alignment of the knee. So these differences in the osseous anatomy in both sagittal and coronal planes play a very important role in the pathogenesis of the medial meniscus root tears. So there was a study done by Melguin et al. Who demonstrated that the increase in the posterior tibial slope, it led to a significant increase in pressures around the posterior area of the medial meniscus, predominantly around the posterior medial compartment of the knee. So thus it increased the compression of the medial meniscus posterior root when the knee was loaded axially. And this also led to increase in anteriorly directed forces onto the medial meniscus root. So more posterior slope, more the tibial posterior slope, more there is a tendency of the femur to go back, and more the stress on the posterior medial compartment of the knee, and thus the more incidence and prevalence of medial meniscus root tears. So thus it becomes important to correct this posterior tibial slope in those patients. Along with that, the sagittal alignment, coronal alignment does also play a very important role in the pathogenesis of medial meniscus root tears. So when the knee is in sufficient varus, the medial compartment pre-contact pressures have been shown to be very significantly elevated, and they remain elevated even if we do a meniscus repair. So this calls into question that should we only do a medial meniscus root repair in case of a biomechanically malaligned knees, or should it be supplemented with a tibial osteotomies to correct the biomechanical alignment? So the study was done by Burke et al., which demonstrated that the repair of medial meniscus root can restore the normal peak contact pressures in the medial tibio-femoral compartment, but in knees with a varus alignment, a critical alignment of 4 degrees or more, repair of the meniscus root fails to restore this normal contact pressure. So, thus it warrants necessity of correcting the alignment of the knee along with the repair of the meniscus root. So how do we come to the diagnosis? The MRI and the arthroscopy. Whereas the arthroscopy is the gold standard invasive modality of diagnosing, MRI can help us in determining or bringing us to the conclusion that the patient does have a meniscus root tear. So what all do we see on an MRI finding? So these are 3 or 4 different things which we can appreciate. First, you can see on the image on the left is a ghost sign. The posterior horn of the meniscus, it is absent. The normal triangular shadow which we can see on the posterior surface, it is not seen here. So this would signify that there is a meniscectomy. There is a radial tear of the posterior horn, which may be suspicious of a meniscus root tear. Secondly, in the coronal image, we can see that the posterior horn of the medial meniscus, just attachment at the attachment of the root, it seems unhealthy. The normal black intensity, it is suddenly changed into a hyper-intense white signal here. So this signifies that there is a radial tear just near or adjacent to the root, which may be a root tear. Now, the third imaging modality, a third axial MRI scan. This is the most neglected MRI, which mostly we don't see. We more focus on the sagittal and coronal sections. But this MRI is the most important one if we have to determine the anatomy or the morphology of the tear. This is the most important MRI which comes handy. Now we can see here the normal C-shaped meniscus, medial meniscus going, but at the posterior insertion point there is a radial linear intensity, white intensity. This suggests a radial tear which is going into the root. So thus this may also help us in diagnosing the root tear. Other than that, we can see here in this image D that there is an extrusion of the meniscus, and the meniscotibial ligament, meniscotibial, this capsule, it seems unhealthy. It seems lifted off the tibial condyle, as we can see here. There is fluid seeping in between the tibia and the meniscotibial ligament. So this suggests a meniscotibial disruption, and possibility of a root tear should be there. And other than that, there are some bony contusions which may be an indirect evidence that there is a meniscus root tear. Another important sign is a giraffe neck sign. This is just on the posterior coronal imaging. We can see that the meniscus, normally this meniscus should go all the way up to this root insertion. But as we can see here, there is a white intensity. This means that there is a tear in the meniscus root. Other small signs are the spreading root sign, which these may indicate that there is an impending root tear. These are edematous changes of the tibial condyle, which may be seen prior to an impending meniscus root tear. Now, how do the patients present? Usually, these patients are in the middle ages. They present with a minor or a non-traumatic event in the 5th or 6th decade of life. Some they may present with a pop while going from a sudden flexion to an extended position, or while doing some daily activities such as squatting. Some may have progressive medial knee pain without any history of trauma, and the symptoms, they are similar to a medial compartment osteoarthritis. Some may even present with a discomfort in the popliteal region, which may be sometimes mistaken as a sciatic pain. Less commonly, patients may present with a traumatic event. These are usually young athletes or those who sustain a pivot injury during sports or road traffic accidents. But we have to keep in mind these patients are usually associated with other ligamentous injuries, and more common than medial meniscus roots, these patients have a lateral meniscus root injury. What are the consequences of meniscus root tears? As we have seen, that there are three types of fibers: the circumferential, the radial, and the intermediate. Out of these, the hoop stresses, the axial stresses which come from the knee joint, come from the body, they are distributed as hoop stresses across the meniscus, and this helps in even distribution of the axial forces throughout the meniscus, thus distributing evenly the joint, the load of the body. Now, what happens if there is a complete tear, a radial tear in the meniscus root? These axial forces are not able to be transformed into hoop stresses, and thus, with the result, with every axial loading, the meniscus tries to go outwards. It tries to go outwards, and thus it is extruded. And the joint surface, it remains bare, and all of the load is directly transferred onto the articular cartilage. And this will lead to progression of the articular cartilage degeneration, and within the span of 2 to 5 years, the medial compartment will be arthritic. So this has been explained again in these series of diagrams. So another important thing which we usually see in these patients is that the meniscus extrusion, you should not think that it is only due to a posterior root tear. Sometimes what happens, there is a discontinuity of the meniscocapsular junction. The meniscotibial ligament is detached, which may also be a cause of a meniscal extrusion. In these cases, what has been nowadays an emerging modality of treatment is that we try to centralize this meniscus by using some anchors onto the tibial condyle and then fixing this meniscotibial junction along with the meniscus back onto its place, thus bringing it back inside. This is the new modality which is gaining importance today in meniscus repair techniques. Now, how do we classify these root tears? Simple classification has been given by Laprade et al., which divides these root tears into 5 basic types. The first one is a partial root tear. The second one is a complete tear, which is within 9 centimeters of the meniscus root attachment. The third is a root tear which has a vertical longitudinal component which leads to a bucket handle tear. The fourth one is an oblique tear of the posterior horn which extends into the meniscus root. And the fifth one would be a avulsion of the meniscus root. Another arthroscopic classification was given by Kim et al., which determines the tear or divides it into 5 types based on the gap between the stump and the posterior horn. So 5 types. There is incomplete tear, there is a complete tear with complete overlap, there is a 1 to 3 mm gap, there is a 4 to 6 mm gap, and there is a 7 mm or more of a gap. Now coming on to the management of meniscus root tears. This algorithm was prepared, a study published in PubMed, which gave us a brief, an idea of how do we manage these meniscus root tears. So what basically it does is it classifies the patients with the meniscus root tears into 2 different categories. First would be an acute traumatic one, usually young athletes with a road traffic or a sports injury. Second would be a chronic degenerative tears, which is usually a middle-aged people, like more than 50 years of age. Now, what do we see? If a patient is a young athlete with an acute traumatic tear, you evaluate for a concomitant pathology. So, as I already said, these patients, they definitely almost always have an associated ligamentous injury, like a cartilage defect. They may have a ACL or a posterior cruciate or a collateral ligament injury. They may have a secondary meniscal injury like the injury to the body or injury to the contralateral meniscus, or they may have a mechanical malalignment. So if the patient has a meniscus root tear and any one of these pathologies present, so you should repair the meniscus root and simultaneously address this pathology as well. Now, moving on to patient who is a chronic degenerative tear and is a middle-aged person with early middle compartment osteoarthritis. So you have to evaluate for changes of degenerative arthritis. First, see if there is an advanced arthritis, if there is a grade 3 or 4 cartilage lesion. We see if there is a tibial plateau insufficiency fracture, or there is a coronal alignment malalignment of more than 5 degrees. So if any of these things are present, so their prognosis will be of after repair will be not that good. So in those cases, you opt more towards a non-operative management. Whereas in other patients, in which these things are not present, we move on to meniscus root repair. And if there is a 3 mm or more of extrusion of the meniscus, the newer modality of treatment is centralization of the meniscus. So what we do is we try to bring the meniscus back into the condyle and thus help to restore the alignment of the meniscus. So what are the techniques of treatment of these root tears? There are 3 basic techniques. One is a transtibial pull-out technique. What we do is we drill a drill hole from the tibia and onto the meniscus root insertion. Like I have already determined where is the anatomical landmark for the drilling of the meniscus root. So we'll do a transtibial drilling, use a meniscus root zig or just an ACL zig can suffice. We'll drill a drill hole with a 4 mm drill bit and then tie knots, pass the sutures to the meniscus and then pass them out onto the tibia and fix them with an endo button. The other technique is suture anchor technique. This is a bit difficult, has a steep learning curve. What we do in this is you don't have to drill a tibial tunnel in here. What you have to do is you can make a posterior medial portal and go in from there and then identify the meniscus bed, then prepare the bed and put in a suture anchor there and then tie the knots onto the meniscus and hold it with it. The third technique which we do is an all-inside technique, but this technique is only applicable in those meniscus tears in which we do have a remaining stump of the meniscus root with which we can attach the posterior horn. So what we do is we use 2 to 3 all-inside sutures, repair the posterior horn back onto the meniscus and then add a supplementary all-inside stitch so that to protect this repair. So all of these have their own advantages and disadvantages. Now the transtibial pull-out technique, it is easier to perform. Like there is the surgeons are the learning curve is easy, and you have to make standard arthroscopic portals on, and it is familiar to most of the surgeons. Technically easier than a suture anchor technique, and standard arthroscopic, as I said, only the standard arthroscopic portals are used. And fixation does not rely on any fixation device, so it is a cheaper technique. But it has its own disadvantages, like there is a bungee effect. Because the tunnel is long, so the thread has to pass through this long tunnel, so this leads to a bungee effect. Other than that, there is a chance of elongation of this suture, so which may with time lead to loosening. Other than that, there is always a risk of neurovascular injury, because whenever you have to make a drill hole from this, the neurovascular bundle is close enough, so there is always a risk of neurovascular injury. And moreover that the threads which pass through these tunnels, they always have a tendency to be abraded by the bone, and thus they may lead to tear. But the suture anchor technique is technically a bit demanding. You have to make posterior medial portal, and other than that, you need an anchor to be placed inside this, so it increases the cost. But it does not have the negative drawbacks of a bungee effect or any abrasions, or it does not interfere with the if we have to do concomitant ACL or PCL reconstructions. So the tunnels there is less risk of coalescence of the tunnels. And the third is the inside-out technique, which is comparatively simpler, but you need to have a stump present. So now, the non-operative treatment, what the statistics are is that the 5-year follow-up study of non-op treatment in 52 patients, it was done by Critch, AJ et al. It showed that in 52 patients with a posterior meniscus root tear, they revealed an association with low functional outcome, and 31% of patients need conversion to total knee arthroplasty. So non-operative treatment should be taken with a pinch of salt, so that all of these patients, they do have a tendency to land into early arthritis, and at least around 50% of them eventually need to be converted into an arthroplasty. Partial meniscectomy, in case of a partial meniscectomy, long-term follow-up of 5 to 8 years has shown the arthritis progression in about 1/3 of the patients. There are two things, either you do a partial meniscectomy or you do not do anything at all. So doing nothing at all compared to a partial meniscectomy is better, because at least we have some preserved meniscus. So it has been seen that the partial meniscectomy has led to early degenerative changes and early lined up into osteoarthritis compared to doing nothing at all. But this patients, so in these cases, when we do a partial meniscectomy, the risk of progression to arthritis has been shown to be dramatically increased. But sometimes it is not wise to do nothing at all because patients may have symptoms of locking or pain, which may be because of the loose meniscus fragment, which we need to excise. Now, meniscal extrusion in osteoarthritis. Meniscal extrusion is a sign that showed impairment of meniscus function, and the degree of extrusion, it might be associated with severity of osteoarthritis. And the longer the symptoms, the degree of extrusion might be worse. So these are, I'll be showing two cases which we have done in a hospital at Paras, Srinagar. The first one is a 45-year-old female. She had a painful right knee, a homemaker by occupation. On clinical examination revealed a posterior medial joint line tenderness, and the McMurray's and Thesides and all tests were positive for medial meniscus. So MRI revealed, this is the coronal section of MRI, which you can see here is the meniscus extrusion. On the sagittal cuts, we can see now here is there is a dissociation of the meniscotibial junction, and the coronal section of the posterior horn in the roof, it shows that there is a tear. So arthroscopy, this is diagnosed as a diagnostic, so we can see there is a root tear and there is some amount of gap present also. So what we do is we prepare the meniscus bed. This is a curette, or we can use a rasp to for preparation of the bed. Remove the cartilage around that area so that at least some bleeding bone is present. Now, second step is to use a transtibial tunnel or use an ACL or a meniscus jig to drill a transtibial drill hole of around 4 mm. This is after we have drilled the tunnel. Now you pass the shuttling sutures, can be Prolene, can be an Ethibond, or any suture which you can pass, it will be used as a shuttling tunnel. You retrieve it through a an anteromedial portal or a posteromedial portal if you are making one. Then after that you pass in two luggage. What we do is we passed 2 luggage tag sutures, like we made a cinch knot with 2 PDS sutures. This is the first pass going in, and you take a bite from the meniscus and make a cinch and just use 2 of these knots. What we can do is we can use 2 types of two cinches, or we can use 1 cinch and we can pass one knot thread through the substance of the meniscus and retrieve it up from the portal, anterior portal. So this way, the one cinch knot will hold the meniscus in position, and the second one will go through the substance and it will prevent this one from disengaging. So these are the 2 basic techniques we can use to pass our sutures to the meniscus. So one is passing a cinch knot, other is passing a knot through the substance of the meniscus. So then what we do is to retrieve these knots through the tibial tunnel and then fix them onto the endo button on the tibia, anterior surface of the tibia. So this is the post-op X-ray of the same patient. Now another patient have a 52-year-old male with painful right knee. As we can see in this coronal and sagittal X-rays, there is a significant malalignment of the knee. The right side seems to be in a good amount of varus of around 7 degrees, and there is a significant increase in the posterior tibial slope of around 20 degrees. Now this patient came to us with a mechanical knee pain with posterior medial joint line tenderness and a varus of 7 and a posterior tibial slope of 20 degrees. So this is his MRI. We can see here the meniscus, a ghost meniscus sign, and we can see here the posterior root does not seem to be healthy. So suspected a meniscus root tear. So in this patient, only repairing the root would not have done the job. So we needed to correct the alignment as well. So we planned him for a high tibial osteotomy along with the meniscus root repair. Okay, I'm just finishing. So we performed a high tibial osteotomy to correct varus as well as the posterior tibial slope by a medial open wedge osteotomy. So this is the transtibial fixation of the repair using PDS sutures, and this is the high tibial osteotomy fixed with the plate. So as you can see, the varus alignment has been corrected as well as the posterior slope has been corrected to some extent, and this is his post-op clinical photograph. He has an excellent range of movement and the varus has been significantly corrected. To conclusion, the medial meniscus root tears, they are a challenging problem in patients. and they lead to increased stress of the medial compartment and often rapid progression to osteoarthritis. So indications of root repair are not clearly defined, especially for middle-aged populations and with degenerative tears. Non-op management has shown a rapid progression to medial compartment osteoarthritis within 5 years. And repair over partial meniscectomy has been increasingly supported in literature. And the evolving concept is of meniscus centralization, and it is gaining increased interest with its effects on improving the overall outcome, but the clinical studies remain limited. Thank you.
Thank you so much, Dr. Faisal Mir. We truly appreciate your spending your time with us virtually today. Thank you very much
Thanks
for the
a lot.
presentation. Moving on to the next topic for today, our next speaker is a true pioneer who is redefining the boundaries of orthopedic surgery with technology. With over 21 plus years of rich experience, he is a specialist in robotic joint replacement and advanced arthroscopy. He has been at the forefront of bringing cutting-edge innovations like stem cell therapy and robotic precision to the operating theatre. Joining us from Paras Health, Udaipur, please welcome with a huge round of applause, Dr. Rahul Khanna, Senior Consultant Orthopedics.
The clap says that you all are alive. So, thank you for being here after this post-lunch session. And it has become a tiring job for me to keep you awake. So, I'll try my level best to do so. So, I think all of you who are dealing with one or the other form of orthopedics have seen or treated a patient of ACL reconstruction. Starting this session with Dr. Gupta's talk about the advances and the evaluation of orthopedics as far as arthroscopy is concerned, he has specifically told that we are living in the world of innovations, we are living in the world of present-day orthopedics where everything is based on evidences. So it is an evidence-based orthopedics, as well as we are trying to use new and newer things as well as innovations so that the results of our patients are more favorable and the longevity of the surgical results persist forever or for the maximum major time. So, जैसा मैं आपसे कह रहा था कि आप सबने ACL related surgeries या ACL related rehabilitation देखा होगा, लेकिन जो आज मैं आपको बताने जा रहा हूँ और what I'm going to tell you is will definitely change your vision as far as ACL rehabilitation is concerned, looking to the longevity of your patient as well as to his or her return to play to sports. So, हम आज बात करेंगे for what is known as ACL deficient knees, जहाँ anterolateral rotatory instability, ये बहुत ही नया टॉपिक और नई टर्म है. ऑर्थोपेडिक फील्ड में लोगों को इस बारे में पता है, लेकिन आप लोगों के लिए नया टॉपिक है. लेकिन ये बहुत इम्पैक्टफुल है क्योंकि इससे आपके ACL के रिजल्ट्स मैटर करते हैं. सो किसी भी चीज को समझने से पहले देयर हैज बीन अ सेइंग दैट eyes can see what our mind knows. सबसे पहले हमें ये समझना पड़ेगा कि इसका कंसेप्ट क्या है, हाउ इज इट कंसेप्चुअलाइज्ड. सो कुछ समय पहले, आज से 4 साल पहले तक मुझे ACL सर्जरी जो मैं कर रहा था, इस पर्टिकुलर पेपर के बाद उसका एक इवैल्यूएशन हुआ और मेरी लाइफ एक तरह से चेंज हो गई एज फार एज ACL रिलेटेड सर्जरीज आर कंसर्न. सो दिस वाज अ वेरी गुड पेपर बाय गेटगुड एंड मरमुरा, जिसने हमें यह बताया कि नीज तो सबके सेम है, ऑल हैव गॉट द सेम नीज, बट एवरी इंडिविजुअल हैज गॉट अ डिफरेंट गोल टू अचीव. Both patient and surgeons, they have certain bit of priorities as far as their patients are concerned, because some patients deserve for early time to return to any level of sport or to the pre-injury level, and there are certain bit of patients जिनको ये लगता है कि मैं अपने pre-injury status में पहुंच सकूं और with a full or a good range of motion. But most importantly, for us as an orthopedic fraternity, we should be considering two things. One is the risk of re-injury, कि अगर कोई पेशेंट ACL के लिए रिपेयर हुआ, रिहेबिलिटेट हुआ, रिकंस्ट्रक्ट हुआ, सो उसको री-इंजरी का रिस्क कितना है, कितनी जल्दी वो अपने रूटीन काम इंक्लूडिंग स्पोर्ट्स एज वेल एज डे टू डे एक्टिविटीज इज कंसर्न वो अचीव कर पा रहा है, और अगर हम लॉन्ग रन में देखें तो इंस्टेबिलिटी की क्या चांसेस हैं उसको, ताकि हम उसको एलिवेट कर सकें या कम कर सकें. So the risk of re-injury, as per this study, this was known as Stability 1 study by Alan Goodgood, and he told कि in the age group of 20 years, 20 साल ऐसा एज ग्रुप है जहां रिस्क ऑफ री इंजरी सबसे ज्यादा कॉमन है. मींस जितने भी यंगर इंडिविजुअल्स है जिनमें ACL रिकंस्ट्रक्शन हो रहा है, they are more prone for re-injuries. Even it was seen that as your age increases, जैसे जैसे इंसान आगे बढ़ता है, लाइफ में आगे बढ़ता है एज में, वैसे वैसे उसकी पोस्टीरियर टिबियल स्लोप में करेक्शंस आते हैं, वो डीप होती हैं, एंड देयर इट पाव्स द वे कि उसको ACL लैक्सिटी होती है या ACL में ढीलापन होता है, एंड ही स्टार्टेड फीलिंग इंस्टेबिलिटी. सो व्हाट इज अ पर्सिस्टेंट नी इंस्टेबिलिटी? दिस इज अ वेरी गुड कंसेप्ट. कोई भी ऐसी चीज जो हमें रोटेशनली अनस्टेबल कर रहा है इवन आफ्टर सर्जरी is known as a persistent knee instability. So irrespective of the kind of graft taken, आप सब जानते हैं कि ACL reconstruction जब भी होता है या ligament reconstruction होता है तो patient का ही हम tissue use करते हैं as a graft. So whatever graft you are taking, whether it's a hamstring, whether it's a BPTB or whatever it is, even in normal individuals who have got ACL reconstruction, there is always a chance that he or she may have a rotational instability in years to come. So what is the parameter for that? तो यहाँ आप एक word देख रहे होंगे which is known as pivot shift. So pivot shift is that particular goal that we have to achieve के our pivot shift becomes negative on long run. So there was a study done by this particular group across centers in Canada and Europe, जहाँ उन्होंने हमें ये बताया कि ऐसा कोई प्रोसीजर अगर हम अपने ACL रिकंस्ट्रक्शन के साथ ऐड करते हैं किसी पर्टिकुलर पेशेंट ग्रुप के अंदर, तो उससे उसकी इम्प्लांट की लॉन्गिविटी बढ़ती है, एज वेल एज लंबे समय तक वो अपने खेल को या स्पोर्ट को एंजॉय कर पाता है. सो दैट इज नोन एज लेटरल लिगामेंट कॉम्प्लेक्स रिकंस्ट्रक्शन और लेटरल लिगामेंट कॉम्प्लेक्स ऑगमेंटेशन. अब ये चीज होती क्या है? इन लोगों ने कुछ 600 और पेशेंट्स के ऊपर ये स्टडी करी विच द एज ग्रुप ऑफ 25, जिसमें उन्होंने ACL सिर्फ ACL किया और बाकी पेशेंट्स के अंदर उन्होंने ACL के साथ लेटरल ऑगमेंटेशन किया. तो देयर वाज अ डिफरेंस. सो व्हाट दिस डिफरेंस वाज, प्लीज स्टे अटेंशन ओवर देयर. देयर वाज अ रिडक्शन इन रोटेशनल लैक्सिटी, मतलब जो पेशेंट का पैर घूमता था इवन आफ्टर लिगामेंट रिकंस्ट्रक्शन, दैट वाज सिग्निफिकेंट रिड्यूस्ड. द ग्राफ्ट फेलियर वाज सिग्निफिकेंट रिड्यूस्ड. देयर वाज नो एडेड कॉम्प्लिकेशन. अगर हमने इस प्रोसीजर को ऐड किया जिसको मैं लेटरल ऑगमेंटेशन कह रहा हूं, तो उसमें कोई अलग से पेशेंट को कोई कॉम्प्लिकेशन नहीं थी. स्ट्रेंथ और फंक्शनल टेस्टिंग बराबर थी ओवर अ पीरियड ऑफ 2 years, और द रिटर्न टू स्पोर्ट्स वाज ऑलमोस्ट सिमिलर टू अ नॉर्मल ACL. अनदर थिंग हमने प्रीवियस स्लाइड में देखी, डॉक्टर साहब ने बताया कि एक पेशेंट की जिसकी उन्होंने मैनिसेक्टमी कर रखी थी या उसमें रूट टेयर था, उसमें पोस्टीरियर स्लोप जो था वो 20 डिग्रीज था. नाउ 20 डिग्री स्लोप इज वेरी अलार्मिंग, क्योंकि ये स्टडी हमें बताती है, स्टेबिलिटी स्टडी, के एनीथिंग विच इज मोर देन 10 to 12 डिग्रीज इज एबनॉर्मल. तो जहां पेशेंट की स्लोप ज्यादा है, टिबियल स्लोप, वहां वो फेलियर होना ही होना है, इसलिए हमें उसको रिकंसिडर करना पड़ेगा. सो there are two kind of procedures which can be done for your lateral augmentation. It can be an extraarticular tenodesis or it can be an ligament reconstruction along with ACL. So इस बारे में हम थोड़ा सा डिस्कस करेंगे, लेकिन हम इसको केस बेस्ड स्टडी के रूप में देखेंगे ताकि हमारे लिए समझना इजी हो जाएगा. So सबसे पहले तो हम ये समझें कि एंट्रोलेटरल लिगामेंट जिसकी मैं बार बार बात कर रहा हूं, जो रोटेशनल स्टेबिलिटी दे रहा है, वो एक्चुअली है क्या. सो इट इज बेसिकली अ सॉफ्ट टिश्यू स्ट्रक्चर ओवर द लेटरल एस्पेक्ट ऑफ नी. आप सबने एक वर्ड सुना होगा और आप कॉमनली आपकी क्लिनिकल प्रैक्टिस में देखते हैं या सुनते हैं, वो है इलियोटिबियल बैंड. सो कोई मुझे बता सकता है कि इलियोटिबियल बैंड के अटैचमेंट्स क्या होते हैं? एनीवन फ्रॉम बैक? सो इलियोटिबियल बैंड इज बेसिकली दिस पार्ट ऑफ आवर थाई, जो कि हमारे एंटीरियर सुपीरियर इलियक स्पाइन से कनेक्ट होके जस्ट नी से गर्डीज ट्यूबरकल पे जाके अटैच हो रहा है. एवरीबॉडी एग्री दैट? और इसको हम इस फॉर्म में टेंसर फेशियल एटा भी बोलते हैं. सो ये क्या होता है? सो दिस आईटी बैंड जिसकी हम बात कर रहे हैं, ये सबसे इंपॉर्टेंट पार्ट है इस लेटरल लिगामेंट कॉम्प्लेक्स में। सो मैं अभी आपको एक वीडियो दिखाता हूं जो हमें बताएगा कि ये होता क्या है। अगर मैं एक पेशेंट का डिसेक्शन कर रहे हैं, उस डिसेक्शन में हम ये देख रहे हैं कि जो पोस्टीरियर फाइबर्स ऑफ बैंड हैं वो बहुत इंपॉर्टेंटली क्या कहते हैं हमें अटैच हो रहे हैं वहां पे। ये पोस्टीरियर बैंड कौन सा मैं इधर आके बताता हूँ। ये जो पोस्टीरियर लेटरल फाइबर्स हैं, दीज आर वेरी इंपॉर्टेंट, क्योंकि ये पार्ट जब हम घुटने को फ्लेक्स करते हैं, नी को बेंड करते हैं, तो ये जो फोल्ड है ये हमें लेटरल स्टेबिलिटी देता है, जो दो काम करता है। एक तो हमारे घुटने को अंदर मोड़ने से रोकता है, जिसे हम इंटरनल रोटेशन बोलते हैं, और दूसरा जब हम घुटने को मोड़ते हैं तो ये एंटीरियर ट्रांसलेशन है। आपने सुना होगा कि एसीएल जिसका फट गया उसका घुटना आगे लचक खाता है, दैट इज नोन एज एंटीरियर ट्रांसलेशन। So this particular ligament, it supports two things. It prevents the anterior translation in ACL deficient knees. Simultaneously, it restricts the internal rotation in flexion. So ये दो चीजें जो होती हैं वो हमारे ग्राफ्ट को लेक्सिटी देती है और वो ग्राफ्ट को स्ट्रेच आउट करके फेल करती है। जैसा मैंने बताया कि हमारा घुटना जब एक्सटेंशन से नी बेंडिंग की तरफ जाता है, ये जो लिवर आर्म है एक्सटेंशन से फ्लेक्शन के बीच में, इस समय हमारा आईटी बेंड होना बहुत जरूरी है, नहीं तो ये लिगामेंट स्ट्रक्चर हमारे लिगामेंट ग्राफ्ट को ब्रेक कर देगा या लूज कर देगा। हम इस स्टडी के अंदर देखते हैं कि जब हमने एंटीरियर पार्ट ऑफ आईटी बेंड को निकाला और हमने घुटने को फ्लेक्स किया, तो ये लिगामेंट कॉम्प्लेक्स काफी ज्यादा डेवलप हो रहा है, और वो जो एरोज आपको दिख रहे हैं वो टाइटेंड एंट्रोलेटरल लिगामेंट कॉम्प्लेक्स है। जब हम और इसके डीप जाते हैं तो हमें एंट्रोलेटरल लिगामेंट कॉम्प्लेक्स दिखता है, जिसकी बात हम बार बार कर रहे हैं। जब हमने ये पता लग गया है कि ये एंट्रोलेटरल लिगामेंट कॉम्प्लेक्स हमारे एसीएल को एक मजबूती प्रदान कर रहा है या उसको एक स्टेबिलिटी प्रदान कर रहा है, तो उसके लिए जरूरी ये है कि हमें ये पता होना चाहिए कि हमें इसको कब तैयार करना है या कब इसको ऑपरेट करना है और कब हमें नहीं करना। हमने एक वर्ड का जिक्र किया था विच इज नोन एज पिवट शिफ्ट टेस्ट। दिस इज द डायग्नोस्टिक टेस्ट जो हमें ये बताता है कि कब हमें इस लेटरल लिगामेंट कॉम्प्लेक्स को एसीएल रिकंस्ट्रक्शन के साथ जोड़ना है या उसको रिपेयर करना है। इस टेस्ट को करने का तरीका ये होता है कि जब हमारे घुटने को हम इंटरनल रोटेट करते हुए सीधा करते हैं, तो ये जो क्लक आपको ऊपर की तरफ दिख रहा है, मैं आपको फिर दिखाता हूं। आप नी को अगर देखेंगे तो जैसे नी बैंड के एक थर्स्ट सा आपको फील हुआ जो कि बाहर की तरफ आपको दिखा नी के, दैट इज नोन एज पिवट शिफ्ट। जब भी आप किसी एसीएल लिगामेंट रिकंस्ट्रक्शन के पेशेंट को देखते हैं तो ये देखिए कि नी बेंडिंग करते हुए उसमें ये पिवट शिफ्ट आ रहा है या नहीं आ रहा। इफ दिस पिवट शिफ्ट इज पॉजिटिव, देन देयर इज अ पॉसिबिलिटी दैट ओवर अ पीरियड ऑफ टाइम हिज लिगामेंट इज गोइंग टू बिकम लैक्स और स्ट्रेच्ड आउट। जब हमने क्लिनिकली ये देख लिया कि हमारा एंट्रोलेटरल लिगामेंट एसीएल के साथ गया हुआ है, तो हम कैसे उसको वेरीफाई करेंगे? द बेसिक इन्वेस्टिगेशन फॉर दिस इज एक्सरे। एक्सरे हमें सिर्फ एक चीज दिखाता है, वो ये है कि जहां एंट्रोलेटरल लिगामेंट टिबिया पे जाके अटैच हो रहा है, वहां किसी प्रकार का कोई छोटा फ्रैक्चर तो नहीं है। इस फ्रैक्चर को हम कहते हैं सिगॉन्स फ्रैक्चर। व्हेनेवर यू गॉट अ सिगॉन्स फ्रैक्चर ऑन एक्सरे या छोटा चिप भी दिख रहा है, दैट मींस योर एंट्रोलेटरल लिगामेंट इज रप्चर्ड एंड यू नीड टू एड्रेस इट। द सेकंड थिंग इज एमआरआई। अगर आप इन एमआरआई इमेजेस के अंदर देखेंगे तो एक नॉर्मल एमआरआई जो होता है उसमें जो एंट्रोलेटरल लिगामेंट है वो इंटैक्ट होता है, लेकिन जहां आपका एंट्रोलेटरल लिगामेंट फटा हुआ है इधर ऊपर या डिस्टली, वहां आपका ये पिवट शिफ्ट पॉजिटिव आएगा। इस प्रोसीजर को जिससे हम हमारे एसीएल रिकंस्ट्रक्शन के साथ लिगामेंट को एक एडिशनल स्ट्रेंथ दे रहे हैं, लिगामेंट को एक एडिशनल फिक्सेशन दे रहे हैं या उसको एक सपोर्ट दे रहे हैं, उसको हम कहते हैं लेटरल एक्स्ट्रा आर्टिकुलर टेनोलिसिस। दिस इज द न्यूएस्ट इन्वेंशन इन द फील्ड ऑफ एसीएल रिकंस्ट्रक्शन सर्जरी, जो हमारे लिगामेंट की लाइफ को बढ़ाता है, हमारे प्लेयर्स को रिटर्न ऑफ स्पोर्ट में जल्दी आने में मदद करता है एवं उसी स्पोर्ट्स को वो लंबे समय तक एंजॉय कर पाते हैं। तो उसकी पर्टिकुलर कुछ इंडिकेशन है जो आपको स्क्रीन पे दिख रही है, जिसमें अगर किसी भी पेशेंट का हम प्राइमरी एसीएल रिकंस्ट्रक्शन पहली बार एसीएल बना रहे हैं, अगर वो कोई पेशेंट 25 साल से कम उम्र का है, तो वहां पॉसिबिलिटी है कि उसमें लिगामेंट जैसे जैसे उसकी एज बढ़ेगी स्ट्रेच होगा, इसलिए वहां हम लेटरल एक्स्ट्रा आर्टिकुलर टेनोलिसिस प्रोसीजर को साथ में करते हैं। सो अगर आपके पास कोई पेशेंट ACL टेयर के साथ आता है जो कि एक एथलीट है या उसकी एज 25 साल से कम है, तो आप अपने ऑर्थोपेडिक सर्जन के साथ डिस्कस कर सकते हैं कि क्या इस पेशेंट को इस पर्टिकुलर प्रोसीजर की जरूरत है या नहीं है। सेकेंडली, जहां भी पेशेंट का पिवट शिफ्ट पॉजिटिव आ रहा है, हमने पिवट शिफ्ट टेस्ट देखा, अगर वो पॉजिटिव है तो डेफिनेटली उसको इस प्रोसीजर की जरूरत पड़ेगी प्राइमरी रिकंस्ट्रक्शन के साथ। दूसरा, अगर कोई पेशेंट आपके पास आता है कि मेरा ACL लिगामेंट रिकंस्ट्रक्शन फेल हो गया है, तो वहां इस पर्टिकुलर प्रोसीजर की उस पेशेंट को जरूरत पड़ेगी। इसलिए आप अपने ऑर्थोपेडिक सर्जन से डिस्कस कर सकते हैं कि मैं इस पेशेंट को आपके पास लिगामेंट के लिए दोबारा भेज रहा हूं, तो क्या आप इसमें कोई साथ में एडिशनल प्रोसीजर करेंगे। क्योंकि आज के वर्ल्ड में जहां मेडिको लीगल इंप्लीकेशन इतनी बढ़ चुकी हैं, ये बहुत जरूरी है कि हमारे पेशेंट की प्रॉपर काउंसलिंग हो कि आपको किस प्रोसीजर की जरूरत है या नहीं है। थर्ड इज मेनिस्कस डेफिशिएंसी। सुबह से हमने 3 या 4 टॉपिक्स ऐसे देखे हैं जहां मेनिस्कस टेयर्स के बारे में बताया गया। जब भी ACL टेयर्स, खासकर क्रॉनिक ACL टेयर्स के साथ मेनिस्कस अगर टेयर है, तो उनमें हमें लेटरल ऑगमेंटेशन की जरूरत पड़ेगी ताकि लॉन्ग रन में हमें इसकी प्रॉब्लम से बचा जाए। ये 2 तरीके से मैंने आपको बताया हो सकता है। एक तो है टीनोडेसिस। टीनोडेसिस का मतलब है एक टेंडन को बोन के साथ जोड़ना है टीनोडेसिस, और एक होता है लिगामेंट रिकंस्ट्रक्शन, मतलब लिगामेंट को नए तरीके से बनाना। सो दैट इज नोन एज एंट्रोलेटरल लिगामेंट रिकंस्ट्रक्शन। सो दोनों के कुछ फायदे हैं और कुछ खराबियां हैं। ये स्क्रीन पे दिखा हुआ है कि कौन सा हमारे लिए फेवरेबल है। जितना भी लिटरेचर आज की तारीख में ऑर्थोपेडिक ACL सर्जरीज के साथ रिलेटेड है, वो ये बताता है कि लेटरल एक्स्ट्रा आर्टिकुलर टीनोडेसिस इज बेटर एज फार एज द रिजल्ट्स एंड आउटकम्स आर इंपॉर्टेंट। इसलिए मेजॉरिटी ऑफ सर्जन्स लेटरल एक्स्ट्रा आर्टिकुलर ट्रीटमेंट को प्रिफर करते हैं। अब वो होता क्या है वो मैं आपको बताता हूं। ये छोटा सा वीडियो आप देखिएगा। इसमें आपका इलियोटिबियल बैंड को हम यूज करेंगे, दिस इलियोटिबियल बैंड के एक स्ट्रिप को हम यूज करेंगे एज अ लेटरल एक्स्ट्रा आर्टिकुलर टीनोडेसिस, जिसको हम बोन के साथ अटैच कर देंगे। देखो इलियोटिबियल बैंड पूरा ऊपर तक अटैच्ड है, लेकिन हम यहाँ से एक छोटी स्लीव लेके उसको बोन के साथ अटैच कर रहे हैं ताकि हमारा जो रोटेशन कंपोनेंट है वो रुक सके और हमारा ACL लिगामेंट रिकंस्ट्रक्शन सक्सेसफुल हो। तो वो कैसे होता है, ये छोटा सा वीडियो देखिएगा। जो गोल आपने मार्क देखा, दैट इज द गर्डिस ट्यूबरकल, और एक करीबन 7 से 8 सेंटीमीटर का इंसिजन हम देते हैं, जिसमें हम इलियोटिबियल बैंड को अलग से सेपरेट करके उसको डिटैच कर देते हैं प्रॉक्सिमली, मतलब ऊपर से, और फिर फीमर के डिस्टल पार्ट में, जिस इज नोन एज द सुप्राकॉन्डलर रिज, वहां उसके साथ उसको अटैच कर देते हैं ताकि जो हमारा लिगामेंट के रिकंस्ट्रक्शन हुआ ACL का, उसमें रोटेटरी इंस्टेबिलिटी नहीं आ सके। ये एक स्ट्रिप हमने इसमें से डिटैच कर ली और इस स्ट्रिप को हम बोन के साथ अटैच कर देंगे। अब हम आपको 2 केसेस ऐसे दिखाते हैं जहां इस पर्टिकुलर सर्जरी जिसके बारे में हम बात कर रहे हैं उसकी कहां उनको जरूरत पड़ी है। Now the question goes back to the leading role of orthopedic surgeons in helping me to how to approach this particular case. He is a 24-year-old male, 24 साल का लड़का है, जिसका ACL रिकंस्ट्रक्शन कुछ 6 हफ्ते पहले कहीं और किसी सेंटर पे हुआ था। पेशेंट हमारे पास 6 हफ्ते के बाद आया कि मेरे पैर में स्वेलिंग हो रही है, पेन हो रहा है, एंड ही हैज गॉट अ लिटिल बिट ऑफ डिस्चार्ज कमिंग फ्रॉम द डिस्टल साइड जहां से ACL का हम ग्राफ्ट इंसर्ट करते हैं। What are the important part is कि whenever there is an infection, it is definitely an emergency, हम सब जानते हैं। हम इन्फेक्शन के साथ आगे नहीं बढ़ सकते क्योंकि इन्फेक्शन हमारे जॉइंट को डैमेज करेगा। हम कुछ इन्वेस्टिगेशन करके ये देखते हैं कि उसको इन्फेक्शन है या नहीं, और MRI से ये कंफर्म करते हैं कि अंदर ग्राफ्ट का स्टेटस क्या है। जो हमने करा तो हमें पता लगा कि उसमें इन्फेक्शन 100% है। My leading question to the orthopedic surgeons here is how you are going to approach, whether you are going for a single stage revision surgery or a 2-stage revision, मतलब एक बार में ही पूरा करेंगे या 2 पार्ट में आप सर्जरी को डिवाइड करेंगे। माइक प्लीज।
So my protocol for infections, which I have published in 2 papers, I will debride as soon as possible, and in the first debridement I don't take out the graft.
Okay.
Around 90% of my patients the graft survives.
Okay.
And I give antibiotics usually intravenous for 2 to 6 weeks, monitoring the CRP basically. intravenous 2 to 6 weeks, and then oral maximum 6 weeks. The 10% in whom the infection doesn't go by retaining the graft, I go in again and I remove the graft and remove the implants. After that, I wait for 3 to 4 months. Around 50 to 60% of them, they become stable because of fibrosis. I don't do ACL reconstruction surgery in them. The remaining 40 to 50% who are getting instability, then I do a second stage ACL reconstruction.
I would agree with sir that if a patient presents to you at 2 weeks, I think it's pretty acute. We can try and salvage, and we do a thorough arthroscopic lavage and debridement. And if at all the debridement doesn't work, then a 2-stage revision can be planned. Whenever there is an infection, doing it in a one stage, I don't think it's a good idea.
So we have planned a 2-stage revision in this. And in first stage, we have removed the previous implant. I'm going to show you the videos that what we obtained there. So this was the clinical picture which patient presented to us. We can see ample amount of pus from the different distal aspect of the wound here. And this was the MRI scan which shows that patient is a case of graft infection. The hematological parameters are in favor of infection. So this was the picture, sir. Still you will go for debridement? Just nothing to do with the graft?
No, that I will decide when I go in. If my graft is, like MRI is showing graft is good, you also come to know the quality of graft when you debride, right? If the graft is solid, it's not shredded, the infection has not eaten it, I don't want to remove the graft. And I am successful in many cases, around 90% of the cases.
Sir. So what we find out that there was a very thinned out graft here, so you can see over that picture, and it was basically the fiber tape which the surgeon has used to fix the graft, to augment his graft, and the graft was very thinned out. So
I have kept a container in my OPD, Avkash might have seen, where I have kept all the removed tapes and braces in that container. And YouTube पढ़ के आता है कि सर मेरे इंटरनल ब्रेस डाल दो. YouTube पे ना कई सर्जन्स ने ऐसी वो डाली हुई हैं वीडियोस कि इंटरनल ब्रेस से करना चाहिए.
So the message
तो मैं उनको वो कंटेनर दिखाता हूँ कि भाई ये मैंने निकाली हुई है, फिर भी आप कहोगे मैं डाल दूंगा.
So मैंने फ्रेम करा रखी. So the message is here कि सर ये कहना चाह रहे हैं कि ligament reconstruction means it should be a pure ligament reconstruction जहाँ आपका graft soft tissue होना चाहिए. कोई भी artificial material as a graft जैसे fiber tapes वगैरह नहीं use करना चाहिए. So this is a good take home message. But in this particular case, as we were not able to find any graft, we have removed the entire screws. Whatever remnant was there, so we have removed the entire thing here. And we did a thorough debridement and we impregnated the stimulant beads, antibiotic coated, and we kept the patient for a period of 6 weeks. For the first 3 weeks, we have given the intravenous antibiotics as per culture sensitivity. And for the next 3 weeks, we have given him oral antibiotics for 3 weeks. And we were monitoring the patient with inflammatory markers. And once it has subsided, we have stopped all the antibiotics. The patient at the end of 6 weeks was, so this was all his infection was settled. The wounds were settled. He was having a good range of movement. He did physiotherapy. But luckily or unluckily what I'll tell is that this patient just lost to follow-up. Because he's an engineering student from Pune, तो वो कहता है कि मैं तो ठीक हो गया, मेरा infection control हो गया, I'm going back for my studies.
So that's why I said they become stable after infection.
But he was not stable, sir. His range of motion. So I'm going to show you. He came back to me at the end of 9 months कि सर मेरे exams हो गए, मेरा campus selection हो गया, अब जो आपको करना है कर लो. So what we planned was a surgery. But before that, we went for a repeat MRI here, and this video is not clear. But now he has developed what is known as a lateral meniscus horizontal tear due to instability. Because he was walking on that particular ligament deficiency, he has torn his lateral ligament, lateral meniscus. So we have taken him for surgery. We have explained to him that we will be doing your ACL revision. We have used a peroneus graft for this. We did a lateral meniscus all inside repair, and we did a simultaneously LAT modified Levias technique augmentation of the lateral ligament जो हम बार बार बात कर रहे हैं. And this was his pre-op video. Sorry. So this was his pre-op video. You can able to see that ligament was lax. His pivot was positive. That means he's having a significant ACL insufficiency along with anterolateral ligament complex injury. So what we did was, we did an arthroscopic ACL reconstruction. I don't have the video right now, but this was the picture. We did a lateral extraarticular tenodesis using an IT band strip, and we fixed it with the help of what is known as Richard's staple. So this was his post-operative video at the end of 2 months. The knee was quite stable. All the wounds have healed well. And he is enjoying the surgery. So now the question here arises, Doctor, is whether you are going to change your rehabilitation protocol as far as your revision reconstruction is there, or with a modified Lemaze?
For me, the rehab protocol will remain the same. But I would like to put forward a few points, probably which just to clear the doubt, and probably we should not be going with the wrong message. That's what I feel. First thing is, in case we come across infection like in your case, so it was 6 weeks plus 2 weeks down the line. So it was already 2 months, in fact, 8 weeks down the line. So there is no role of conservative, especially when you are not the primary surgeon. So if I am the secondary surgeon, definitely I'm not going to think that with suppressive antibiotic this is going to heal. Point number one. Point number two, I would be taking out everything like you did. And ProCal, instead of ProCal, probably that is something which ICU guys are more fond of. I would be eager to have CRP because that's going to guide me. These are all technical points that probably for sake of discussion I'm saying. Then other point I wanted to note was, like, we are strongly against, that's a personal choice, of using an augment. But the case which I had shown, that national kabaddi player, there I had used the augment. So it's not that every augment will get infected. Yes, there are reservations, personal reservations, but I have seen high volume centers, especially in the south, where they routinely use augments and they do excellently well, like the case which I showed. Second thing is, the point against the use of augment is, since you are using a synthetic material along with the natural, so the elasticity will differ. Exactly. So whenever it's a synchronized movement, then probably this will be lagging, or this will be firing too ahead of the natural ligament. I'm talking about the augment. So that is the main drawback, or you can say the point.
So
yes,
that's why, sir, whenever you are using an augment or an internal brace to augment your ACL reconstruction, you always do a differential tensioning while you are
right.
holding.
So that's what I'm saying.
Why,
so
yeah.
it can't be like all or none phenomenon. Probably literature is scarce. And coming on to like rehab, as you said, and one more point I would like to add, like you said, LAT, probably recurvatum would be another add-on indication for me.
It was there in the indications. If you
Yes,
see below
whenever we are revising, there's no point. Definitely LST has to be there. But as far as rehab is concerned, it will be exactly what we will do for primary ACL.
So your antibiotic protocol in case of revision ACL?
Revision ACL,
Yeah.
same.
How many days you will continue with antibiotics
You are
after
talking
second
about
surgery?
non-infected revision. No?
I am asking about a revision ACL reconstruction after the definitive second surgery. How long you are going to give antibiotics?
The same. No difference.
And the
because
reality-
I have excluded infection.
Okay.
It's like doing a TKR after,
Like a primary surgery. Okay. Okay. Thank you. So switching on to a second case, this will be the last case for me. So this is a case of a 36-year-old male. He's a physical teacher by profession. He was operated almost 6 years back elsewhere. They did an arthroscopic ACL reconstruction, but I don't know how they have fixed it, because we were able to see two endo buttons here. One at the level of supracondylar ridge and other at the level of the joint line. So where that second has come endo button, I am not aware of this, and I don't know how it has come. So this was a thing, and if you can see that the tunnel what they made, it was quite anterior, so that is blown out anteriorly in the patellofemoral groove. We can see there at the level of trochlea, and that ligament that is lying there. So this was the X-ray. Clinically, he was having a significant medial joint line tenderness, and he was having a medial meniscus tear also. It was a bucket handle tear. The drawer was positive, Lechman was positive, and he was having a quite grade 3 pivot shift with an expensile pivot. Hematological parameters were all within normal limits. All the infection has been ruled out. There was no infection. There was no signs of infection even clinically. MRI was suggestive for degenerated ACL with bucket handle medial meniscus, as I told. So the next question to you, sir, is that what will be the next investigation you will order in such a case? That has been ruled out.
Or the limb alignment.
Okay. So what we did was a scanogram. So a scanogram is basically meant to understand the deformity that has developed over a period of time in case of chronic ligament insufficiency. Because our normal knee mechanical axis gets deviated या अपनी जगह से change होती है जैसे जैसे हमारा ligament reconstruction abnormal होता चला जाता है, deficient होता जाता है, and it fails. So thereby what we are looking for is early medial compartment osteoarthritis, because अगर साथ में osteoarthritis है, then our treatment plan changes. So this was the scanogram, and scanogram was totally normal, sir, here, because the weight bearing axis was passing to the center of joint, and even we have checked it over the software. So the MPTA was normal, the LDFA was normal, and there was nothing like convergence. So what we planned here was an straightforward single stage ACL reconstruction with removal of all previous implant and a medial meniscus repair. So this was a pre-op video for this particular case. The ligament is insufficient here, ACL, drawer is positive. Lechman is positive here. So MRI was of medial meniscus tear and degenerated ACL remnant, that's all. I don't have picture right now. So this was the arthroscopic image. The video is not running. It was a classical bucket handle tear what he was having that was entrapped between the articular surfaces. So we reduced this bucket handle tear. We went for an ACL reconstruction using a peroneus graft here, peroneus longus, and we did a modified LET using modified Lemaze technique. So this was the ACL. We have reconstructed here in this particular case. The ACL was robust enough using a peroneus longus graft. The medial meniscus was repaired. So we did all three procedures here. The central part was repaired using an all inside. The peripheral posterior third to middle third junction by an inside out, and the anterior middle third through an outside in technique. So it was quite a stable repair, as we are able to see. It is not coming back. So this was the final picture. We did an ACL reconstruction. We fixed our LET here with modified Lemaze technique using a bio screw. And this is his post-op video at the end of 3 months. So squats is good, quad strength is good. He is doing a better bit of lunges. Even a single op test was normal. So there are multiple publications in the literature which says that an associated lateral augmentation with a revision ACL or any primary ACL as per the indications we have seen is better for the longevity of the graft as well as the survival rate of the graft. The return to sports is earlier. So the take-home message from my slides are that it is an adjuvant procedure to all ACL reconstruction depending on the indications concerned. The function is to just reinforce the anterolateral structure of the knee, thereby providing an anterolateral stability. by reducing the internal rotation. It has definitely got evidence that it reduces the graft failure rates and improves stability. Surgical considerations are very important because your graft tensioning should be very much adequate at the 30 degrees of knee flexion with normal neutral rotation. And LAT, at the last I would say, LAT is not a replacement for ACL reconstruction. It is always an adjuvant to an ACL reconstruction. So thank you guys for bearing with me to stay here in the live. And thanks to Paras community as well as Paras Ranchi for giving me this opportunity to stand in front of you. Thank you.
Thank you so much, sir, for the interactive session. I would now request Dr. Kaush, sir. So please memento. I would request Dr. Kaushik Roy to please come and present the memento as a token of gratitude to our speaker. A huge round of applause for Dr. Khanna.
Thank you, everyone. We have got a panel discussion. If you have got any queries, any questions related to this, I will be more than happy to address.
Thank you. So moving on with our discussion, let's invite our next speaker. Our next speaker is a key member.
देखो स्विच करो ठीक है सर
Our next speaker is a key member of the Paras Ranchi team specializing in the diagnosis and management of musculoskeletal conditions. He brings a wealth of hands-on experience and is a firm believer in the power of comprehensive rehabilitation. He has been at the forefront of restoring mobility for his patients. We look forward to his insights today. So ladies and gentlemen, with a huge round of applause, please welcome Dr. Avkash Kumar, Consultant Orthopedics, Paras Health Ranchi.
Thank you for a wonderful introduction. I think this is the last presentation of this session, but I won't be taking your longer time, and I would be focusing on foot and ankle sports injuries, जो अभी तक present नहीं किया गया था. और मोस्टली हम लोगों के दिमाग में जब हम बात करते हैं कि हाँ उसको एंकल में इंजरी हुई है, स्पोर्ट्स इंजरी है, खेलते समय चोट लगी है, तो सबका ध्यान जाता है कि इसको एंकल स्प्रेन होगा. एंकल स्प्रेन ही तो है उसको, ठीक है. उसका मैनेजमेंट सबको पता है, गर्म पट्टी लगा दी, क्रेप बैंडेज बांधा, कुछ समय के लिए पेन किलर्स दिया, एंड ही वुड बी अप एंड अबाउट. इवन बिफोर दैट मैं ये भी बोलना चाहूँगी कि व्हाट इज स्पोर्ट्स इंजरी. स्पोर्ट्स इंजरी आर दोज इंजरीज जो स्पोर्ट्स और एक्सरसाइजेस खेलते समय ही केवल नहीं लगती हैं, लेकिन साथ ही साथ वो केवल एथलीट्स के ऊपर ही नहीं रहती हैं. वो कॉमन पब्लिक्स के जो भी पेशेंट्स हमारे एक्टिव इंडिविजुअल्स हैं उनके ऊपर भी ये अप्लाई होता है. फिजिकल एक्टिविटी ऑल्दो इट बूस्ट्स हेल्थ बट ऑल्सो कॉजेज इंजरीज. लार्जली स्पोर्ट्स इंजरी को हम लोग दो कैटेगरीज में डिवाइड कर सकते हैं, एक्यूट इंजरीज एंड क्रॉनिक. एक्यूट बीइंग जो आपको दौड़ते समय में या खेलते समय में चोट लग जाती है, जैसे कि ट्विस्टिंग इंजरीज है, स्प्रेन एंड डिस्लोकेशंस. जो क्रॉनिक इंजरीज होती हैं वो मोस्टली ओवर यूज इंजरीज होती हैं जो ओवर द टाइम डेवलप कर रही होती हैं, जैसे कि स्ट्रेस फ्रैक्चर या फिर बर्साइटिस. लोकेशन के आधार पर अगर हम देखें तो इट कैन अफेक्ट बोन, आर्टिकुलर कार्टिलेज, जॉइंट, लिगामेंट, मसल, एवरी पार्ट ऑफ द लोअर लिम्ब. एंड बोन्स की इंजरीज के बारे में बहुत ज़्यादा फोकस नहीं करना चाहूँगा मैं, बिकॉज दैट इज़ अ सेपरेट टॉपिक. एंकल एंड फुट में जो बोन इंजरीज होती है दैट कैन बी फ्रैक्चर्स, एंड फुट फ्रैक्चर्स आर क्वाइट कॉमन इन स्पोर्ट्स इंजरीज. ठीक है. आउट ऑफ दीज फुट फ्रैक्चर्स मैं एवल्जन फ्रैक्चर्स के ऊपर मैं थोड़ा ध्यान आकर्षित करना चाहूँगा. एवल्जन फ्रैक्चर्स जो होते हैं उसमें बोन का एक पीस लिगामेंट लेके उखड़ जाता है, जैसा इस वाले में आप देख पा रहे हैं. कैल्केनियम का ये एवल्जन फ्रैक्चर है, तो दिस नीड्स टू बी फिक्स्ड. ऑल्दो ऑल द एवल्जन फ्रैक्चर्स डज नॉट रिक्वायर सर्जरीज. लाइक इन दिस केस देयर इज अ एवल्जन फ्रैक्चर near the lateral malleolus which is undisplaced. So undisplaced fractures generally heal with bracing and casting. So mostly जो evergent fractures हैं ankle के around में, they can be mistaken for ankle sprains. और अगर ankle sprain के जैसा ही हम उसको treat करते रहे, that in that case they can cause a longer disability. ठीक है? Coming on to the another kind of sport injury, which is often overlooked, is stress fractures, most commonly seen in longer running activities. जैसे सॉकर है, बास्केटबॉल है, इन सब के प्लेयर्स में होता है ये. बेसिकली बोन होती है जो हमारी, वो टाइनी क्रैक्स जो है वो डेवलप करना शुरू कर जाती हैं ओवर ए लॉन्गर पीरियड ऑफ टाइम. इफ यू लुक एट द फर्स्ट एक्सरे, on the first x-ray you cannot see any fracture. When the patient visits to us with a gradual onset of the pain which is increased over the time and weight bearing के साथ साथ में पेन बढ़ता जा रहा है, बट एक्सरे में हमको कुछ दिखता नहीं है. In that case we also can get MRI, which is the earliest it picks up the stress fracture. But अगर 3-4 हफ्तों के बाद में अगर एक्सरे हम रिपीट करते हैं, in that case you can see on the second metatarsal there is a periosteal reaction and new bone formation is also visible. And another cause of the ankle and foot pain is shin splint. ये most commonly athletes में होता है जो फुटबॉल, बास्केटबॉल या डांसेस कर रहे होते हैं. इनमें मोस्टली जो पेरियोस्टियम है, which serves as the anchoring point of the several muscles, it get inflamed and causes the pain on the anterior aspect of the shin. And I won't be talking much about the physical therapy management. You guys are expert in that. So the rehab occurs in the 3 phases: phase 1, phase 2, and phase 3, which is inflammatory, proliferation, and remodeling phase. So coming on to the more serious kind of sports injury, mostly seen in the ankle joint, it is articular cartilage injury. There is a osteochondral lesion. Osteochondral lesion क्या होता है? Bone के साथ साथ में हमारी articular cartilage उखड़ जाती है. Mostly seen in the talus bone. And the patient presents with the ankle pain with morning stiffness, which gets, and sometimes the patient complains of the catching or audible click sound coming onto from his ankle joint. So for diagnosis, X-ray is most of the cases insufficient होता है. We have to get the MRI done. MRI में we can see the articular cartilage elevated from the bone. And most of the cases, if it is more than 5 to 6 millimeters, then a surgical treatment is warranted. जैसे इस केस में talus के ऊपर एक osteochondral defect है, and उसमें हम लोगों ने या तो माइक्रो फ्रैक्चर के थ्रू उसको ट्रीट कर सकते हैं. And the another modality is through the Mins cartilage, which is placed inside the articular cartilage. And coming on to the ankle sprains, ankle sprain the ankle sprain occurs when the one or more of the ligaments around the ankle gets torn. It is the most frequent cause of the ankle pain in athletes, and most of the cases lateral ligament complex gets torn in ankle sprain. Okay. You all are aware of the anatomy of the ankle joint and the ligaments pertaining to it. This is the medial ankle ligament and this is the lateral ankle ligament. The ATFL.
I would request the participants to please come and be seated because there's a lot of noise at the back.
ठीक है. I would be finishing in maybe in around 5 minutes or so. So lateral ankle is the most common area of the ankle sprain. 85% of the ankle sprain occurs in this area. Out of that, ATFL, anterior talofibular ligament, is the most common torn ligament. We also have the ankle sprain can be high ankle sprain or it can be low ankle sprain. The low ankle sprain affects ATFL and PTFL and deltoid ligament area, and the high ankle sprain affects the syndesmotic area, which lies higher up in the ankle joint. Risk factor for athletes, it is the there is always a history of some ankle pain prior to this thing occurring the ankle sprain. So in athletes where there is always occurrence of ankle pain, so they lose their proprioception when there is repeated trauma or overuse of the ankle joint. So this patient always present with the pain in the ankle after an injury or a fall, and there would be swelling, ecchymosis pertaining to the ankle joint. And many of the conditions can mimic ankle injuries like ankle impingement, tarsal tunnel syndrome, sinus tarsi, or cartilage or osteochondral lesions like I showed earlier. Peroneal tendopathy, which is also an uncommon cause of the ankle pain, and posterior tibial dysfunction also. So there are some tests to ascertain the ankle pain or ankle sprain. These are maneuvers. You can do inversion or eversion testing. So you can come to the conclusion of whether the ankle ligaments are torn or not. And also you can do the anterior drawer test, like what you see in the knee joint. And there is also a Taylor tilt. These are the radiographic stress tests. So the mild ankle sprain generally recovers in 7 to 10 days after bracing, casting or taping. And for severe ankle sprain, we have to do the surgery in more than 50% of the cases, and mostly in the cases of athletes. So in surgery, what we do, we either do ligament repair or a reconstruction. If the case is acute, we can do the modified Brostrom procedure, in which the torn portion of the ligaments are stitched together. In chronic cases, we have to take the help of the augment in the form of fiber tape or fiber sutures. Like in this case, we are doing this. And like a tendon, the muscle also get injured. It can also get torn. So the muscle injury is called a strain, and mostly it occurs around the musculotendinous junction. And these are the repetitive or the overuse injuries. For grade 1 and grade 2 injuries, we implement RICE protocol, rest, ice, compression and elevation. You all are aware of this. And there is another entity called muscle cramps. It occurs where there is excessive physical exertion, or in athletes where there is who are low in potassium, like hypokalemia is the cause. Dehydration can be a cause of this. Ill-fitting shoes are also the cause of this. For treatment, rest and massage of the affected muscle is done. And coming on to the tendon injuries, we also can get tendon tear. Tendon tear are although very rare in the ankle areas, but like in this case, we can see there is a peroneal tendon injury, and the tear is longitudinal in pattern, and we have to do the surgery to take out the problem. And also, you are very well aware about the tendo-Achilles rupture, which occurs in athletes, and which, if they are overused or very not well prepared, like if they are not doing pre-workouts and stretching, then the tendo-Achilles can get torn, and we have to do the surgery in these cases. Surgery can be done through an open technique or minimally invasive technique. There is also a term called paratendonitis, which is the inflammation of the outer layer of the paratenon, which occurs most commonly in the Achilles tendon. And there is also tenosynovitis. The tenosynovium is the outer layer or covering of the tendon, which is synovial lining of the tendon. And there is tendinosis. Tendinosis is the degenerative, it is a degenerative condition without the inflammation. So it occurs mostly in the athletes where there is repetitive directional changes or jumping is involved, in that they get mostly tendinosis. And there is also bursitis, which can occur in athletes. It is the inflammation of the bursa, which is a small synovial lining filled with synovial fluid. and it mostly caused by the persistent friction, repetitive impact, or sustained pressure. Management of the non-infectious bursitis is the rest, ice packs or NSAIDs. In some of the cases, we have to aspirate the bursa, and in the more chronic cases, like if they are associated with haggling deformity, then in that case, we also have to excise the tendoachilles portion of the tendon, and bone excision is also done. And there is very extremely rare cause of the leg and ankle pain, which is called chronic exertional compartment syndrome, which occurs in elite athletes, which remains mostly undiagnosed till very last cases. There is an increased intercompartmental pressure in this, and the patient cannot walk over this. Symptoms are mostly persistent and after the activity, and they are limited to that particular compartment. The anterior and the lateral compartment of the leg are most commonly involved in this, and fasciotomy is the treatment of jaws in these cases. Okay, so I would like to thank you all. Thank you, Paras, for giving us this opportunity. Thank you.
Thank you so much, sir. Thank you so much, sir, for the amazing presentation. I would request Dr. D.P. Sharma, sir, to please come and as a token of gratitude, present the momentum to our speaker.
Thank you. If you have any questions from the audience for any speakers, means all our speakers are here. So is there any question? If you have question. I will request the person who has question, please come on the dais. Please come.
Very good afternoon, sir.
आपका क्वेश्चन किसके लिए है?
Dr. Rahul Khanna, sir. Very good afternoon, sir. I just wanted to ask you, like you told, if osteoarthritis is there, the treatment plan changes. Sir, what we can do in those cases? How do you rule out exactly? Like, how do you manage?
Whenever you are suspecting a long-standing ligament deficiency, your mechanical alignment is going to get disturbed and you will be having more of a varus deformity, the most common one. Okay. So the best part will be to go for what is known as a weight-bearing scanogram. So weight-bearing scanogram gives us a pictorial depiction of our mechanical axis starting from hip to your ankle joint. Okay. So on the basis of that, you can calculate that if your two identities you have to think of, one is lateral distal femoral angle and other is medial proximal tibial angle, that you have to calculate. So you've got multiple methods to calculate. I usually use a software for that. We've got a software now available. So if that is variable, means if it is not within the normal limits of 85 to 90 degrees, then you have to think about a varus or a valgus deformity.
Right.
Now you have to address that varus and valgus deformity in a biplanar fashion, in which you have to address the varus part and you have to also calculate the slope of the tibia. If your slope is variable, then you have to address a slope also. You can go for a simultaneously anterior closing wedge osteotomy with a medial open wedge. Okay, right. You can do that. So once you have corrected the alignment, you can go for an ACL reconstruction. So you will be taking care of both your ligament insufficiency as well as your mechanical alignment.
Sir, if the osteoarthritis is severe, so like what would you will be going for arthroplasty?
No, totally depends on the age of the patient.
Right.
Okay. If the age of the patient is above say 50-55 years, if it is a unicompartmental disease with a complete meniscus blown off, with a medial compartment arthritis, but an intact ACL, I will go for what is known as a unicondylar knee replacement.
Unicondylar. Sir, if the patient happens to be a lady and she is having osteoporosis, how do we do in that?
lady.
Suppose if the patient is a lady and she is also suffering from osteoporosis, so how do we manage
Osteoporosis with what?
Like a bones she is having, like on bones osteoporosis she is having. Osteoporosis is having of bones. She has also a condition of osteoporosis. So will the
Osteoporosis is a different identity, sir. Osteoarthritis is a different identity.
Okay, like osteoarthritis is not there, but the diagnosis has been the osteoporosis.
So you have to take care of osteoporosis section. Okay.
First.
So osteoporosis, you have got multiple treatment options available, starting from oral medications to what is known as recombinant parathyroid hormone, or even you can go for a recombinant analogs are available. So depending on the DEXA scan of the patient, you can advise a medical line of management for that.
Right.
Besides, it has also been seen that when you have got a osteoporosis and if a patient is having a fracture non-union, a local pulsatile ultrasound over that particular area can help in regeneration of bone and increase osteoblastic proliferation.
Right.
So you can go for a local ultrasound on that.
Thank you, Dr. Rahul. I think next question. Okay, you can sit. Okay. Huh? No, you just give, because you are the only person who is questioning.
Good evening, sir. My name is Hassan from Usha Martin University. My question is to Nirmal, sir. If lateral meniscus repair surgery, if meniscus surgery, meniscus repair surgery has to be done along with ACL reconstruction, then what will be the criteria of weight-bearing progression of that patient?
For any meniscal repair, it has to be protected for 6 weeks. That's the general dictum which we all follow, and probably most of us will agree. Although there are literatures which suggest like weight bearing as tolerated, but on safer side and with going by what majority of the literature and what we practice, we have to protect it for 6 weeks. So whether it's lateral meniscus or medial meniscus, it has to be, if there is a meniscal repair, it has to be protected for 6 weeks.
Sir,
so that will be toe touch. So it's not that we don't allow the patient, no, not partial weight, that's toe touch. So partial weight bearing is something like, I mean, although we all will be knowing, but if I can kind of reiterate what exactly we mean by partial weight, so that's like 1/3 of your weight. So if I'm a 60-year-old guy, so I need to put around 20 kgs of weight. That's the maximum which I'll be allowed. That's called partial weight bearing. And how do you do that? We make the patient press with that limb, the weight weighing machine, and that gives him an idea like the moment he touches that 20 kg mark with a 60 kg person, so he knows that this is the weight which I have to give. So that's the maximum weight which will be allowed. So that's partial weight bearing, but protection is by way of toe touch for 6 weeks. Yeah.
Sir, both types of injury, for both type of surgeries, one surgery is arthroscopic partial meniscectomy, or for another is meniscal repair. For both types of surgeries.
See, if it's partial meniscectomy, that's the only procedure, then we don't restrict the weight bearing. We just allow it. But as I said, that will be like once in a blue moon. Now, considering that we are so aggressive with maintaining as much of meniscus as possible. So even if it's a complex tear, then partial meniscectomy in the form of just letting the stable fragment stay there, and then we'll repair it. So partial meniscectomy per se will be very rare to deal with, but if at all we are doing just partial meniscectomy, then we can allow the patient full weight bearing the very next day.
Thank you, Dr. Nirmal. Basically, we are running out of time. I request everyone to come on stage. We need to take a group photo with our dignitaries. So, please. सब पीछे भी जो बैठे हैं सब आ जाइए.
फोन बज रहा है.
आइए मैं
Akash sir.